good morning to one and all present here. We extend a warm welcome and invite all the faculties and delegates to our third Preeti Anaesthesia update on chest wall, abdominal wall and Truncal ultrasound blocks. Here we have with us all the eminent speakers and guests from far and wide to share their vast knowledge and experience with us. As Thiruvalluvar said, Tottanai Thorum Manarkeni, Mandarku Katranai Thorum Arivu, which means as deeper you dig the well, the more water you get. Likewise, as deeper we learn, the more knowledge we gain. So with this, I call upon our organizing secretary, Dr. Balaji sir, to start the proceedings.
So I welcome all the faculty, senior faculties and all the delegates from all around Tamil Nadu. So this is the third edition of Preeti Anaesthesia update. We have conducted upper limb, lower limb and now we are moving on to the truncal blocks. So this is our hospital is a tertiary orthopedic center comprising about 250 beds. And we are accredited by NBE MS board for DNB anesthesia, OG and orthopedics. So few instructions for the delegates. So this time we have planned this workstations just a floor above in our Preeti Nursing Institute. There are a total of 6 stations and all of you will be divided into equal groups of 20. So the group name will be written on your ID tag. So according to the group, you just be there in your stations at 11:30. So station 1, group A should go to station 1 like that. Group B, station 2, C will go to station 3. From there, after every 45 minutes, we have to rotate among the groups. So up to 1:30, we will have 2 groups. Then we will break for lunch. Then from 2 o'clock, we will again start the evening sessions. So last one session will be 45 minutes will be given where you can go into which station you like and interact with the faculties, and if you want you can refresh the scanning session also. So with that I would like to invite my first speaker Dr. Rajaram sir. So he joined as an assistant professor when I was in final year PG in Stanley Medical College. So we used to call him as a library because when you go with any questions he will answer. Some absurd questions also. If you go with IV set, he will start from the manufacturing of the IV set from the first day itself. So he is a very avid reader. So we have chosen this topic specially for him. So I think he will. Thank you, sir. Please, sir.
Welcome you all for the Preeti Anaesthesia update, and thanks Balaji for the kind introduction. So straight away I am coming to the topic. The ideal site of local anesthetic deposition in ultrasound guided regional anesthesia. Why this topic is so important? Because everybody here is aspiring for an ideal anesthetist. There is 100% success, 0% failure and 0 complications. But welcome to the real world. Unfortunately, we face failures and complications. But it is not impossible to circumvent. How to do this? Just listen to the wise words of Dr. Alan Winnie. He says, when there are problems with any regional technique, look for the cause at the proximal end of the needle. So what do you need for a successful regional anesthesia? We need an ideal drug to be deposited at an ideal site at an ideal dose. So failure to achieve this goal might land up in failure or land up in complications. Such know the future just shows the way for the future. So regional anesthesia started with peripheral nerve block and evolved into interfacial plane blocks. The peripheral nerve block started with the landmark guided technique where the nerve is located with paresthesia. This is the era of no paresthesia and no anesthesia. Then the nerve is located with nerve stimulator guided techniques, which is something objective. There is no pitch and no anesthesia. Finally, we landed up in ultrasound guided peripheral nerve blocks. While the interfacial plane block started with landmark guided facial clicks started by Winnie with 3-on-1 block, and it's evolved through ultrasound guided facial plane blocks. But does ultrasound have solved every problems? So why ultrasound? Because we have three things. We can visualize the anatomical structure of interest and the vital structures around the structure of interest and track the needle tip, and we can deposit the drug near the neural structures, and we can always assess the spread. What we need to have to achieve these goals, we need to have a sound sono-anatomical knowledge and a needle probe manipulation. The sono-anatomical knowledge gives you how to select a block for the particular planned surgical procedures, and the needle probe manipulation requires imagination and experience. So ultrasound definitely gave vision to the blind anesthetist. But whether it has solved the problem, because there is no difficulty in visualizing the nerves. But what the problem here is, we are too close to the nerve. There is unintentional intraneural injection is around 20 to 25%. So the breaching the perineurium causes intrafascicular damage. I can see there is a breach in the fascicles in the interscreen loop. This is the nerve. You can see this is the needle is going through and through the nerve. So the breaching the perineurium causes intrafascicular damage. Even entry into the extrafascicular subepineurium is not without risk. So electrophysiological defects as well as the histopathological defects exist for months after the intraneural injection. So I think it is time to redefine the peripheral nerve block, which has to be defined like deposition of local anesthetics in and around the nerve structures. That is the tissue space or the fascia that contains the nerve rather than into the nerve. That should be the definition of nerve blocks. For that we need to have the anatomy. Structure of the nerve is more important, because knowing the anatomy is half the battle. This is a nerve fibers surrounded by the myelin sheath. The single nerve fiber is covered by the endoneurium. These nerve fibers are grouped together called the fascicles, which is protected by the thick perineurium. The fascicles are stacked together and it is covered by epineurium, and you can see these are the connective tissues, these are the neural elements. So the nerves are made up of parenchyma of nerve fiber and the supporting connective tissue. The perineurium is the principal barrier in preventing the nerve damage, because it helps to maintain the blood nerve barrier. So needle entry even within the perineurium, epineurium is not without risk, because you can see the blood vessels going through the connective tissue. So when you enter the needle through this, there is always a chance of injuring the blood vessel, that is vasa nervosa. So injuring the vasa nervosa is dangerous because these vessels do not have any autoregulation. So before you block it, just note few things, because peripheral nerve injury is much more common in interscalene block and supraclavicular blocks, because nerve injuries in the interscalene block is 3 per 100 patients, which is quite higher. and the ratio of non-neural to neural elements increases from the proximal to the distal end of the plexus. That's why the nerves are hypoechoic in the proximal area and hyperechoic in the distal. The same reason is true, that's why the onset of block is much more faster in the proximal than in the distal nerve groups. You can see the nerve entering through the perineurium, and you can also see the swelling of the nerve. So at last, that is an answer for the topic given to me. That is, the paraneurium is the ideal site for injection of the local anesthetic, where you can see there is epimysium, that the paramysial, that is the paraneural sheath that is surrounding the nerves. But just place the needle in a tangential manner around the paraneural sheath, that when you have it, you can always have the rotating feeling of the nerve. Just inject a small volume, you can have a whole donut effect of the around the nerves. So subparaneural spread is the ultrasound endpoint. Place the needle in the paraneural sheath, but the problem here is the ultrasound does not clearly delineate the paraneural sheath. This is an high-end ultrasound, where you can see the epimysium here. There is a paraneural sheath. There is a small gap, that is the subparaneural sheath. This is where you have to place the nerve. This is where you have to place the local anesthetic. Should be deposited in and around the paraneural sheath, not outside, which can cause failure, not into the nerve, which can cause nerve injury. So interscalene block has more chance of nerve injury. So we have deposit the local anesthetic in and around the, that is periplexus, where you can see the nerve. This is the fascia that contains, the prevertebral fascia that contains the nerve, where you can see the needle entering through the nerve. That is, it is around the periplexus. Just by giving small injection, the nerve is pushed away from it. Now the needle is placed in between C5 and C6 just for the demonstration purpose. That is, this is called intraplexus, but this is not necessary, because intraplexus injection causes 50% subneural injection. So needle nerve contact in interscalene block leads to 50% subepinural injection. You can see this is extra plexus. So where we are placing at the needle tip at the above the C5, you can clearly see the fascial sheath. Just place it around the nerve. Number of needle entry into the interscalene leads to peripheral nerve injuries. So coming to this supraclavicular block, where you can see the superior trunk, anterior and posterior division, the needle, if it enters through the fasciculate, intrafascicular, the ideal tip position has to be paraneurium. When you place it, this is called subepinural spread. But what we need is only paraneurial placement. So there is dual injection. So below the lower trunk and between the middle trunk and superior trunk, and place above the trunk. How we know? You can see here the needle is coming from down. So the needle tip is not so clearly visualized, but that's what the problem, where the nerve injuries can happen easily. Just give small amount of local, where you can see the upper trunk and the middle trunk is going up. By slowly giving injection, where you can see the lower trunk lifting up. You can see the needle tip here, that is below the lower trunk, not into the trunk, not. So we can clearly see the upper trunk, middle trunk and the lower trunk. So the needle has to be placed here first, and then above the subomohyoid deposition of local anesthetic. Where you can see the nerve, the needle is clearly placed below the omohyoid, where you can see pushing down the superior trunk and middle trunk. So number of needle passes can lead to nerve injury in supraclavicular blocks, which were much more common block that is performed. You see here what happens. Because what are the causes for nerve injury? So it's direct mechanical injury, injury to the vessels of the nerve, chemical injury due to the deposition of local anesthetics. You can see the needle directly enters into the subepimysial middle trunk. How I can say that? It just swells the nerve, where you can see the intrafascicles very easily. That is one of the cause for nerve injury. So injury may be due to increased injection pressure. Always remember the non-anesthetic cause for nerve injury, which is tourniquet and patient position and pre-existing neuropathy like diabetic. Always remember needles don't block the nerve, but local anesthetic does. But how to avoid nerve injury? Maximize needle visibility. Target the circumneural fascia that contains the nerve, not the nerve itself. Ensure that the nerve is pushed away during the local anesthetic injection. Avoid paresthesia as far as possible. Exert minimal pressure during injection of local anesthetics. Avoid swelling of the nerve. Use nerve stimulator where the intraneural injection is supposed to be if there is a twitch in less than 0.2. And if you use an injection pressure monitor, but ensure that it has to be less than 15 psi. This is a sciatic nerve block where you cannot see the tip of the nerve, but actually there is a circumneural spread, but actually the needle tip was well inside the nerve. So that's the importance of knowing the tip of the nerve, tip of the needle. Otherwise there is absolute chance of nerve injury. So maximize needle visibility. So tangential entry towards the nerve, and always target the paraneural sheath, not into the nerves. So coming to our topic, the interfacial plane blocks. These are heterogeneous family of blocks where the local anesthetic is deposited in between the facial planes, believing that it blocks the local anesthetic, that is the nerves that travels along the facial planes. There are so many blocks, but these blocks are not the same. These blocks are not the same with efficacy. So these are the important references that I have. To understand the facial blocks, we have to understand the anatomy of fascia, because most of the facial plane blocks targets the deep fascia. The facial system is continuous and connects the different body parts, and it is sheet of connective tissue and elastic tissues. So it helpful in gliding as well as for strengthens. So the prevertebral fascia in the neck, the endothorax fascia in the chest, and the transversus fascia in the abdomen, and the fascia iliaca, they form a natural continuation which provides a way for the pathway for the local anesthetics. So the fascia provide highway for the target nerves. Fascia acts as a reservoir or the compartment where the local anesthetic can be deposited. So the facial interconnectivity is the fundamental for understanding interfacial plane blocks. So what are the different types of fascia we have? The epimysial fascia, which is very thin, easy to lift, but the local anesthetic may not be there for a much longer hours because it is absorbed by the muscles. Example, peg block and tab blocks. These are thick aponeurotic sheath, the fascia iliaca or the thoracolumbar fascia. This is relatively avascular, but it is difficult to split the aponeurotic fascia, but it holds the local anesthetic for longer hours. That way it provides long-lasting analgesic efficacy. The lines of fusion, that is an important concept in interfacial plane blocks, where you can see the transverse fascia fuses with the middle and posterior thoracolumbar fascia. This is the lumbar interfacial triangle where the three fascias join. So you can see the erector spinae, the latissimus dorsi, and the QL muscles. Because the line of fusion are sites where fascia fuse and creates a compartment, it limits the spread. The spread can be anywhere, depends on the resistance of the fascia connecting these three things. So understanding facial convergence is far more important for predicting a facial spread. You want to provide a QL2 block, you have to place a needle tip here. So if you place it here, it becomes a QL1 or lateral tap. So you have to know the facial connectivity. Surgery or trauma definitely leads to pathological line of fusion. It is actually interfacial plane blocks are so many interfacial plane blocks for the given procedure, for the similar procedures. How to choose it? So first look at which block gives optimal analgesia, because there is ill-defined indications for different blocks. Look out for evidence, because every interfacial plane blocks, they have randomized control study around 80 to 85 publications for ESP, but still we lack quality evidence. So discuss the risk benefit for the given technique. So always think of traditional alternative like epidural and paravertebrals. Know the sono-anatomical details of the block, so that what are the nerves that is likely to be blocked to be known. And this is a article by Manoj Karmakar, where he says it relies on the random spread of local anesthetic to get a good block, which may not be, which resembles a shotgun, with the hope that at least one of the pellets may clear the trap. So just because there is facial planes exist, it is not necessary to inject local anesthetic into every plane. So these are the wise words of Manoj Karmakar. So how to choose between neuraxial as well as interfacial plane blocks? There is no question of evidence in epidural or paravertebral. It is gold standard. But in case if there is a high technical failure or hemodynamic instability, just try out other blocks like tab rectus or QL blocks. Paravertebral is quite absorbing, but the chance of pneumothorax and the technical complexity always gives you sleepless nights. That's why try proxy paravertebral blocks like ESP, serratus plane blocks, and retrolaminar blocks. So before going into any interfacial plane blocks, just know the truth. That is hard and bitter truth. The mechanism of most of the facial plane blocks is not well known. We can't assess the adequacy of the local anesthetic spread. There is no objective assessment of the efficacy of the block, and definitely there is no endpoint. And the same neural targets are accessed through different facial layers with the different names. You can see the ESP, the needle comes and hit the transverse process, but a few minutes the local anesthetics is not seen. I do not get to assess the spread of the local anesthetic. So that's why I used to put two needle at different size, T5 and T3, to get a good efficacy. And why, in spite of that, why we need facial plane blocks? Because this is the ERAS post-operative guide, where the multimodal analgesia is the main focus. Because unfortunately the thoracic nerves and the abdominal nerves are not visible by the ultrasound, and it is very simple to perform. It is safe and effective. Alternative options like epidural and paravertebral are contraindicated. There is no alteration in hemodynamics. It is always opiate sparing analgesic block. It can be done under regional anesthesia. This is the era of minimally invasive surgery, so we have to move out to minimally invasive anesthesia. That's why we are looking ahead with the interfacial plane blocks. The mechanism here is it targets the nerve within the same facial plane, that is serratus plane as well as the tap plane. Target the nerve in the adjacent facial plane, that is in continuity, that is ESP and MTP block, and systemic effect of the absorbed local anesthetic is another mechanism here. If there is an ideal site here, so that we have to understand the facial anatomy, select an appropriate size needle, look for anatomical patterns, look for the neurovascular bundle that travels through the facial plane, look for bony endpoint in some of the interfacial plane blocks, ensure linear spread rather than a round spread, assess the spread if it is possible. You can see here, this is a fascia iliaca, supraangular fascia iliaca, where you can see the dorsal circumciliac artery and thick fascia iliaca. You can place a needle, so it can act as a target here. So ideal site could be identification of the artery, because identification of artery leads to identification of the nerve vessels. This is the pec major and pec minor, where you can see the thoracoacromial artery. So the medial and the lateral pectoral nerve travels along the thoracoacromial artery. What you see here is the LD and serratus, the thoracodorsal artery, where you can see the nerves can travel along the. So ideal site might be nearer to the vessels. So ideal site could be a bony landmark in. So pen block, this is where you can see the iliopubic eminence, the psoas tendon, the anterior inferior iliac spine. So we can target the needle and hit the endpoint. There is a definitive target endpoint here. For ESP, the transverse process is a endpoint. This is the rhomboids and trapezius, and we have the definitive endpoint where you can see the ESP sheath that deposit the leg below the ESP sheath nearer to the transverse process. You can identify always as an anesthetist. It's easy to identify the anatomical patterns. There you can see the ilioinguinal iliohypocystic nerve and the dark deep circumflex iliac artery, the external oblique, internal oblique, and the transverse abdominal plane. It's a QL block where you can have a Samra sign, the transverse process, the leaf shaped QL, the psoas and the ESP. You have to deposit the drug below, in between the QL and the psoas. So you have to look for these patterns to look for the interfacial plane blocks. It's not an ideal thing, so always we land up in less ideal blocks where you can see CA breast patient where because of the radiotherapy the muscles are not well delineated. So you can see the circumneural spread within the muscle plane. Just take out the needle and put it in the right plane. So that's what the difficulty here. So again there is a muscle spread here. The right plane is not visible here because there is no artery. We try to locate the artery, but it is very difficult, there is no artery here. That's why it came out of the plane. Just small volume and look for the linear spread. Now you can see it is splitting up. This is a ESP block where you can see the needle entering through the muscle and hitting the target like transverse process. The needle tip is well below, but even though it is well below, we can see the muscle spread and lamination. You can see there is a spread of local anesthetic inside the muscle, even though because size of the needle is more than the size of the fascia. That's why the needle tip, even though is well placed below, the local anesthetic just travels up as well as along the muscle. There is clear lamination of muscle. You can see there is clear lamination. This is not an ideal ESP block. How to improve the efficacy? Just deposit the local anesthetic closer to the target. For example, rectus sheath block rather than lateral tab block. Inject at more than one side if you assess the local anesthetic spread. Increase the concentration and volume of local anesthetics, but beware of lost. Use epinephrine. Maybe you can use a continuous catheter to increase the efficacy. So in summary, just know the zone anatomy. Always target the fascia that contains the nerve, not the nerve itself. The interfacial plane blocks are always unpredictable. Always opiate sparing analgesic block, not an anesthetic block. Think of alternative gold standard technique like epidural and paravertebral. So the only source of knowledge is experience, and imagination is more important than knowledge. Thank you.
Thank you very much, sir. Excellent talk, sir. So any questions from the audience? Do you have any questions? Sir, then we can move to the next step, sir. Thank you very much, sir. Yes, sir. Sir, I call upon our senior faculty, Dr. S. Arun Kumar, sir. So he is a very versatile anesthetist and he updates very much every year. So if something new comes, sir will know about that. So if you need anything about a new technique or newer instruments, sir will answer, always ready to answer. So wonderful teacher. I know him from my UG days and PG days. So I welcome you, sir, for your talk on neuraxial ultrasound. So for the delegates, Hall B is also available, just near to the Hall A, where you can also directly interact with the faculties also. Video and audio are projected there. So we can also use it if you like.
Hello. Check. Yeah.
A very good morning, one and all. I'm so happy to be here in my hometown for the third edition of this Please the Anaesthesia update, and I thank the organizers and Balaji especially for giving me this opportunity. Today I'm here to talk about a new area in ultrasound guided regional anesthesia, which is neuraxial ultrasound. I'll be focusing mainly on the lumbar neuraxial procedures and using it for using ultrasound for epidural and spinal anesthesia. Neuraxial anesthesia, without an iota of doubt, is a cornerstone in modern medicine, which has made an elaborate number of surgeries and obstetric procedures possible. It has been traditionally taught to us by landmark-based techniques, and it is still practiced in most centers as landmark-based techniques. But the problem is there can be, relying on landmarks alone can be suboptimal and less satisfactory results are obtained. So to improve this, enter ultrasound. So by utilizing ultrasound, we can enhance the accuracy of the technique and the safety of the procedure. With these words, we'll be going into the presentation. Okay. So as I said, role of ultrasound in neuraxial procedures is grossly underappreciated. This is because of the fact that traditionally we have been thinking that bone is the biggest impediment to the sound waves. So since a spinal cord is surrounded by the vertebral canal, we will not be able to get much information. But we must remember the interlaminar window, which allows the passage of needle, also allows the sound waves producing a distinct pattern. And the dura is a specular reflector, which means that it's an excellent reflector of sound waves. So it gives a clear vision as your target. So this technique facilitates neuraxial blockade in patients with difficult surface anatomy, where you cannot rely on your landmarks. So with my presentation, I intend to provide a systematic approach to the imaging and the performance of spinal and lumbar epidural in adult patients. We are going to restrict to that. Okay. A brief summary of the history. It was Bogan and Sterlin in 1971, who were radiologists who were the first to do ultrasound for spine interventions. Then Porter et al., then Cork et al., they had small papers had come by that time, but the real contribution towards anesthesia was by this person, the Grove et al., who used it in obstetric epidurals, and his contribution has made significant to the current understanding of spinal sonography. Of course, then it was propagated by eminent people like Manoj Karmarkar, Kim Jin Chin, and it has moved to a different level. So as I told you, why should we use ultrasound when we have a specific landmark? Say we know that the Taffius line, this is the first thing we are taught as residents, and but we must know that the Taffius line is a radiological entity. The amount of soft tissue over the area can grossly differentiate the landmark which we are trying to achieve. So what happened was, a group of consultants were asked to identify the correct level using the Taffius line. To the surprise, it was found that even senior consultants, only 30% of the people were able to correctly identify. Majority of them identified by either one level wrong, or some people even by 2 levels wrong. So this is it was surprising that Taffius line can be so misleading at many times. Then technical issues. Suppose you get an obese patient where no landmarks are palpable. Now what we do, we approximately put in the needle, try to hit bone, then redirect, which can cause much difficulty to the patient and the anesthesiologist. Then patients with scoliosis, spine abnormalities. And nowadays more and more we have patients with instrumented spines. So with these patients you get your landmark based techniques are not that effective. So what critical background information that an ultrasound can give you? So these are the 4 important things which you are going to look for when using ultrasound. Identifying the midline. I hope many of you people would accept the fact that this will be the most toughest challenge, to locate the midline in an obese patient, especially in obese parturient. Identification of the correct space, depth to which the dura is located. So you will have a pre-planned idea of how long to insert your needle. Then at what angle should the needle be inserted? How much degrees should you tilt your needle? So this 4 most important information will be obtained by ultrasound. And the systematic approach is going to make us get all these 4 values. To begin with, we have to have a good knowledge on the anatomy of the lumbar vertebra. We all know that this lumbar vertebra has a body and there is a arch. The neural arch has transverse process, superior and inferior articular process, and a transverse process. But when you see here, what are we going to see on ultrasound? At the level of the articular process, see the inferior articular process and the superior articular process of the lower vertebra form the facet joint. So if you are able to identify the facet joints on both sides, invariably you will be able to see the dura. That is where the interlaminar window lies. So the 2 humps which you are trying to look for will be the 2 articular processes or the facet joints, to be specific. So in the interlaminar window you will be getting this so-called equal to sign. This will be the posterior dural complex, or this will be the anterior complex. I am specifically using the word complex because many a times you will not be able to differentiate between the ligamentum flavum and the dura. So we call it posterior complex and the anterior complex. They will be appearing as an equal to sign. That is what we are trying to see in a transverse view. So getting ready for scanning, as far as your equipment is concerned, a curved array low frequency transducer is ideal. We all know why, because it is deep. But rather than that, the most important aspect is it gives you a wider field of vision. So this wider field of vision will cover, when you are using a sagittal scan, it can cover 2 or 3 spaces which can give you vital information. So always this is preferred, the curved transducer is preferred. Identify and change your depth setting, focus and gain. Unless your settings on the machine are proper, you will not be able to get your landmarks. turn on tissue harmonic imaging. Latest machines already incorporate, but some older machines you have to specifically switch it on. It's a signal processing technique which will reduce the artifact and improve the resolution, especially in patients with big body habitus. This will help you increase the resolution. It can be done in sitting or lateral position and ergonomics. Any ultrasound guided procedure, ergonomics plays a significant role. Unless your ergonomics are right, you will not get the desired result. So please have. And we are going to focus here on more of an ultrasound assisted technique where we are going to mark the space, which means that the position of the patient should not be changed after the initial scan and marking. So this you have to educate the patient and your assistant who is holding the position. So if the position is changed, you have to do it all over again. So I prefer to do it always in the sitting position with the machine to the left side. I'll try to get all my settings right, switch on the tissue harmonic imaging. Try to adjust your gain in such a way that you are able to catch the specular reflection of the dura well. So what are the views we are interested? So this is the one which we all have to remember. There are only 5 views which will give you all the information. Of this, one is the transverse and the sagittal view. Of the sagittal view, one is at the level of the transverse process, one is at the level of the facet joint, and then there's an oblique view. At the transverse view, you will have one at the level of the spinous process and then at the level of the interspinous space. So 5 views. So we need 4 information. For that we are employing these 5 views. So this is a pictorial representation. See, by placing my probe sagittally at the level of the transverse process first, then I will move medially to the level of the articular process, and from the same point I will tilt my probe medially to look into the interlaminar window. So these are the 3 views which I am going to get in my sagittal. So the probe orientation, this is the longitudinal and this is a transverse orientation. And a small thing what I would suggest is holding the probe to your conventional nerve blocks. This technique mandates a slightly different grip. So since there is no gravity to help you support the probe in a stable position, and you are scanning through a very narrow interlaminar window, for example, your probe has to be very, very stable. So for that, use a bimanual technique. Use your both hands to hold the probe in a stable position so that you get an ideal image on the screen. So this is the level of the transverse process. Now the probe is placed along the long axis at the level of the transverse process. You can see the shadows cast by the transverse process. So superficially you can see the erector spinae muscle. Then the transverse process is casting the shadow. In between the transverse process you get the psoas major muscle. So why do you need this view? So longitudinal views or sagittal views are mainly used for identifying the level. So when you move up and down, the last transverse process you will see will be the L5. So with that you will be able to count at which vertebra you are exactly on. So this is an image. You can, as I told you, superficially erector spinae muscle. Then you have the transverse process casting shadows, which is called the trident sign. And in between the transverse process shadow, you have the psoas major muscle. This is one of the views which we use to do the lumbar plexus block also. Moving to the next view. So I had placed my probe here first. Now I am placing my probe more medially at the level of the articular process. Here you can see there is a continuous bone. So how should the image look? So if you see, it looks something like this. There is a continuous hump. This is a linear transducer in a virtual convex mode. This is a thin patient. So we have used a linear transducer in a virtual convex mode. And you can see the humps, which means that a continuous articular process. And this resembles a hump of a camel, and it's called a camel hump sign. Okay. This does not give you any major information, but this sets you up for the next important view, which is the paramedian sagittal oblique view, where you tilt your probe medially towards the midline so that you are able to insonate the interlaminar window. So what do you get? You get something like this. So we call it the horse head appearance. Here you see the erector spinae in long axis. You see the lamina. So here is the interlaminar window. So this is the posterior complex and this is the anterior complex. In between is the intrathecal space. So this resembles the head of a horse. So we call it the horse head sign. So when you look at the horse head sign, you will know that there is a posterior complex and you are able to see the anterior complex. So this is the importance of the oblique, parasymedian sagittal oblique view. So you can see again an equal to sign is seen clearly. You can see the lamina, this is the interlaminar window, and here is the erector spinae muscle. So now I do a dynamic screen. See, this is the, from bottom I am coming up, here the continuous bone is the sacrum and the first breach is the L5S1 interspace. From there it's easy to count. This is the L4, L5 interspace. So as I had started using this, I found the importance of L5S1. I have been taught by many of my seniors that the L5S1 interspace, which we access through Taylor's approach, is the largest and it should be utilized more frequently. But personally, after doing the scan, I was able to appreciate the widest laminar space is your L5S1. So this is again the same thing in a virtual convex mode. You can see the lamina, this is the posterior dural complex and this is the anterior dural complex. And when we do a dynamic scan, you can see from now I am actually from cranial to caudal I am moving. So you can see there is a lamina, there is an interlaminar window, you see the posterior complex and the anterior complex. This is the L5S1. You can see the posterior complex, anterior complex, then the continuous bone of sacrum. So once you identify the sacrum in long axis as a continuous bone, then as you move cranially, the first breach would be the L5S1 interspace. So we try to get it in the middle of the probe, then you can rotate the probe and identify the space. Now moving on to the spinous process view. Personally, I would prefer that this is the most important view because it identifies the spinous process and which helps you identify the midline. So you can see as a diagrammatic representation I have shown here on the model, we have placed a probe exactly over the spinous process. You can see the spinous process casts an acoustic shadow. So since at the level of the spinous process, little deeper you have the lamina on either side, the lamina is producing a broader acoustic shadow. So this temple-like pattern, if you see, it means that you are exactly in the midline. Your idea of tilting and rotating the probe is make sure that you get this exactly a similar image on the screen. If the patient is scoliosis, you will have to with scoliosis, you will have to adjust your probe in such a way that you will get a similar picture on your ultrasound screen. If you want, you can also put an M mode on the screen to align your spinous process towards the center. The next is the interspinous space. Now I am moving to the interspinous window. Now you can see what happens is the two articular processes are casting big shadows. As I told you, the articular process casting big shadows. Here is the posterior complex and here is the anterior complex. Here is the interspinous ligament. So this resembles a bat, like the ears of the bat, we call it the bat sign. So getting the bat sign, you will have the equal to sign, the posterior complex and the thicker anterior complex. Always remember the anterior complex is thicker because it involves the posterior part of the vertebral body also. So that is the thickest and it sometimes can cause reverberation artifacts. So you can see the articular process casting the bat ear pattern, the posterior complex and the thick anterior complex. There might be a reverberation artifact as seen here, but we must, with experience, you will know how to ignore it. So this is the interspinous view. So now, after the view, how I am going to mark the space. So you can see what I am doing now is holding the probe and trying to align the posterior anterior complex. I am trying to get a glimpse of the anterior complex. So when I see the anterior complex, I am pretty sure that my sound waves are going through the interlaminar window to see the anterior complex. So once I get an optimal image, what I do is with a marker, skin marker, I mark on all the three sides of the convex probe. So once the marking is done, once I remove the probe, now all the three lines will be connected. The three lines will be connected, and the point where the three lines meet, I make an indentation with a needle cap. So remember, this is an ultrasound assisted approach. So I have to now go and wash up, scrub, and then come. So I have making a mark with the needle cap. So now the most important part is the patient should not change his position. So now we have painted and draped, and you can see the mark which we had made by the needle cap. Now doing the block, what happens? We need, now I am not even touching the patient, just at the, put the needle exactly at the point where we marked. Then we can, the depth was somewhere around 7 centimeters. So we just have to keep moving your needle till the mark of 7 centimeters. This was a patient who was very apprehensive about his neuraxial block because he had a very bitter experience with the previous surgery. So we had to convince him to do this, and you can see exactly at 1 centimeter of the epidural needle was left, and we were able to place it in a single prick. So the next, another approach is a paramedian approach. You can get this, as I told you, the temple view in a midline. You can mark subsequent 3 or 4 spaces you can mark on the patient, and make a mark 1.5 centimeter just lateral to the spinous process. And with the 5 to 10 degree medial and cranial angulation, you can enter the interlaminar window. This is an alternate approach where you are not able to get your spinous process is clearly seen, but you are not very sure about the interlaminar window. You are not able to get the dural complex. There you can use this paramedian approach. Real-time guidance. Personally, I have been practicing this for almost very recently only. So the problem here is doing a hand-eye coordination at the same time maintaining sterility, because neuraxis, if you use a gel, the gel can enter into the neuraxis, or I am very apprehensive about a gel entering into the neuraxis. So probe contact with the skin was, I am a little bit skeptical. So what we have done here is, just I have shown you, I do it in the left lateral. Conventionally, we put a patient in right lateral position to do the spinal. Here, we put the patient in left lateral position, keep the machine ergonomically on the opposite side, use an oblique orientation of the probe to get a view something like this. So, on the cranial side, the head or the cranial side of the probe, you will see the interlaminar window. So, I can do an in-plane approach from the caudal end of the probe. So, but the probe has to be covered by a sterile probe cover. Strict asepsis have to be maintained. So this was one of the cases which we done under out of plane approach. You can see the interlaminar window. You can see the needle coming from the middle. So from the middle of the probe, the needle will come and enter the interlaminar window. Once you strike, you can get the CSF, but what is more important is you have to observe this. The probe has to be sterilized thoroughly before you embark on this technique. So what is the role in obstetrics? So we know that weight gain, hyperlordosis, all these things will make the central neuraxial blockade more challenging. You can do a pre-procedural scan to identify the correct space. So it has been well proved by studies. The efficacy and safety in obstetric epidurals has been proven by Perlas et al. And does it have a role in emergency LSAs? I personally feel it does, and it has come to our rescue in few situations. So the evidence, there are a lot of systematic RCTs, systematic reviews and meta-analysis which proved beyond doubt that increases the safety of the technique. The accuracy and safety of the technique is beyond doubt. It has been improved. So we have to get trained. Now we have spine phantoms are available to train for ultrasound guided central neuraxial blockade, and there are some needle innovations as well. Remember, we had a standard 2He needle. We have an echogenic 2He needle now available by Payunk, and this was an experimental needle, a curved epidural needle. When this was in a cadaveric study, it was found that the needle visibility, the operator easiness, everything was comfortable with this curved echogenic needle. Remember, in future, needles may not always have to be straight. So we have to be prepared for this. So my take-home message, landmark and palpation-based markings are often inaccurate and a frequent result in spinal anesthesia being cited at a level higher than that is intended. Pre-procedure scan can give you the critical background information which will help you do your technique better. Use of ultrasound will result in fewer needle process, which can result in increased patient comfort and improves patient safety. Definitely it will take an extra 5 minutes of this scanning will save a lot of pain for the patient. So it's an easy skill. Definitely it's an easy skill with practice which can inculcate. Extremely effective with the perioperative obstetric and pain management setup. In-depth knowledge of the vertebral sonoanatomy is mandatory, which we will be seeing in the afternoon session. And practice on phantoms which help in smooth integration into clinical practice. When you start for first case, don't try to do it in an obstetric case. Try to do an ordinary patient where you have some time. Try to get the landmarks, try to do the markings, try to get the stable image. Early days when we started doing, there were people who were mocking at us that you are using ultrasound for a basic spinal anesthesia. Even my colleagues, many of them made fun actually, my friends know. But over a period of time, everyone understood that this improves patient safety and saves you a lot of time. With those words, I come to the end of my talk. Thanks for the patient listening. Thank you.
Thank you very much, sir. It's an excellent talk. Any questions from the delegates? Naveen, mic.
Subhash, good morning.
The role in emergency ultrasound.
Emergency,
Morbid obesity. Patient comes with wheeling into the ultrasound. I'm sorry, into the labor room or the OT. An emergency section has to be done. The role of ultrasound in that case.
As I told you, it's not easy actually. In an emergency situation where you will not be able to have enough time in making the patient sit, do the marking, but it can still give you, if you have planned a spinal, it will definitely, you can have 2 or 3 minutes within which you need not do all the 5 views. You can go for identifying the midline and interspinous view and roughly mark it, and then you can do the spinal anesthesia. It has definite role, but obviously it is something like usage of echo in a patient with cardiac arrest. You can do it, but you must do it within the 10-second window to find out whether there is a reversible cause, something similar. You will have a, say, a 2 or 3 minute window where you will be able to identify the space. Thank you.
Thank you, sir. Thank you.
Thank you.
So I call upon our next speaker, Dr. Narasimhan, sir. So he is an assistant professor from Stanley Medical College. He is the most energetic person I have seen. Always moving around in the OTs, trying to learn new things today. And I think he always goes home in the night and think, I have learned these 2 new things today, like that. Because he is always energetic and always there when there is a high level of academic exchange. So over to you, sir. Thank you, sir.
Thank you, Balaji, for the nice introduction. Video check பண்ணிக்கலாம். view மாத்தணும். எஸ்கேப்பா குவிட் பண்ணலாமா? குவிட் பண்ணிக்கலாம்ல? ஃபோர்ஸ் குவிட் எப்படி பண்ணுறது? இதை ஆஃப் பண்ணி போடலாமா?
நடுவில் ஸ்டக்கப் ஆகிட போகுது.
ஸ்லைட் ஷோ இல்லை சார். ஸ்லைட் லேஅவுட்டு இருக்கு சார். ஸ்லைட் ஒன்லியா? இந்த மாதிரி தான் இருக்கா? சேஞ்ச் இங்கே இருக்கு. இதை போட்டுட்டுமா?
இல்லை ப்ளே ஸ்லைட் ஷோ போடுங்க.
ப்ளே ஸ்லைட் ஷோ போட வந்துடும் சார்.
சைடு வரல, விண்டோஸ் தான் வருது.
விண்டோஸ் தான் வருது.
எஸ்கேப் கொடுத்துட்டு சைட்ஸ் ஒன்லி வருது சார். ப்ளே ஸ்லைட் ஷோ
இல்லை ப்ளே போட்டால் என்ன ஆகுது சார்னா அங்கே வந்து ப்ரெசென்டர் வியூ
இல்லை ஓகே பரவாயில்ல விடுங்க அப்படியே பேசிடலாம் இது வருதாங்க
ஆரம்பிக்கட்டும். அதை மாற்ற நீங்கள் பேசிட்டு
இல்லை வேறு இதில் காப்பி பண்ணலாம் சரி நடுவில் ஸ்டக்கப் வச்சா பிரச்சனை
இல்லை எங்கிட்ட இருக்குது சார் அப்படியே பண்ணுங்க.
There is slight delay in the conference due to technical issue. The conference will be resumed very shortly. Thank you.
ஓகேவா? இல்லை இது வெளில வந்துடுவோம். இங்கே வேறு வருது, அடுத்த ஸ்லைடு வருது. ஓகே போதும், இப்படியே பேசிக்கிறேன் விடுங்க. Good morning, one and all. At the outset, I'd like to thank the organizers of Preeti Anaesthesia Update for having given this excellent opportunity to present in this historic town of Madurai. I am Dr. Narasimhan and I'll be discussing about the anterior chest wall blocks. As we all know, the anatomical structures in the anterior chest wall includes, from the midline, we have the sternum, costal cartilages, ribs, and the breast tissue in the subcutaneous plane. So we can classify anterior chest wall blocks into anterolateral and anteromedial chest wall blocks. So under anterolateral chest wall blocks, we have PEX 1, PEX 2 and serratus anterior plane block. These anterolateral chest wall blocks are used predominantly for surgeries on the breast, rib fractures and also for thoracotomies. Whereas this anteromedial chest wall blocks, we have two there, transverse thoracic plane block and pecto-interfacial plane block. These are used predominantly for sternotomy incisions. I bring warm greetings from my workplace, which is Stanley Medical College. So we all know the course of the thoracic spinal nerve. So each spinal nerve root, as it exits, as it emerges from the spinal cord, it gives the dorsal ramus. The ventral ramus, it continues in the intercostal space between the internal intercostal muscle and innermost intercostal muscle. Approximately at about the mid-axillary line, it gives the lateral cutaneous branch. This lateral cutaneous branch, it ascends and branches into anterior and posterior branch, which supplies the anterolateral chest wall tissues. The intercostal nerve ends as the anterior cutaneous branch, which pierces the intercostal muscles as well as the pectoralis major muscle. It supplies the anteromedial superficial tissues of the chest wall. So, how blocks are classified? We have the posterior chest wall blocks, right, which includes retrolaminar block, erector spinae plane block, and paraspinal intercostal plane blocks. Now we are going to deal with the anterolateral blocks, particularly the pex 1, which is between the pex major and pec minor muscle. Then we have the pex 2 and serratus anterior plane blocks. Whereas the anteromedial chest wall blocks, we have two. They are the transversus thoracis plane block and pecto-interfacial plane block. Why we need this facial plane blocks? So you can see the complexity of innervation in these structures. So you can see that it's not like the upper limb or lower limb where you can block a nerve and produce analgesia. So these nerves are complex nerves, as you can see here, and there is an extensive communication between the branches. So what you can do here is, you can inject large volumes of local anesthetic into facial planes. For example, we do a rectus sheath block, we do a tab block, or a serratus anterior plane block, where we inject local anesthetic into facial plane blocks and expect drug to act on the local anesthetics, drug to act on the nerves and produce analgesia. So let us refresh our knowledge by going into the cadaver dissection, which is done in our Stanley Medical College. We are going to see a cadaver dissection. So the incision is made in this manner, and as we retract the skin, we see the breast tissue which is sitting on the pectoralis major muscle. So that's the pectoralis major muscle. We all know that pectoralis major muscle, it arises from the sternum, costal cartilages, clavicle. It gets inserted into the humerus. So it's the major muscle which sits immediately deep to the skin. On retracting the pectoralis major, we see the pectoralis minor. So this pectoralis minor, it arises from 3rd, 4th, 5th ribs, and it gets inserted into the coccygeal process. So thing to be remembered here is clavipectoral fascia, which arises from the clavicle. It splits to encircle the pectoralis minor muscle. It extends to the axillary fascia. So when depositing the drug, you have to ensure that the needle goes beyond the clavipectoral fascia so that you will have axillary coverage. Now on retracting the pectoralis minor muscle, we can see the ribs with the intercostal muscles. So you have to remember that intercostal muscles are seen between the ribs. Whereas you can see the serratus anterior muscle over there. These are the digitations of serratus anterior muscle. So this arises on top of the rib. So when the muscle arises over the rib, it's serratus anterior muscle. When it is seen between the ribs, it is intercostal muscles. So the serratus anterior muscle, it becomes more fleshy in the axillary region. We know that the anterior axillary fold, it is formed by pectoralis major muscle. Whereas the posterior axillary fold, it is formed by latissimus dorsi muscle along with teres major and subscapularis muscles. So this is the latissimus dorsi muscle. So coming to the nerves, between the pectoralis major and pectoralis minor, we can see a small nerve which pierces the pectoralis minor and supplies the caudal portion of pectoralis major. So this is the medial pectoral nerve. Now as we reflect the pec minor, what we can see is the axillary artery, which gives off the thoracoacromial artery, which gives off multiple branches, of which the pectoral branch of thoracoacromial artery. So that's the pectoral branch of thoracoacromial artery that is in relationship to lateral pectoral nerve. Between the pectoralis major and pectoralis minor, you expect blockade of medial and lateral pectoral nerves. Now this is the serratus anterior muscle. We can see a nerve running on the serratus anterior muscle and supplying it. That is the long thoracic nerve of Bell. Still laterally we have the subscapular artery which extends continues as the thoracodorsal artery. So this artery, it is in relationship to the thoracodorsal nerve. That is the nerve supplying the latissimus dorsi muscle. So these are the nerves which are of interest to the anesthesiologist. So this is the anterior cutaneous branch. You can see that we are closer to the sternum. So it supplies a small twig. So when you want to block this anterior cutaneous branch, we need to do the block closer to the sternum. Now coming to the lateral cutaneous branches. So now what we are seeing is the second rib. So he's showing the second rib, and just below that we can see the lateral cutaneous branch of T2. So that's the lateral cutaneous branch of T2, which is also called as the intercostobrachial nerve. So this is very important to anesthetists because this one frequently gets spared when we do a supraclavicular brachial plexus block. So we need to supplement this intercostobrachial nerve. So this is the lateral cutaneous branch of T2. So we are also going to mark the lateral cutaneous branch of T3, T4 with the pins. So you can see there all this, they arise between the digitations of serratus anterior. So the innervation to the anterolateral chest wall is complex. It is derived from intercostal nerves, cervical plexus and brachial plexus. So cutaneous innervation is by the medial cutaneous branches and lateral cutaneous branches. Not only that, the supraclavicular nerves from the cervical plexus, they also play a role. Very important to remember that the myofascial pain, the myotomes are supplied by the brachial plexus, right, from the medial and lateral pectoral nerve, thoracodorsal nerve and latissimus dorsi. This has to be remembered while choosing analgesia for breast surgeries and thoracotomies. So I just wanted to stress two important points here. So when you keep a probe here, right, just below the clavicle, the rib you see will be the second rib. You will not be seeing the first rib when you keep a probe just closer to the clavicle. So the first rib you see will be the second rib. And the pectoralis minor muscle will be in relationship to third, fourth and fifth ribs. So when you see pectoralis minor muscle, it means you are closer to third, fourth and fifth ribs. And you can see the serratus anterior muscle, this becomes more prominent in the axillary region. So coming to the sonoanatomy for PEX block. So this is the ergonomics, this is the sonoanatomy we did. So ergonomics which has to be employed while doing this block. So we start the scanning with the probe in oblique orientation. We start just lateral to the midclavicular line. The probe is sequentially moved towards the intercostal spaces, towards the axilla. So we do sequential scanning of the intercostal spaces starting from the clavicle. So first we see is the clavicle. So the rib here is the second rib. We can see the pulsations of axillary artery. So this is your subclavius muscle and this is the pectoralis major muscle. So this is the step 1. This is the point where we start the scanning. So as we move the probe down, we are able to see the third rib. So this is the third rib and this is the fourth rib. Here you can see the pec major, pec minor, serratus anterior muscle which is above the rib, whereas the intercostal muscles are seen between the ribs. So you can also appreciate the pectoral branch of thoracoacromial artery. As we move further down towards the fifth rib, you can see the tapering of pectoralis minor muscle. So the pectoralis minor muscle tapers. So you can see the tapering pectoralis minor muscle at this point. So this clavipectoral fascia, it encircles this muscle, it continues as the suspensory ligament, which is also called as Gerdy's ligament. So you can see that the muscle has tapered and this is your suspensory ligament. So as we scan further, so this is your anterior axillary fold, it is formed by pectoralis major muscle. So now this is the pectoralis minor muscle, it has ended there, and as we turn around into the axilla, so we have the serratus anterior muscle here. Serratus anterior muscle sitting on the rib, and above that we have the latissimus dorsi muscle when you scan towards the posterior axillary line. So this is the sequential scanning which we are going to discuss in the afternoon workshops. So on scanning further, you can see there rib here, serratus anterior muscle, and above that we have the latissimus dorsi muscle. So this is the panoramic view where the scanning starts at the clavicle. So we have the pectoralis minor muscle over the third, fourth and fifth ribs. In the axilla we can see the serratus anterior and latissimus dorsi muscle. So pex 1 block is between pec major and pec minor muscle. Pex 2 injection, subpectoral injection happens in this plane. So serratus plane block, it can be either above the serratus anterior or deeper to the serratus anterior muscle. So we have this 3 thoracic blocks where the relative probe position is shown here. So usually pex 2 block, it is done over the fourth or fifth rib, whereas serratus anterior plane block is done between the anterior and posterior posterior axillary lines. So coming to the needling in pex 1 and pex 2 block. So we do a in-plane needling, cranial to caudal needling. You can see the needle passing through the pectoralis major muscle. It is further advanced through the pec minor muscle. We are entering the space between the pectoralis minor and serratus anterior muscle. So when we have a doubt, we can inject few mils of saline to know that we are in the right plane. So when we are sure that we are in the right plane, we have to give the local anesthetic. It is always preferable to do a pex 2 block first before doing the interpectoral injection. So you can see the drug spreading nicely, it extends above the serratus. So it's always advisable to have rib as a backstop when you are maneuvering the needle. So this will avoid inadvertent pleural injury. So right there, so the local anesthetic spreading nicely between the pectoralis major and serratus anterior muscle. So once this is done, you deposit around 20 mils of local anesthetic in this plane, slowly withdraw the needle. So this is your thoracoacromial artery. So try to open out the space between the pectoralis major and pectoralis minor. So as we give few mils of local anesthetic, there is unzipping of the interpectoral plane. So you deposit around 10 mils of local anesthetic in the interpectoral plane. So you can see that the drug has spread nicely between the pec major and pec minor, and also it has extending into above the serratus anterior muscle. So pex 2 block 2 injections, a deeper or a subpectoral injection which happens between the pectoralis minor and serratus anterior muscle. The point here is there will be clavipectoral fascia. It has to be deposited below clavipectoral fascia, so there will be coverage of the axillary dissection. So when the surgeon does axillary dissection, we need to ensure that it is spreading correctly in the serratus plane. Whereas pex 1 injection, that is the interpectoral injection, pectoralis major and pectoralis minor muscle. So coming to the serratus anterior plane block. So to the needling and sonotomy and needling for serratus plain block, we prefer serratus plain block in the lateral. So this will be in patients with voluminous breasts, so we can have easy access. So we start scanning in the mid-axillary line. We need to find the serratus anterior muscle first. Slowly, as you move the probe towards the posterior axillary line, we'll be seeing the latissimus dorsi muscle. So you can see the serratus anterior muscle on top of the ribs. As you go posteriorly, the latissimus dorsi muscle comes into view. Next thing is, you need to find out the pulsations of thoracodorsal vessels between these two muscles. So between the latissimus dorsi and serratus anterior, you have to look for pulsations of the thoracodorsal vessels. So you can see that nice pulsations of thoracodorsal vessels. You can see one more pulsation here. So this is the plane where we need to inject the drug when we give a superficial serratus anterior plain block. So you can see a small muscle, teres major muscle, coming into view when you scan cranially. So as we know, there's two injections. It's the superficial serratus plain block where the injection is done superficial to serratus anterior muscle. So coming to the needling, the needle has passed through the latissimus dorsi muscle and I'm advancing the needle through the serratus anterior muscle. So as I inject local anesthetic, you can see that there is clear unzipping of the deep serratus plane. So drug is spreading nicely deep to the serratus anterior muscle. So in this case, because there are longitudinal striations of the muscle, it is very difficult to delineate the latissimus dorsi and serratus anterior muscle. So with the rib as a backstop, it is easier to do a deep serratus anterior plain block. So this is the deep serratus anterior plain block. Superficial serratus anterior plain block injection will be between the latissimus dorsi and serratus anterior muscle. So coming to the anteromedial chest wall blocks, we have two blocks here, transverse thoracic plain block and pecto-interfacial plain block. We know that closer to the sternum, the transversus thoracic muscle replaces the innermost intercostal muscle. So the anterior cutaneous branch, it passes through the internal intercostal muscle and the pec major muscle, it supplies the skin. So we have 2 points of injection we can do, either deep to pec major muscle or between the internal intercostal and transversus thoracic muscle. So this becomes the pecto-interfacial plain block or superficial parasternal intercostal block. This one is your transversus thoracic plain block. So what is the problem with pecs and SAB block? Because we are producing blockade of lateral cutaneous branches, the anterior cutaneous branch gets spared. So whenever we do a pecs or a SAB block, it is very important that we combine blockade of the anterior cutaneous branch so that the entire anterolateral area is covered. So the approach will be in this manner, the probe is kept in this manner. We see the two ribs. So you have to focus on this area. This is the pec major muscle. So as you move closer to the sternum, we'll see one more layer of muscle. So this is the transversus thoracic muscle. But this layer has got a lot of vessels in the form of internal thoracic vessels. So on careful scanning, you can see the 3 layers. So this is your pectoralis major, internal intercostal muscle and transversus thoracic muscle. So when you put the Doppler, you can see the internal mammary vessels nicely in this view. So to avoid injury to these vessels, you can do scanning in the transverse orientation. Now you can see nicely the internal thoracic vessels. So this is your internal intercostal muscles and this is the transversus thoracic muscle. So you can do needling so that you can avoid damage to the internal thoracic vessels. So we have lots of blocks to avoid confusion, there has been a recent advisory on change of nomenclature. So no longer PEX 1, PEX 2 is used terminology. Now it's called as interpectoral plane block. For PEX 1 and for PEX 2, they are using the terminology pectoserratus plane block. For for PEX, for serratus anterior plane block, we use the terminology superficial and deep serratus anterior plane blocks. For anteromedial chest wall blocks, we use the name superficial and deep parasternal intercostal blocks. So I thank all of you for your patient listening. Sorry for the computer delay. Thank you.
Thank you very much, sir. Excellent presentation, sir. Any questions from the delegates? Okay, then we will move on to inauguration, sir. Thank you, sir. Thank you. So tea will be served inside the hall.
Good morning. Next is our inauguration session. We invite all the dignitaries to come forward to the dais. First, I welcome our guest, Dr. Kumar sir. He is the HOD of Cardiac Anaesthesia from Meenakshi Mission Hospital, Academic Coordinator of the ISA Tamil Nadu State, and the past President of ISA Tamil Nadu State. Welcome, sir. Next, I call upon Professor Dr. Chidambaram sir, our HOD of Orthopedics, to come forward to the stage, sir. Next, Dr. Prahalad sir, our Senior Orthopedic Consultant and a Senior Arthroscopy Surgeon, to come forward to the dais. Next, I invite Dr. Sendil Kumar sir, our Medical Superintendent. Next, I invite our Organizing Secretaries, Dr. Balaji sir and Suresh sir. Then Mr. Zahir sir, our Chief Operational Officer, to come forward to the dais. I call upon Dr. Bharat sir, our Senior Orthopedic Consultant, to come forward to the dais. Next is the welcome address. Now I would like to call upon Dr. Suresh, our Organizing Secretary, to deliver the welcome speech.
Good morning all. I wholeheartedly welcome you all to the third Preeti Anaesthesia update on ultrasound guided nerve block. We are truly honored to have you all gathered here today at our esteemed function. At this juncture, I would like to thank our chairman, Professor Dr. Sevakumar sir, and our MD, Dr. Hema ma'am, whose constant encouragement and their unwavering support facilitated to have their event possible for the third consecutive year. I also welcome our COO, Mr. A.Y. Zahid sir, and HOD of Orthopedics, Professor Dr. Chidambaram sir, MS Dr. Sendil sir, and Senior Consultant Orthopedician Dr. Prahalad sir, and Dr. Bharat sir. I also welcome Dr. Rajaram sir, Dr. Saravana Kumar sir, Narasimhan sir, Rajesh sir, and Dr. Karthik sir, and Siva Prasad sir, Gauri Shankar sir, Ganeshan sir, Sendil Kumar sir, Gurumurthy sir and Satish Raja sir for this event. I also welcome Dr. Kumar sir, HOD of Cardiac Anaesthesia, Meenakshi Mission Hospital, for being a guest of honor for this event. Today, we embark on a journey of knowledge and innovation in the field of anesthesia with a particular focus on revolutionary technique of ultrasound-guided nerve blocks. It's a privilege to see so many experts and enthusiastic delegates come under one roof to exchange their ideas, share experience, and advance our collective understanding of this critical aspect of medical practice. Throughout the day, we have an exciting lineup of distinguished speakers, experts in their respective domains, who will share their insights, experiences, and expertise on various aspects of ultrasound-guided nerve blocks. Their presentations promise to be informative and thought-provoking, offering us providing an opportunity to expand our knowledge and skills. Before I conclude, I would like to express my sincere gratitude to all the faculties, delegates, and volunteers who had contributed to the success of this event. Now, without further ado, let's dive into this exciting day of learning and discovery. Thank you once again for joining us today. I wish you all a productive and enlightening experience at Preeti Anaesthesia update on ultrasound-guided nerve blocks. Thank you.
Next is the Kuttuvelakal lighting ceremony. I would like to call upon our Dr. Shanmuga Priya ma'am, Senior Consultant of Anesthesia, to come forward and light the lamp. I would also like to call other dignitaries to join with her. So now I would like to call upon our medical superintendent, Dr. Sendil Kumar sir, to share a few words.
Good morning all. Respected dignitaries and delegates, friends and colleagues. It's with pleasure and joy I am here to convey our chairman, Professor Dr. Sivakumar sir's goodwill and best wishes for the success of this Preeti Anaesthesia update. This is the third edition of our Anaesthesia update continuing education program, which we have been doing continuously. This is an example of carrying forward the legacy of our chairman, who is a keen academician and has a very good interest in updating both in expertise as well as in equipments and infrastructures. Our new CORI real intelligence orthopedic robo system is a recent example of one of its achievement. We have installed it and we are doing the robotic surgery routinely on a day-to-day basis. It's not only that embracing the new technology is only one aspect. Gaining expertise and using it for the benefit of the patient as a commitment to give back to the society a very good, innovative, state-of-art technology enabled service at an affordable cost. That's our motto, and we have been consistently doing it. That is evidenced by our academic excellence by gaining approval and conducting DNB programs in orthopedics, anesthesia, obstetrics and gynecology, and few other specialties are in the pipeline. Our alumni, especially the orthopedic alumni, are spread all over India, and it's a very well recognized and very well taken up program. In this juncture, I am glad to announce that we are starting our fully recognized, fully accredited Preeti College of Nursing from this year onwards, and the admissions are already going on. On behalf of our chairman and the managing director, our COO, and all of our team who have put their efforts to make this a reality, and it's not only that, we are committed ourselves as a team, the Preeti Hospital team, for continuing development, sharing our knowledge and expertise, learn from each other and complement each other. With the guidance of our chairman, our anesthesia department has grown strongly, and we have regular DNB PGs, and they have their hands on the state-of-the-art technologies which are available from the very first day onwards. And it's also very well recognized, and I wish our anesthesia department to carry on this forward, scale up new heights and set up new benchmark standards. Thank you. Thank you all.
Now I call upon our beloved Professor Dr. Chidambaram sir to address the gathering.
Good morning, everybody. Chief guest of today, Dr. Kumar, Medical Superintendent Dr. Sendil, Dr. Perkalat, and the organizing team, Dr. Balaji and Suresh, our CEO, Dr. Zahir sir, the various faculties who come forward for the success of this conference, and delegates, and the organizing team and the masters of ceremony. As our medical superintendent has told in detail about our hospital and the state-of-art equipments, and this is our third edition of our Preeti Anaesthesia update. Anesthesia has become a safe procedure. When we were, I retired as the professor of HOD of orthopedics in way back in 2018, nearly 16 years back, and I'm really fortunate to be attached to this institution since my retirement in 2008. And since then, this institution has grown leaps and bounds, and now we have a very good orthopedic department with postdoctoral fellowship after MS or DIP&B, and since 1914, and our alumni are more than 30 in number in orthopedics, And we have the Dip and Be program, as Remas was telling. The so 2 batches are passed out, and the 3rd batch or 4th batch are in, and the 5th batch is coming, and we have increase of our Dip and Be candidates to 4, and we have our OG postgraduates and also anesthesia postgraduates are here. And you are all here to learn about the, as I was telling about the safe anesthesia. When we were, there are only general anesthesia and spinal and the epidural and some blocks here and there. Now, with the advent of ultrasound, we had our first CME on the upper limb, second CME on the lower limbs, now the trunk and abdomen, and you're all here, and anesthesia has become a very safe practice. And congratulations to the organizing team for a successful program, and you all come here, learn all the techniques of the state of art in this hospital. And one word about Dr. Ganesan, when I was HOD and the senior warden, and Dr. Ganesan he was the secretary of the our YSS. At that time we did a lot of improvements. I can still remember he was a very dynamic person, and I don't know about the other faculties personally, so we have been attached right from my professorial days. And thank you for all the organizing team and all the support team. We are here for this conference. Thank you all, and wish the conference all the best. Thank you.
Thank you, sir. Next, I invite our guest of honor, Dr. Kumar sir, to deliver a few words.
Respected Medical Superintendent Dr. Sendil sir, COO Mr. Zagir, HOD of Orthopedics, Professor Dr. Sidambaram sir, Dr. Prahlad sir, Dr. Bharat sir, my good friends, Dr. Suresh, Dr. Balaji, respected faculties, delegates, and my dear postgraduates. A very good morning to everyone. At the outset, I would like to thank the organizers, especially Team Anaesthesia, Preeti Hospital, for the invite for the consecutive 3 years. Though I am a neighbor and co-PG of Dr. Sivakumar, I become co-member of our corporate also, Preeti and Meenakshi. Thanks to Balaji, thanks to Suresh, thanks to my mentor and teacher, Dr. Sendil sir, and the entire team of Preeti Hospital for the kind invite. I congratulate Preeti Anesthesia team because they're consistently conducting this CME and workshops. As sir was pointed out, consecutive 3 years, they're doing extremely good job, and they are done in our state conference also. The quality of CME and workshop conducted in Preeti Hospital is really appreciable. It is well appreciated by all the delegates who attended this program. Thanks to Preeti Anesthesia team again for continuously, consistently conducting this program. But at this juncture, I have to thank our Preeti Hospital management, Chairman Dr. Sivakumar sir, Managing Director Dr. Khema ma'am, and the entire team of management Preeti Hospital for the unconditional support and encouragement for conducting these type of academic programs by Department of Anesthesia at Preeti Hospital. Thanks to management. I think sir is not available on the way back to Madurai. And you all know that one of the branch in anesthesia just developed significantly over these recent years is regional anesthesia and trauma care. There is no doubt about it. The reason behind this is innovation. A lot of innovations in regional anesthesia and trauma care, especially ultrasound has taken over the advancements in trauma anesthesia. That is a really appreciable one, and everybody has to learn ultrasound and regional anesthesia blocks. That is the way forward to future. And in future, it is going to be technology-based medical practice, no doubt about it. Robotics and AI, artificial intelligence, going to be the future. I don't know how far AI is going to replace our role. It will be supplementary, it will not replace. There are a lot of talks going in all the conferences in recent days about AI, but there is, to some extent, it will make our job easy. So we have to learn all the technology-based practice. And robotics have been introduced in first time in South Tamil Nadu in Preeti Hospital, especially for robotic-based joint replacement and trauma care, because in Meenakshi already introduced 5-10 years back robotics for all the surgeries, but for joint replacements and trauma care, first time in South Tamil Nadu, Preeti Hospital done a fantastic job. I congratulate the entire team of orthopedics under the head of Professor Dr. Chidambaram sir and Dr. Sivakumar sir, Dr. Prahlad sir and entire team for doing excellent work with the help of robotics. It is going to be the future, no doubt about it. And I'm sure you all will get benefited by these type of workshops. Keep on learning about the CMEs and lectures, it will get bored. And these type of workshops definitely make you to understand and make it better. That is why they always combine lectures plus hands-on workshop. That is really appreciable. No doubt you all get benefited and you can use your knowledge learned here for the better patient care. There is a quote from Mother Teresa. I usually fond of that quote. Not all of us can do great things, but we can do small things with a great commitment and love. Yes, together we can make great things to make our profession a better specialty and also to spread the knowledge across our field. With this, my best wishes for the successful conduct of this CME and workshops and in future years also. Thank you very much. Have a great day.
Thank you, sir. Then I would like to call upon our Professor Dr. Prahlad sir to share a few words.
Good morning, one and all. So, respected guest of honor, Kumar sir, and all the senior dignitaries on the dais. So, I am really thankful for giving me this opportunity here. So, I think so everyone has shared what we are committed to do and how we are doing. So, in today's scenario, everyone is talking about Chandra and we are touching the moon and so many things are happening. So it's not only in our field, medical field also, we have done a lot of things. So we being surgeon, we are very closely associated with you all. So we cannot even think of doing anything without anesthetist. And for that matter, I am very thankful to our anesthesia team who are very grateful to us. They come even in any time we tell, Suri, we want this case, sir, anytime we will be available. Balaji. So any high risk case, they are ever ready to come and give that. So this is only possible because of continuous learning. So we have to keep upgrading ourselves at every stage. So what we could not have imagined all these procedures few years ago, and we are now comfortably doing all the procedures in regional anesthesia and making it so safe. Anesthesia has become so safe and we are able to do surgeries at our will. Just couple of days, I have certain my friends who were telling that they were doing of repair and they developed pneumothorax, severe pneumothorax. Certain complications, we don't know whether it was because of block or extravasation of the fluid, and one patient lost his life. So these are certain things which are not in our, but nowadays we are able to identify what is the cause and how we can prevent them. So we are, every day we are upgrading ourselves it is not only learning the techniques, but it is also we should know what are the intricacies in that, what are the problems in that. So we are, that is the reason why we are all having this great faculty here and all the delegates who are here to upgrade themselves, and it is always interaction and you can always share your knowledge on such platforms. I thank our anesthetist team for bringing up such meetings on regular annual basis. So I wish you all have a great time here, and thank you one and all.
Thank you, sir. Next is the felicitation ceremony. I request our Medical Superintendent Dr. Senthil Kumar sir to felicitate our guest of honor, Dr. Kumar sir. Next, I request you to felicitate our Professor Dr. Chidambaram sir. Next, I request you to felicitate our beloved Professor Dr. Prahalad sir. Thank you, sir. Next, I request Dr. Chidambaram sir to felicitate our faculty members. First, I call upon Dr. Rajaram sir, Senior Assistant Professor of Anaesthesia and Stanley Medical College, to come on to the dais. Next, I call Dr. Saravana Kumar sir, Associate Professor of Government Tiruvallur Medical College. Now I call Dr. Narasimhan sir, Assistant Professor of Stanley Medical College, to come on to the stage. Thank you, sir. Now I request Dr. Prahalad sir to felicitate our faculties. Now I call Dr. Rajesh sir, Senior Consultant Anesthesiologist of Meenakshi Mission Hospital, to come to the stage. Next, I call upon Dr. Karthik, Consultant in Meenakshi Mission Hospital, to come on to the stage. Next, I call Dr. Siva Prasad sir, Assistant Professor of Madurai Medical College, to come on to the stage. Next, I call upon Dr. Gauri Shankar sir, Assistant Professor of Madurai Medical College, to come on to the stage. Next, I call upon Dr. Ganesan sir, Associate Professor of KAPV Government Medical College, Trichy, to come on to the stage. Thank you, sir. Next, I call Dr. Next, I request Mr. Zahir, sir, to felicitate the faculties. Now, I call upon Dr. Sendil Kumar Mohan, sir, Associate Professor of Government Medical College, Pudukkottai, to come on to the stage. Next, I call on Dr. Gurumurthy sir, Senior Consultant Anesthesiologist of Ganga Hospital, to come on to the stage. Next, I call Dr. Satish Raja Selvam sir from Ganga Medical Center, Coimbatore, to come on to the stage. Now I request Mr. Kumar sir to felicitate our guest of honor, Dr. Ganesh Prabhu sir. He is the HOD of Anesthesia of Velamal Medical College and Hospital and the past National General Council member of ISA. To come on. Next is the vote of thanks. Next is the vote of thanks. I cordially invite Dr. Naveen sir to conclude the inauguration session by giving the vote of thanks.
Good morning, everyone. On behalf of this prestigious institute and organizing team, it's my privilege to propose a vote of thanks on this occasion. My heart fills with lots of gratitude and respect for the distinguished speakers for not only sparing their invaluable time for us to grace this occasion, but also for enlightening us with their commendable talk on the subjects. Thanks all of you for clearing our concepts and enhancing our understanding pertaining to the chest wall and abdominal blocks. You have indeed put your best of your efforts to make us understand all and make this event unforgettable. I'm running short of words to express my honorable thanks to our beloved Chairman Sir and MD Ma'am for providing us this stage for showcasing our department CME. And also, I'd like to thank on this occasion our MS Sir, our COO Sir, our Ortho Department team, IT team, Food, Mr. Sayam Sir and his security team, and Mr. Satish, Mr. Nagarajan, Mr. Dilip, and Mr. Potiraj and a whole housekeeping team and other people. And also our beloved delegates, without whom this program would have not been possible. And a special thanks to our sponsors, of Sonosite, GE, Neon, and Fresenius Kabi for putting our efforts to put up this show today. Thank you.
With this, we end the inauguration session and let us all stand up for the national anthem.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जनगण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Let's all dispose for the snacks. The session will continue after a small tea break.
We will continue with the sessions. I welcome Dr. Rajesh sir, senior professor from Meenakshi Mission Hospital and Research Center, for his talk on anterior abdominal wall blocks. So sir is always ready to explore newer topics and newer challenges. Over to you, sir.
Good morning, one and all. Okay, I think everyone is there in the tea break. It's okay, fine. First of all, I would like to thank the organizers of this Preeti Anaesthesia update. The organizing team headed by Dr. Balaji, Dr. Suresh, Dr. Shanma Priya, and everyone in the organizing team. And I congratulate them for this excellent arrangements made in this CME workshop. So I am Dr. Rajesh and from Meenakshi Mission Hospital. Me with my colleague Dr. Karthik will be presenting on anterior abdominal wall blocks. So one of the oldest block in this ultrasound era is the anterior abdominal wall blocks. And when this topic was given to me, I had a lot of doubts related to this. is it equivalent to upper limb or lower limb plexus block or something else? And there are a lot of approaches being explained in many literature, so how to decide over that particular approach. And what are we going to inject, and in which plane we are going to inject, and how to identify the particular plane of injection. And do we really have any target nerves in this anterior abdominal wall blocks? And very important question, how does it act? So when we are not able to see anything, how it is going to act? And moreover, can it be used for anesthesia, surgical anesthesia, or is it simple analgesic block? So these were the questions which I got in my mind, but some of the questions remain unanswered. That is that is what I want to tell you now. Some of the questions are still unanswered here. So I'll try to make some answers with my presentation. So the anterior abdominal walks came into limelight when there was some difficulties or complications related to gold standard analgesia for abdominal surgeries, that is thoracic epidural. So the first block which came into limelight was transverse abdominis plain block, and it is being practiced everywhere, left, right. So I know all of you know that this block is indicated for all abdominal surgeries, but it produces analgesia for skin of the anterior abdominal wall, yes. Muscles of the anterior abdominal wall, yes. Parietal peritoneum, yes, but where is the visceral peritoneum or viscera? There is no analgesia for viscera or visceral peritoneum. So this block cannot be used for surgical anesthesia. It is just an analgesic block, or can be used as a part of multimodal analgesia what we are providing. And in a simple words, putting a local anesthetic in between two muscles or in the interfacial plane between the two muscles, that is internal oblique and the transverse abdominis muscle, will produce a good surgical analgesia for abdominal surgeries. Yes, fine. Is it really true? Is it so simple that we can put a drug anywhere in between these two muscles for any surgery? No. The anatomy makes it little more complex. To understand the various levels where we have to deliver the drug, we should be thorough with the anatomy. Unlike the nerve anatomy, this is muscle anatomy which we have to be thorough with. The abdominal wall is guarded by 4 pair of muscles, that is anterolateral abdominal wall, in the form of rectus abdominis, transverse abdominis muscle, internal oblique muscle, and the external oblique muscle. The deepermost muscle, that is the transverse abdominis muscle, which runs transversely, arises from the 7th to 12th ribs, thoracolumbar fascia, iliac crest, and anterior superior iliac spine. It wraps medially, and it inserts into linea alba and the pubic crest. Linea alba is nothing but the aponeurosis of all the 3 abdominal wall muscles. Okay, so this is the direction in which the transverse abdominis muscle goes on. Internal oblique muscle is originating from the down. Actually, it is originating from the thoracolumbar fascia, iliac crest, it's from the iliac crest, anterior superior iliac spine, and the iliopsoas fascia. It also wraps medially, but the direction is running upwards. It is run towards upwards, inserting into the linea alba and the 10, 11, 12 ribs. External oblique, originating from the 5 to 7 ribs, it run medially, anteriorly, downwards, inserting into the linea alba, iliac crest, and pubic tubercle. As I told, the linea alba is the junction of all the 3 muscle aponeurosis. Now, you have to be very clear with this. The direction of all the muscles are not same. Transverse abdominis muscle runs medially in a transverse direction, while the internal oblique runs from down to up, while the external oblique runs from up to down. So this is very, very important in identifying the each muscle, because we are going to deliver the drug in the compartment which is being made by these muscles. The compartment where we have to deliver the drug is the transverse abdominis plain compartment, and it holds T6 to L1 thoracolumbar nerves. That is our target. T6 to L1 thoracolumbar nerves. The plane is bounded anteriorly, it lies between the transverse abdominis and the rectus abdominis muscle. When it go posterior or posterolateral, the rectus abdominis muscle ends there, so you will have the boundary as internal oblique and the transverse abdominis muscle. So the plane will be situated between the internal oblique and the transverse abdominis muscle. So anteriorly, it is between the transverse abdominis and the rectus abdominis. When you go posteriorly, it is between the internal oblique and the transverse abdominis muscle. You have to be very clear in that. And when you look at the abdominal wall innervation, the thoracoabdominal nerves, as I told, T6, T to T12. So now I am eliminating L1 because L1 is from lumbar plexus. L1 nerve is from lumbar plexus. It is the one which forms the ilioinguinal iliohypogastric nerves. Among the thoracoabdominal nerves, T6 to T11 are intercostal nerves. Means it travels between the two costal margin, while T12 is subcostal. There is no 13th rib, right? So T12 is subcostal and T6 to T11 are intercostal nerves. So this has been enlightened by Dr. Narasimhan that a spinal nerve, after emerging out from the paravertebral space, divides into the anterior and posterior rami. The dorsal posterior rami takes care of the back, while the anterior rami is the one which supplies the anterolateral area of the body. So that gives off two important branches. One is the anterior cutaneous nerve and the other one is the lateral cutaneous nerve. The anterior branch is the one which travels in the intercostal space earlier, that is what we call it as intercostal nerve. Then it takes a different plane through which it travels. So that is where we target it for the anterior abdominal wall blocks. So if you look at this nerve, so when you go down at the level of the abdominal level, so it is it's not the intercostal muscles there. You have quadratus lumborum here, you have latissimus dorsari here, the ventral rami here. So the nerve emerges from there and it takes a different path. It goes through the quadratus lumborum muscle and then it enters into this plane which is called the transverse abdominis plane between the transverse abdominis and the internal oblique muscle. Not all the nerves enter the plane in the same area. That is very, very important when you go for a tab block. So at the level of T12, the entry may be more entry into the tab plane is more posterior, and it is something related to the quadratus lumborum muscle, and the takeoff point of the lateral cutaneous nerve is also different at that level. But normally, when you go down, the takeoff point is at the level of the mid-axillary line. So the lateral cutaneous nerve comes out of the mid-axillary line, it divides into anterior and the posterior branches. The anterior one is the one which is going to supply the lateral wall muscles. But when you go for anterior muscles, it is the anterior cutaneous nerve that has to be targeted. And this anterior cutaneous nerve, when it goes for terminal region, same like the intercostal nerves in the thoracic region, it also gives off a branch which comes out through the rectus muscle and divides into two branches, and which takes care of the midline supply. So our target should be two areas. One is this anterior cutaneous nerve here, other one is the anterior cutaneous nerve even before reaching there or before the lateral cutaneous nerve gives off. So if you want to complete anterolateral analgesia, you are supposed to deliver the drug before the takeoff of the lateral cutaneous nerve. So before the lateral cutaneous nerve. Now, the tab plane, the segmental nerves, where they enter the tab plane differs. So T6 to T9, they enter the tab plane medial to the anterior axillary line. They enter the tab plane medial to the anterior axillary line, while T10 to T12 and also ilioinguinal iliohypogastric, they enter it more laterally. So if you want an analgesia involving these nerves, the target should be more posterior, while if you want analgesia for T6 to T9 segments, the drug deposition should be medial to the anterior axillary line. This is the basic of tab block. And tab block is not a simple thing. It forms plexus. It forms plexus. There are two plexus, upper quadrant plexus and the lower quadrant plexus. The upper quadrant plexus are formed by the T6 to T8 anterior cutaneous nerves. They enter at the tab plane at the costal margin, and they are the one which is taking care of the subcostal skin over the subcostal margin, while the lower quadrant tab, which is the one which innervates the infraumbilical region. So this is for all your upper abdominal surgeries, and this is for all your lower abdominal surgeries. If you look back the history of TAB, 2001, Dr. Rafi introduced this as an abdominal field block for inguinal hernia surgeries. Soon after that, 2006, Dr. O'Donnell, he introduced the same block in a different term as transverse abdominis plane block, and from the day this block has got invented, there are a lot of fights happening around the terminology, around the drug deposition, everything. So this is, both of them did it at the level of Petit's triangle, which is being bounded by the external oblique and the latissimus dorsi. This is Petit's triangle. Both the authors, they did the same block at the same area, one with single pop-off and the other one with double pop-off. Very importantly, what we have to notice here is, both of them did it more posteriorly. It is not the anterior tap. This has happened more posterior. That is why the success rate was so high with them. After the ultrasound era, in 2006, display okay. Sorry. Okay, in 2007, Peter Hubbard introduced the ultrasound guided TAB block. Here, he deposited the drug in the anterior, little more anterior plane. Within 4 years, Carney et al., they challenged it, and they deposited the drug in the posterior area. So the posterior area, in the sense, the junction between the transverse abdominis muscle and the quadratus lumborum muscle. So they deposited the drug here, while Peter Hubbard explained it, he had to deposit the drug here. So which is superior, which is inferior. So much of debates and so much of nomenclatures has been given to this block, where the drug has been deposited here as transversalis fascia block, thoracolumbar fascia block, and slowly I think Dr. Gurumurthy will be explaining the same thing, that this is the one, is the pioneer for the quadratus lumborum block, the QL1 block. So there are lots and lots of approaches, which is superior, which is inferior, that we have to yet to come at the decision. There are 4 different types of TAB block which has been standardized: subcostal TAB block, posterior TAB block, lateral TAB block, and the anterior TAB block. Anterior TAB block is not very commonly practiced by the regional anesthesiologists. That is meant for, usually for the pain physicians, because the patients coming with ilioinguinal, iliohypogastric neuralgia will need anterior TAB block, because it's not common in regional anesthesia practice. So the 4 different blocks, the subcostal block involves the upper quadrant analgesia, but it will not involve the skin lateral to the anterior axillary line. That is very important. Lateral TAB block, again, it produces lower quadrant analgesia, but skin lateral to the anterior axillary line, again, it will not be covered. The posterior TAB block plays a superior role, providing all type of analgesia. Here the question is whether this will produce visceral analgesia. That is the biggest question with the posterior TAB block. There are a lot of studies which shows that it produces visceral block also. That is why the QL plays superior role. The ilioinguinal iliohypogastric nerve block, it provides only for analgesia for skin in the inguinal region. This will not cover up any visceral pain. So this is a landmark for subcostal TAB block. The subcostal margin and the xiphoid process. For lateral TAB block, it is iliac crest and the mid-axillary line, and the ilioinguinal, for ilioinguinal hypogastric plexus block, it is anterior superior iliac spine and the umbilicus. That is important. Okay, so the positioning also for lateral and subcostal, it is supine position, and for posterior TAB block, it is lateral position. So placing the transducer lateral to the xiphoid process and along the lower margin of the rib cage, medial and cranially you have to place it. So this is the plane where we have to inject the drug between the rectus abdominis and the transverse abdominis plane. If you are seeing this, some patients may not sorry, you may not be able to see the transverse abdominis muscle here. So in that situation, you may have to inject it between the internal oblique and the transverse abdominis muscle, and the volume needed will be somewhere around 15 to 20 ml, that is 0.2 ml per kg body weight. This is for upper abdominal surgeries. The lateral tab block, again, it is the placement is of this thing, probe is between the midway between the costal margin and the iliac crest. You will see the 3 muscle plane, and you have to inject the drug from medial to lateral direction, so that the drug gets deposited in the between the internal oblique and the transverse abdominis muscle. For posterior tab block, the same drug place, the same plane, but patient in the lateral decubitus plane position, the transverse can, we have to go more posterior till we identify the QL muscle and deposit the drug at this level, and this is the for posterior, and the volume all same, 15 to 30 ml volume for every block. So this is the scanning sequence to identify all the 3 planes, all the subcostal tab, lateral tab, and the posterior tab, which has been explained. So okay, so this is your rectus abdominis muscle. So you can see the transverse abdominis muscle here. This is linea semilunaris, that's junction between all the 3. So the scanning sequence happens. Then now I am entering into the lateral tab plane. I'll slowly going into the posterior region. So you can see the transverse abdominis muscle getting an end, and this is the thoracolumbar fascia, and here you can see the quadratus lumborum muscle. Okay, so this is a scanning sequence for okay, now where to deposit the drug? See, the drug deposition should produce a lens below the level of internal oblique muscle. If the drug goes into the transverse abdominis muscle, doesn't matter, the block will act. But if the same drug leaks into the internal oblique, it is not going to act, because the facial plane should depress, the drug should dip down the facial plane of the transverse abdominis muscle, not the internal oblique muscle. Okay, so the volume again is very, very important, and the drug dosage is very important. So you have to calculate for the volume, and you have to calculate for the local for drug dosage for the local anesthetic systemic toxicity, because this area is highly vascular, absorption will be high. So every quadrant needs 20 ml. So for complete analgesia, you may need an 80 ml. So dilute your drug. This cannot produce surgical anesthesia. It is only for analgesia purpose. Interestingly, Tran et al., very recent study, had come up with multiple surgeries and multiple recommendations for the tab block. Cesarean section, which is the tab block where we commonly practice. See, the posterior and lateral tab block is not recommended when you give intrathecal opioids. That's the current recommendation. So laparoscopic cholecystectomy, subcostal tab block is recommended. Laparoscopic cystectomy, no more tab blocks. No more tab blocks. You can go for only multimodal analgesia. And the colorectal surgery, still thoracic epidural plays a major role. Thoracic epidural plays a major role. Only when it is contraindicated, when we can go for continuous tab blocks in the form of lateral subcostal tab blocks. Open appendicectomy, posterior or lateral tab blocks are recommended. Laparoscopic appendicectomy, lateral tab blocks are not at all recommended if you want to go for posterior tab block. And again, open prostatectomy, lateral tab block is not recommended. Means the lateral tab block is slowly going out. Is slowly going out of practice. So it has to be either posterior tab block, or it has to be either quadratus lumborum block, which has come as an alternative blocks. Okay. So the completion for purpose of the upper abdominal surgeries will not get completed when you don't do a rectus sheath block, because for midline incisions and the midline pain relief, you have supposed to put the local anesthetic for the anterior cutaneous nerve, which comes out through the rectus sheath and divides at the level of at this plane. So you have to deliver the drug below the rectus abdominis muscle, but above the posterior rectus sheath. So this is the rectus abdominis muscle, which travels from up to down. Shall I take 5 minutes? Is it okay? Okay. Okay. The two heads of the rectus abdominis muscle originating from the pubic crest and the anterior pubic ligament, inserting into the anterior chest wall between the 5th to 7th costal margin. It has 3 fibrous bands with the tendinous incisions. So these are the tendinous incisions. This happens one at the level of xiphoid process, the next one at the level of umbilicus, the next one in between the xiphoid process and the umbilicus. So we have 3 pairs. 3 pairs. This is why this is how people get 6 packs with this muscle. Okay. So why it is important to us? See, the rectus sheath also it has a plexus. It has a plexus which is very much related to superior epigastric artery and deep inferior epigastric artery. So both the arteries are related to the rectus sheath, and the rectus and the anterior cutaneous nerve, once it enters here, it goes through the rectus muscle, to deliver the twigs into the anterior abdominal wall. So even if you inject into the rectus muscle, this block is going to work well. But you have to be very careful. The posterior rectus sheath is not always present. It's not always present. In the middle, it is present, but when you go up and down, the posterior rectus sheath is not always present. So this is the posterior rectus sheath which is being formed by the aponeurosis of transverse. Again, all the 3 aponeuroses, they divide and then they engulf this the muscle here. So the posterior rectus sheath may not be present in all the places. See, this is at the level of xiphoid sternum. You have anterior rectus sheath, there is no posterior rectus sheath. Here it has both anterior and posterior rectus sheath. When you go down, there is no posterior rectus sheath. Means infraumbilical, there is no rectus abdominis block. If you deliver infraumbilical rectus abdominis block, you are going to put the needle into the peritoneum and you are going to cause the peritoneal injury. Even MRI shows that the umbilicus is the margin, that is the arcuate line. So below the arcuate line, this is the transition point. So below that, it is only the transversalis fascia and peritoneum. There is no posterior rectus sheath. So this is our scanning sequence. So you can see that at the level of the xiphoid process, the rectus muscle and the anterior rectus sheath. So there is no posterior rectus sheath earlier. Now you can see the formation of the posterior rectus sheath along with that fascia transversalis and the peritoneal structures. When you keep on going down, see, this is the umbilicus. So after that, there is no posterior rectus sheath. It is only the transversalis fascia and the peritoneal layer here. Okay, so you have to be very careful there. So the drug delivery should happen, lifting displacing the fascia down and lifting the muscle up. Okay, I'll just highlight only small points here because this is not in common practice in ilioinguinal. This is from the lumbar plexus. This is from the lumbar plexus. That is the point number 1, iliohypogastric and ilioinguinal, with some amount of contribution from subcostal, that is T12 nerve. Iliohypogastric is the one which lies medially, and ilioinguinal is the one which lies laterally. The ilioinguinal is the one which lies laterally. Iliohypogastric is the one which gives off a branch, that lateral cutaneous branch towards the hip. That is for where your hip surgery incision happens. Okay, so this is the common area which is being supplied by the ilioinguinal, iliohypogastric nerves. So most of the times, this nerve, if you want to catch, better option is always quadratus lumborum block rather than going for the individual block. So as it has been highlighted earlier, this is also related to an artery, that is deep circumflex iliac artery. Keep the probe over the iliac crest towards the umbilicus. Always identify the deep circumflex iliac artery. It is very much related to the deep circumflex iliac artery, and always apply Doppler before putting the drug in. Okay. Okay. Now you can see that iliac crest here. You can see all the 3 muscles. Now, see there is a small bubble here. This is a plane, but earlier it was not having the nerve. So because the nerve, we don't know where it will enter into the tap plane. So you have to be very careful. Don't inject the drug without seeing some bubbles, at least the deep circumflex iliac artery, because if you inject it either anterior or if you inject posterior, nothing is going to happen. But if you inject it more anterior, probably the nerve would have left that place and it would have entered into the external oblique aponeurosis. So To catch the nerve, you have to be very careful. So there are a lot of complications related to the abdominal wall blocks too. Failure is very much common because that anatomical variations. Last is the important complication. Again, intraperitoneal injury, bowel injury, and hepatic injury if you are not monitoring your needle tips properly. So coming to a conclusion, so interfacial plain blocks, putting the drug between the rectus abdominis muscle or transverse abdominis muscle produces rectus sheath block, and between the internal oblique and the tab plane produces the transverse abdominis plane block. Okay, so this is the pictorial diagram. We will explain all those things in the afternoon workshop. Thank you. Thanks for the opportunity.
Thank you very much, sir. Wonderful videos and excellent pictorial presentations, sir. Thank you very much, sir. Any questions from the audience? Thank you, sir. We will move on to the next talk. I like to call Dr. Seva Prasad, Senior Assistant Professor from Madurai Medical College. He has an unique quality to him, can be called as a cardiac regional anesthesia. So he practices both cardiac and regional anesthesia, and he is doing regional anesthesia in cardiac surgeries now. Over to you, sir.
Thank you, Balaji sir, for the wonderful introduction. Good morning all. Is it audible?
Good morning all. So after mind exploring sessions, let us all sit back and see a relatively easier block. Okay, I am Dr. Seva Prasad from Madurai College, and I have my colleague Dr. Gauri Shankar to show you some videos of this block. And at the outset, I would like to thank the organizing team of Preeti Hospital for inviting us to give this lecture. And more so, I would like to thank the speakers who spoke before me for reducing all my work. So to explain all the anatomy, they have done that, and they made my job easier. So erector spinae block is depositing local solution in the plane between the epimysium of erector spinae muscle and the intertransverse ligament. So you can see this is the transverse process. And in between two transverse processes, you have the intertransverse ligament, and that is the erector spinae muscle. You put that needle there, and you give the drug, and that's it. And the aim of this block is to directly block the dorsal ramus. You already know that the spinal nerve gives off a dorsal ramus. So in this plane, the dorsal ramus straight goes through it, and you're directly doing it. And the ventral ramus may be indirectly, because the drug has to go through some planes and block the ventral ramus and the intercostal nerve also. So it is first described by Mauricio Ferreiro from Ontario, Canada, and it's a landmark paper because report on two people who had metastatic pain of the ribs, and it was really very successful because somewhere else the pain was there. He did this in erector spinae plane, and the pain was totally gone, and you can see that from the year of introduction, 2016, so many very good articles have come describing this block in variety of indications. So this is a superficial paraspinal facial plane block, very, very easy to perform. I would say that if you are a postgraduate trying to learn about the ultrasound guided blocks, this is the first block you should start, then go ahead with other blocks, because in plane approach it tells you how the muscle look like, how the you can guide your needle, you can see the tip of the needle going down, you can open up the plane. There are no major neural or vascular structures there. It's a very good block to start with. It is relatively very safe, and complications rarely occur only if you don't see the needle tip. Such a complication like pneumothorax can occur. And if there is any transverse process visible on your ultrasound, you can do this block right from the cervical area to the sacral area. So, and it has proven efficacy and more so in the posterior skin, and the indications keep expanding. Let us see how these indications fit into us by anatomical and clinical approach.
So to understand anatomy, typical spinal nerve, it has already been taken. I'll just brush it up, and we'll also see how the local anesthetic spreads in that erector spinae plane, and the barriers to the paravertebral space, pathway to the paravertebral space, and the muscles of the back. So you already know this diagram. The spinal nerve is formed by the fusion of the dorsal and the ventral root from the spinal cord, and immediately the dorsal ramus is given. It goes posteriorly to give the sensory motor supply to the bones and ligaments and the muscles there. The anterior ramus, it travels into the intercostal space in between the inner and the innermost intercostal muscles. It goes anteriorly and around the mid-axillary line, it gives off the lateral cutaneous branch that travels both posteriorly and anteriorly, supplying the muscles of the skin of the lateral chest wall. And as Narasimhan sir had already told, the anterior cutaneous nerve is the terminal branch supplying the sternum and the parasternal area. So this is roughly the anatomy, and you are going to deposit the drug at this place. This is the place where you are going to go and aim and give the drug there. So I am bringing my needle here, depositing the drug there. The drug will spread in a cephalocaudal direction. Many spaces, up, down, it can spread, and very useful for spine surgery. So this is one block. If you give, your spine surgery is going to have less amount of opioid consumption, good hemodynamics. When your surgeon tells you bring down the BP, it's so easy because the plane is good with that analgesia. And the drug is also going to spread laterally, either subcutaneously also, and in between the external intercostal, inner intercostal space, and it is going to block the lateral cutaneous nerve. So that will help you in providing for the breast surgery, thoracotomy, cholecystectomy, and nephrectomy. And if you are going to do a cardiac surgery, if you want to do an anterior sternotomy, the drug has to go into the paravertebral space anteriorly, and then it has to block all the segments so that the terminal most branch of the intercostal nerve has to be blocked. That is the barrier. These barriers to the paravertebral space consist of ligaments, membranes, and muscles, and we'll see that how the barriers and how we are going to overcome those barriers. So this is the costovertebral area looking at from above. This is the plane where you are going to give the drug. So there are few ligamentous barriers for the spread of the drug. The first one is called the lateral costotransverse ligament and the radiate costotransverse ligament. This will impede the flow of the drug from the posterior to the anterior compartment. We have the paravertebral space here where all these nerves will come and will go the anterior ventral ramus and the dorsal ramus. So this, if the drug goes here, you will have a complete block of that segment. So we have, can you see there is a recess here? This is called the costotransverse space. So this space provides one channel for the drug to spread from the posterior area to the anterior area. And the other ligaments here are the superior costotransverse ligament connecting the transverse process above and the rib below. So can you see this? The fan-shaped ligament going from above downwards, and the another ligament is the intertransverse ligament moving from the transverse process of the above to the lower transverse process. Now you have your erector spinae muscle posterior to it, and easily you can give the block by filling that space between the intertransverse ligament and erector spinae muscle. Now I think I am very clear where the plane is. So the drug will spread cephalocaudally in one direction, it will spread in the lateral direction one direction, giving anesthesia for the lateral cutaneous nerve, and it has to cross two barriers, the intertransverse ligament and the superior costotransverse ligament, to enter into the anterior field and go into the paravertebral space. So let us see the muscles of the back. They are in four layers. First one, you remove the skin, you have trapezius and latissimus dorsi. Next layer you will have rhomboidus major, and in the third layer you will have the triradiate erector spinae muscle, and if you remove that also you will have intricate muscles which are connecting the transverse processes. And next comes the intertransverse ligament. So sonoanatomy, when you do it in the cervical area or thoracic area or in the sacral area, you can use a linear high frequency probe, but if you do it in the lumbar area, you will need a curvilinear probe. You can start with the parietal plane and with the marker cephalid. This is the marker there, that's in the cephalid direction. You can set the depth to 5 to 6 centimeters and you can increase the gain at the 4th to 5th centimeter to make the intertransverse ligament more visible. So this is the scanning plane. You can see that, you can see three muscles there, the trapezius, the rhomboid and the erector spinae muscle. So this bright shadow is of the intertransverse ligament on the yellow there. The two transverse process should be box shaped. So that is the place where you can give. You have to move the transducer medially and laterally and see to that box shaped transverse process starts. It is not so medially and so lateral. If you go laterally, you will go and see the ribs which are rounded. You cannot see the ribs in the lower down because the transverse process casts echogenic shadow there. You cannot see the ribs there, and pleura also should not be seen. If you are in the pleura, you are very lateral. So move more medially where the transverse process starts and you don't see the pleura. And the typical dose is around 30 ml, which can block 8 segments in thoracic and only 4 segments in the lumbar area. So the block depends on how you orient the needle, what pressure you give, the segment you are going to put the needle in. That depends how much of drug is going to spread to how many levels. So now coming to the barriers of the intervertebral space or the paravertebral space, you can see that my needle is coming there and the drug is going there, but you can see three strong ligaments, the intertransverse ligament, the superior costotransverse ligament and the radiate ligament, which will impede the drug flow from this area to the paravertebral area. See, the drug here will easily block the posterior part and on the either side of midline. It can also go and give some analgesia to the lateral thoracic or abdominal wall. But if it has to go to the anterior area to block all the nerves, it has to come here in this area to block the paravertebral plexus space. So there is a lot of impediments for the movement there. Let us see what they are. In the first layer, that is the anterior that's anterior ventral ramus. So just behind the ventral ramus, we are seeing from the posterior area, just behind the ventral ramus you have the internal intercostal muscle, and that continues towards the vertebra as a internal intercostal membrane. So still now you have a vision of that anterior ramus. The next ligament that comes there is the costotransverse ligament. The space which you already seen, the costotransverse space, that is called the medial slit through which the posterior ramus comes out, and the space between the costotransverse ligament and the internal intercostal membrane is called the lateral slit. So these three channels will allow the drug to move anteriorly. So if I have done a medial scan, the intertransverse ligament is absent, the radiate ligament is also absent, and the superior costotransverse ligament is also deficient here. So drug can easily pass down there. So if you give a block here, it is called a retrolaminar block. We give it here in the erector spinae plane and you allow the drug to go anteriorly. I think I am clear about it. So these are the three spaces through which the drug passes, and depending on your indication, if you give it at various levels, the drug will spread anteriorly and posteriorly and laterally, and will give you analgesia. One more minute, I will just finish it. So cadaveric studies indicate that the posterior spread is very good, whereas the anterior spread is very unreliable. That is why many clinical studies, a lot of papers coming there, but they are not really, they don't really whether it works for the anterior the abdominal wall or not. And to end, there's two papers, landmark papers which have come, which are warning us to, because it's a very easy, safe block, people tend to use it for a lot of indications. They are telling that if you are using it for a indication which needs the drug to go to the paravertebral space, better be cautious. So it is easy to learn, safe block. You aim at the most lateral part of the transverse process. Choose the level that suits the surgery. Suppose you want it for a cholecystectomy, you should come down up to T6 or T7 level and give it. For cardiac surgeries, you will need to give it at T5. For breast surgeries, you will need it at T3. And for lumbar surgeries, you will at least need to go to L1 and L2. And confirm the spread after the injection. It might not spread the way you want it. So once you give the drug, you put the transducer up and down and look at it. Do not rely on ESB where the effect is due to paravertebral spread. Thanks a lot.
Thank you very much, sir.
One video, 2 minutes.
No problem, sir. Sir, next I call upon Dr. Gauri Shankar, sir. He has completed fellowship in pain medicine and is one of the anesthetists actively practicing pain medicine in Madurai. Over to you, sir.
வீடியோ மட்டும் ஒரே நிமிஷமா இது மார்க்கர் எழுதி வச்சுக்கிறேன் சென்டர் ஓகே ஸ்டாப் பண்ணுறது இங்கே நீங்கள் ஸ்டாப் பண்ணிக்கலாமா வீடியோவை ஸ்டாப் பண்ணணும்னா தேங்க்யூ ஓகே ஓகே good afternoon everybody. This is a small video presentation regarding the erector spinae plane block. Let us start with the erector spinae plane block. வராது இருக்கா ஆடியோ வராது பிளாக் பண்ணிடுங்க ஸ்டார்ட் ஆயிடுச்சா what to do before starting the block? The most important thing is we have to secure a peripheral IV access. This is the most important thing. Many of the time I myself while doing the PG have not started an IV line and I have performed a block where the patient might have gone for a pain shock and there not be any venous access to revive the patient also. It is very difficult. Therefore we should start with the venous access and then we have to connect to the monitors even while performing the block, even while making the patient sit and do the procedure. While we are doing the procedure we have to monitor the patient continuously. Next, what are the positions in which we can do the block? It is totally based on what we are comfortable with. Mostly the patient may not be able to lie down in certain positions. He might be comfortable sitting. In such patients we have to perform a block in the sitting position. But for me, I used to perform the block under sedation, a mild amount of midazolam and a fentanyl. Along with it, I will make the patient to lie down in a lateral position and make the patient bend a little bit forward so that I will be able to place the probe without much of a movement. It will be much more stable. Many of the blocks are performed in the sitting position, but as I had told you, I prefer doing the block in a lateral position like this with the knee flexed, upper knee flexed a bit and rotated, the shoulders rotated a little bit forward. We can also do the block particularly in a prone position, particularly if we are doing a lumbar approach and bilateral lumbar approach, we can do it in a prone position. Let us see, before going to the Sona anatomy, we can perform the block at various levels depending on the indications. We can perform at T2 level, we can perform at T5 level, T8 to T10 level and also at L3 level depending upon the indications. Okay, we will see the indications later. But how to identify the level at which we have to perform the block? We can use the anatomical landmarks like the 7th prominent spine at the back, at the neck and the thoracic junction will be the C7. From that we can count the spine down. Or we can use the scapula as a landmark where the spine of the scapula will be at the level of 3rd thoracic vertebra and the tip of the scapula will be at the level of 7th thoracic vertebra. Like that we can palpate and also we can identify the lower rib and from that we can correspondingly do that one. But with the aid of ultrasound we can easily identify the level at which we can perform. What we have to do is that we have to identify the first rib by placing the probe in the superior level and gradually we can count the ribs downward and we can come to the particular level at which we have to perform a block. For lumbar level we can do a paramedian ultrasonography so that we can identify the largest and widest space between S1 and the L5. So that from there we can identify and count the levels easily. This one we are going to do the scanning at T5 level. Okay. Therefore, the muscle The erector spinae muscle will be constant, but the superficial muscles will vary. For example, in the lower level, we will be having latissimus dorsi, certain times serratus posterior, inferior, and in the middle level, we will be seeing at the above T6, we will be seeing trapezius, rhomboidus major and minor, and if you go in a higher level, we will be also seeing serratus posterior, superior. This block is performed at T5 level. This is a transfer scan at the T5 level. What we are going to do is that from the spine we are going to move the probe laterally. The spinous process will be casting a big shadow, and the hyperechoic line will be seen at the lamina level, and the tip of the transverse process will also be seen. If we move it further laterally, we will be able to see the coastal this rib articulating with that of the transverse process. In this position, initially we will be seeing only the trapezius muscle. Gradually, as we go laterally towards the scapula, the muscle will become more prominent. And these are the this erector spinae muscles. This is the transversospinal group of muscles, and then spinalis, longissimus, and iliocostalis will be visible on the lateral both borders. This is the tip of the transverse process, and this is the rib. We can mark the position at which we get this one. Next, we will perform the block at the sagittal paramedian scanning by doing the sagittal paramedian scanning. From medial to lateral, we will be proceeding. Here we are placing the probe paramedially from the top of the spine. Therefore, you will be visualizing the lamina. This will be a dark shadow because of the bone, and you will be able to see the epidural space, and then you will be able to visualize the erector spinae muscle, above which there will be the rhomboidus muscle and then the trapezius muscle. We have to gradually slide the probe laterally. From lamina, we will be able to visualize the transverse process, which is something like a tombstone appearance. This is the transverse process. This creates a tombstone appearance like a shadow. We have to avoid the transverso-costal margins. We should not inject here. Just we have to keep it a little bit medial. Certain times, some people will be much more comfortable from coming from the lateral side, from the ribs to the top of the transverse process. In such cases, we can perform the sagittal plane sono evaluation from the ribs, and we have to move gradually medially. This is the part where the transverse process articulates with that of the rib. We should avoid that spot. We have to move a little bit medially. In this plane, we will not be able to see the pleura here, clearly here. We can tilt the probe a little bit laterally so that the curvature of the pleura will give a echogenic shadow if you tilt a little bit laterally. These are the ligaments which you are be able to visualize. This is the transverse process, two transverse processes. This is the intertransverse ligament, and this is the superior from the lower rib. It passes to the top of the transverse process above. Therefore, it is called as the superior costotransverse ligament. Within that, we'll be able to see the multifidus muscle and rotatorus muscles. Certain times, levator costorum will also be visible here. This is how we perform a in-plane approach for the T5 sagittal paramedian after doing a sagittal paramedian scanning. We are doing a scanning at this level, at the level of the ligaments, intertransverse ligaments, and we'll be able to see the trapezius, rhomboidus, and then we are able to see the erector spinae, and this is the rib which we will be visualizing. Now we give a local anesthetic before proceeding with the block. We should pass the needle in such a way that it comes into contact with that of the transverse process. It is always helpful and it also helps in limiting inadvertently passing into that of the what to call paravertebral space and inadvertently injuring the lung in thin patients. For locating the, before giving the drug, we can do a hydrodissection and we can see whether whether we have approached the correct plane. Because if we keep on using the local anesthetic, we'll lose the total amount what we need to give at that time. Therefore, we have to do a hydrodissection. Two more minutes. Now we are able to see the drug being given and the erector spinae muscle being elevated from that of the transverse process, and there is a clear-cut drug spread which is visualized. What we can do is that to enhance the drug spread, we can give it rapidly and then we can proceed by dissecting the plane by advancing the needle into further anteriorly or superiorly or inferiorly, either way. Thank you.
Thank you, Gauri sir, for your excellent presentation. Next, I would like to invite Dr. Sindhil Kumar Mohan sir, Associate Professor, Government Medical College, Pudukkottai, to present his topic.
A very, should I say, good afternoon, probably getting late. A topic today for us is ultrasound guided paravertebral blocks. Though it's called as a paravertebral, it is purely a thoracic paravertebral blocks which we are going to deal with. Is there a lumbar? Is there a cervical? We'll discuss in the workshop. Okay, anybody can ask that out or remain me in the workshop. We'll discuss whether there is a cervical or a lumbar. We are going to deal only with thoracic paravertebral block. I thank my colleague and senior Dr. Ganesan sir in helping me this presentation. We will be coordinating in the workshops. So coming to the anatomy, this is the basic paravertebral space, which is actually the wedge-shaped space, which is bounded superiorly by the posteriorly by the superior costotransverse ligament and laterally by the pleura. The base of the wedge is formed by the vertebral body, the vertebral disc, and the intervertebral foramen. Okay, what you need to just listen to it. I think I thank Shankar probably for enlightening the anatomy regarding the paravertebral space. In fact, the paravertebral space was very much visible in those videos. We'll also see in the video subsequently. Right. The important point to note is this is being the space. You can see all the nerves are present here. Right. You're able to see this is the ventral rami or the intercostal nerves arising from the spinal cord. You can able to see the dorsal rami also passing the paravertebral space. You can also see the sympathetic chain or sympathetic ganglia. Meaning all three are present in this space. Meaning if you can deposit some amount of local anesthetic in this, it's almost like your unilateral, epidural, causing somatic and visceral analgesia, as well as anesthesia also. Okay? An important thing is it also communicates laterally with the intercostal space, medially with your epidural space. Okay? And also communicates with the upper and below or contiguous paravertebral spaces, meaning it provides good anesthesia as well as analgesia. Right? The content being the intercostal nerves or the anterior rami as well as with the vessels, with the sympathetic ganglia and the dorsal rami. So coming to the ligaments with regard to the paravertebral space, we need to learn the superior costotransverse ligament, which is marked in the blue, and the another ligament is the one in the orange color, that is your lateral costotransverse ligament. Right? This is the spinous process, lamina, costotransverse junction, this is the rib, and this is the orange color, which is your lateral costotransverse ligament, and this superior costotransverse ligament, you can see the shape, it transverses from the rib below to the transverse process above. This is the external intercostal muscle. If you remove this external intercostal muscle, you have the internal intercostal muscle, the intercostal membrane, which continues as the superior costotransverse ligament. Okay, this anatomy is very, very clear. This membrane continues as the SCTL or superior costotransverse ligament. And anterior to the superior costotransverse is the lung or the pleura. This is your paravertebral space. Can you see this space? Definitely you can see it, right? So you need to remember only the two ligaments. One is your superior costotransverse ligament, which forms the posterior border of the paravertebral space. And another is your lateral costotransverse ligament. It arises from the tip of the transverse process to the tubercle of the rib. So why I am emphasizing these two ligaments, we'll see in the subsequent slides. Coming to the what are the needs, prerequisites before you do a paravertebral scanning, definitely you need to have an ultrasound machine, and the probe you choose is usually a linear probe, right? Depends if the patient is too obese or having a thick paraspinous soft tissue, you can always go for a curvilinear probe. Depth, if it's crossing more than 4 centimeters, definitely you choose your curvilinear probe and adjust your focus regarding appropriately according to the depth. Coming to the position, usually advocated is the sitting lateral, but what we'll show in the workshop is your prone position, which we have been doing it for the past 1 month. It's so comfortable in needling, also comfortable for the patient. Only problem is you cannot do it when the patient is under, after giving anesthesia, especially after general anesthesia or a regional or after spinal, if you want to give for post-operative anesthesia. It's slightly difficult to put the patient prone, or otherwise you want to do it for anesthesia purpose, prone is the best, right? And ergonomics, this is your sitting position, operator, probe, machine, all in the same line, right? With regard to your lateral position, the same thing. Patient lateral position, which you want to get blocked, should be on the upper side, non-dependent side. And regarding a prone, operator, probe, machine, all in the same line, that's always going to provide you a good ergonomics and very comfortable for the patient as well as for the anesthetist. Coming to the needle issues, usually advised is your 2-eye needle in order to avoid inadvertent pleural puncture, and you can also use an echogenic needle also if available. And the end point of injection, when do you say it's end point? If there is a pleura down. The pleura gets down because of the deposition of your local anesthetic. So what are the views available? We are going to scan. We are going to scan the transverse view. We are going to do a paramedian sagittal view. We are going to do a paramedian sagittal oblique view. Telling workshop is only the first one, because it's very comfortable, very good analgesia. Definitely paramedian sagittal is also useful, but in my personal thing, transverse scan is very good for a beginner to do a paravertebral space because the needle orientation, needle visualization is very, very good. And this is the transverse view scanning. This is using a linear probe. This is using a curvilinear probe. You just start from the midline. That is the spinous process. And one important point I want to emphasize in thoracic vertebra is the spinous process is two angled downwards. So if you do the spinous process, if you just come laterally, the laminae will be the lamina of the vertebra below. Okay, it's not this spinous process, this lamina is not for this vertebra. This spinous process from the upper vertebra. So keep that in mind, especially if you want to particular about your level, right? The spinous process is usually the lamina will be just next below. So just scan laterally, get to the lamina. Usually the thoracic vertebral lamina is flat, unlike lumbar vertebra. So you have a flat lamina and you just go laterally, pick up your costo-transverse junction, meaning the junction between the rib and the transverse process. And after you picked up, just slide your probe. Don't tilt, slide. Okay, slide means just get it down. Get to your tip of the transverse process. You'll be able to see your pleura. Right? So this is your transverse section. The probe being kept in the skin in the posterior border. You are able to visualizing the tip of the transverse process. Since the tip obscures the view beyond, you will not be able to see the superior costotransverse ligament. So if superior costotransverse ligament is not seen, then how will you be able to approach the paravertebral space? You remember I said before, the internal intercostal membrane, which is continuation of the internal intercostal muscle, continues medially as your superior costotransverse ligament. So what will be targeting or visualizing in this transverse view will be only the internal intercostal membrane, not the superior costotransverse ligament. I repeat again, in transverse view, we will not be able to see your SCTL, we will be able to see only the internal intercostal membrane. Okay? Sometimes you'll be able to see the lateral costotransverse ligament, just forget about it. And what you're targeting is your apex of your paravertebral space. Right? This is a transverse process. Okay? This is the parietal pleura. This is your internal intercostal membrane. Beyond this point, this will continue as your superior costotransverse ligament. In this view, we'll be able to see only the internal intercostal membrane. We'll just pierce this and deposit the drug this. This is almost the apex of your paravertebral space. Okay? Now we are just going to do a scan. This is your spinous process. This is the flat lamina of the thoracic vertebra below, right? So this is your tip of the transverse process. Actually, just see, will be, this is your transverse process with the rib. I'm just sliding below, getting the tip of the transverse process. This is the parietal pleura. You'll be able to, can you see the line? This line is your internal intercostal membrane. Internal intercostal membrane. This continues medially as superior costotransverse ligament. So this internal intercostal membrane, you can definitely be able to visualize and deposit the needle here. So you can see again the tip of the transverse process, the parietal pleura, the needle in plane coming and just piercing your internal intercostal membrane. After you piercing, after giving you the drug, you can see this pleura will go down. That will be your end point of your paravertebral space injection. The needle tip, you can easily visualize it. After giving a local anesthetic drug, this pleura will come down. Just watch, the pleura is here, see, the pleura is coming down. This is your end point of injection. Coming to the next view, there is a paramedian sagittal view. In this, what you'll be seeing is you keep the probe in the back in a sagittal plane. Just you'll be able to see your your target is your transverse process above and below. In this view, you'll be able to see your superior costotransverse ligament and the paravertebral space with the contents. These are the two. How do you identify the differentiate between transverse process and the rib? Usually, the level of transverse process will be broad, right, like bumps, and your pleura will be less visible, unlike rounded rib borders with a very clear pleura. In this, still you are able to see a line, right? This line is your internal intercostal membrane, whereas this line is your superior costotransverse ligament. So what is the difference? Still you can give a drug here. Here it will cause only the intercostal nerve block, whereas if you want to have a paravertebral nerve block, you need to get your transverse process. We'll show all these in the workshop, just have an idea. Okay, this is a sagittal scan, able to see the broad transverse process. So this is your pleura. You can see a small white line, right? This line is there. That line is your superior costotransverse ligament. So needle can come from here, out of plane here or in plane from the ear. Okay, pierce this. This is your paravertebral space. This space is your paravertebral space. Now I'll just be scanning, going laterally in order to show you the difference between the ribs and the transverse process. See, the ligament is clearly seen very much. I'm just coming down. So this is your broad transverse process. See, this is the costotransverse junction. Okay, this is their rib, this is your transverse process. So this is we did an out of plane, my colleague Ganesan said did an out of plane, able to see the transverse process. This is slightly obese patient, that's why you're not able to see anything, but just watch for the pleura. See the pleura going down, right? This with experienced persons, definitely you can do it, okay? What are the advantages of doing a paravertebral block? It's considered a unilateral epidural, which is supposed to be the gold standard for any technique for analgesia and anesthesia. You can do it for surgical anesthesia for breast surgeries, chest wound exploration, good for post-op analgesia for thoracotomy, VATS, cholecystectomy, appendicectomy also. And we can do a single or multiple levels. If it's multiple level, it's around 4 to 5 ml for each level, depending upon the level you need for the planned surgery. You can also do a single shot paravertebral block or also keep a catheter. Are there disadvantages? Definitely. There's chance of vascular puncture, pleural puncture, pneumothorax, hypotension. All these incidences percentages are with landmark techniques. Definitely with the advent of ultrasound, these incidences very less. But the one problem is what we are bothered about is the pleural puncture. With the use of 2-eye needle, with a transverse view, with the needle visualization, this is very, very, very less. And all pleural punctures does not translate into pneumothorax. Keep it in that mind. Unless until you go and injure the lung, there is always a chance for a pneumothorax. And needle visualization, if there is difficulty, you can always do a hydrodissection using saline or 5% dextrose so that it's better. You don't waste your local. See that where your needle tip is, in which plane is this, your pleura is going down or not. Then after that you give your local anesthetic. And why it's not so popular? Because of the previous, all your presentations, because of easy alternatives or proxies, because of the so-called recta spinae, by your midpoint to transverse process to pleura block, or the intertransverse plane block, or the retrolaminar block, all terminologies are there. All these blocks wants to have the effect of paravertebral without doing a paravertebral. That's the main thing. My point is, do paravertebral, very well you can see it. Why you want to go for proxies? Definitely these proxies are useful in difficult case. That case which I showed you, slightly difficult, you're not able to see a needle. In those cases, these might be useful. In most of the patients, you'll be able to see your paravertebral space. To summarize, this is your transverse view. Get your transverse view here. Tip of the transverse process, pleura, internal intercostal membrane, deposit the drug. For sagittal view, transverse process, pleura, superior costotransverse ligament, and deposit the drug, paravertebral space. Thank you. I want to thank this person. He is my senior and colleague, Professor Dr. K. Chandran, who has been instrumental in guiding me in each and every step in the preparing this workshop as well as for this lecture. Thank you for a patient listening.
Thank you, Sendil sir, for your elaborate presentation. Next, I would like to invite Dr. Gurumurthy sir, Senior Consultant Anesthetist from Ganga Hospital, to present his topic.
Good afternoon, everyone. I think everybody is tired, so quickly we'll finish the lecture and go to the workshop session. Thank you for the wonderful opportunity. The team has organized very well, meticulously arranged CME. Special thanks to Dr. Balaji, who has been doing continuous work in each and every step. I'll move on to my topic, that is quadratus lumborum block. So some of the facts we have to know about the quadratus lumborum block. Again, it is a interfacial plane block, volume-based block. We have to give a good volume to reach our target. Whether we can do it without ultrasound, I don't think it is possible. Ultrasound is mandatory to get this block done. And whether we can use this block as a sole anesthetic. So again, so far few case reports, we have also tried in few cases where surgeon is going to harvest the iliac crust bone grafting. Only few cases we were able to succeed. So it is part of multimodal. So yet still we have to go a long way to achieve as a sole anesthetic block. So again, it is a part of multimodal, or it is a mainly analgesic block. Definitely we have to give bilateral, especially if the midline incision is done whenever needed. So what are the indications? Our blocks become useful only if we are going to use for patients after surgery when the postoperative pain is going to get relief. So a lot of indications you can see it in each and every abdominal surgery. About this our block for this QL block, and newer addition is regarding this total hip replacement, especially in a primary case. We cannot do it in when the patient comes for revision surgery, and small amount of literature is starting to creep about these lumbar spine surgeries also. Contraindication, definitely like any other routine block, only the special mention about this coagulopathy, we have to follow the ASRA guidelines whenever we are going deeper block. This is one of the QL block, is one of the deeper block, where around the QL block we can see the branches of lumbar artery. So there is a chance of puncturing those vessels. So when we go anterior to the QL especially, you have to follow the ASRA guidelines before embarking on this block. This is everybody described our traditional triangular petite approach, landmark based approach. So this is a video, as we have all the previous speakers mentioned. We are seeing the posterolateral aspect of the abdominal, posterolateral aspect of the back. So erector spine is very close to the spine, and these are all the abdominal wall muscles, external oblique, internal oblique, then transverse abdominis. Then our muscle of interest, that is quadratus lumborum block, which starts from iliac crest, and finally it is getting attached to the transverse process of the lumbar vertebrae. And we will see one more muscle, important muscle, that is anterior to the QL, that is psoas major. So if we identify these two muscles, this block is going to become successful. This is attachment of psoas major. So anterior muscle is psoas major, posteriorly is the quadratus lumborum. This we have to understand before giving this block. So repeating the anatomy. So incision is 12th rib and all the L1 to L4 transverse processes, and origin is from iliac crest. So this is a dissection. Once we remove all the vital organs and abdominal structures, we see the vertebra here. Then two important muscles we see in the lateral aspect is psoas major and iliac crest muscle. Once we remove the psoas, we can see the QL muscle here, and especially the lumbar nerve roots are emerging from especially in the upper lumbar nerve roots. So this is very important. While giving, we put the needle anterior to the QL. So we are putting the needle and giving drug. The drug is going to block the upper part of lumbar plexus. So there are a lot of understanding how this block works, because we are giving, putting the needle in the lumbar area. Finally, it is giving pain relief in the thoracic area. How it is possible? There are several mechanisms proposed. One of the mechanism is the drug is spreading along the thoracolumbar fascia. Okay, so we have to understand the, again, basic anatomy. Sorry. This is, we have to understand the three lumbar fascia. So this is anterior lumbar fascia, which is situated between the psoas major and anterior aspect of the QL muscle. Next one is middle thoracolumbar fascia between the erector spinae muscle and quadratus lumborum. Next, this is a posterior thoracolumbar fascia, which is in the posterior aspect of erector spinae. So this is very important to understand how the drug is being transferred from one area. So finally, to sum up how the drug is going to work, one is somatic component through the thoracolumbar nerves, and drug is going into the paravertebral area and blocking the visceral component. That is why it is better than TAP blocks. And we have seen the anatomy relation between psoas major and quadratus lumborum. That is where the lumbar nerve roots emerge. And finally, all the thoracolumbar fascia contain lot of receptors like methanoreceptors and nociceptive receptors. Those receptors are getting blocked and directly we are getting pain relief. So again, important understanding about this. This is the quadratus lumborum muscle. This is the anterior aspect, posterior aspect. Anterior aspect, we can see the ventral rove root. That is why apart from, there are different approaches we are going to deal in the next few slides. If you see, anterior works better because the ventral rami is best covered in an anterior approach. Of course, this is the lateral aspect where we are going to get the lateral approach. That is also ventral nerve root rami is coming. This is another one more understanding about how, again I told you in the previously, like we are giving a block in lumbar area, it is going to work in the thoracic area. Something called lift. Lift is lumbar interfacial triangle. This is the area. So this is an interfacial area where the aponeurosis comes and meets between thoracic, that TAP plane. It is a combined aponeurosis of this transversus abdominis and internal oblique. So sonal anatomy wise, this is corresponding to the posterior aspect of the quadratus lumborum. Again, to make it better understanding, this is the QL, that quadratus lumborum muscle. These are all the abdominal wall muscles, anterior abdominal wall muscles. Once it is a lateral aspect, this is a posterior aspect of the quadratus lumborum. Here we get the lift area. So these are the approaches. Previously the nomenclature was like 1, 2, 3 like that. The new nomenclature is only in relation to the muscle, like lateral, posterior or anterior. Even this transmuscular name is not used nowadays. So if you put the needle anterior to the QL, that is anterior QL. And if you put the needle here, it is posterior QL. And lateral to the QL, if you put this lateral QL. This subcostal will deal in next slide, few slides. Which position is better? Again, in thin patients, pediatric patients or thin adult, we can definitely go for the supine position. But lateral QL and posterior QL, or these approaches are easy to get it from supine. Especially you have to keep a wedge under the hip. But lateral position, lateral approach of QL, especially when you do it muscular adult or anterior QL, you have to cross the muscle, then lateral position is better. Sitting also practiced, especially in a chronic pain practice. Recently some of the literature are coming in the pain relief, lumbar back pain. To get the lumbar back pain relief, one of the approaches is this quadratus lumborum block. So this is ergonomics. We are going to put the probe in the lateral aspect of between the iliac crest and costal margin. Wedge is there, and operator has to stand on the side of the block, and machine you have to keep it in the opposite side. This is the lateral position. This is where we have to cover ergonomics. This is the sitting position ergonomics. And which probe to use? Again, linear probe can be used in thin adults and pediatric. Curvilinear probe, we have to use it in adult and lateral approach. So this is the sona anatomy. We see after once all the anterior wall abdominal muscle become aponeurotic, we see the fascia transversalis. Then we see the QL muscle here. This is the other approach where we get the Shamrock sign, which I will describe in next slides. This is the QL muscle, and we see psoas major and vertebral body. So this is only one of the important signs, it is called bunny sign or thumbs up sign. We see this is the ear of the rabbit. In the tip we see quadratus lumborum. In the front we see psoas major. In the back we see erector spinae. This is called the vertebral L4. You can compare with the zone anatomy. So why it is called samrak? Samrak is a tree. It contains a stem and 3 leaves. If you see this is a stem, that is a transfer process, and the tip is quadratus lumborum, and the other leaf is erector spinae here, and the one more leaf, the other side is psoas major. So which needle is best? Because we are not directly hitting the nerve, I think our routine practice is to use the spinal needle, even bigger size needle also. And other needle, preferred needle, where you want to see the ultrasound visualization of entire needle, we can use the stimulator needle also. Drug selection, again bupivacaine or levobupivacaine, since it is analgesic block, lower concentration can be used. Our choice is always ropivacaine 0.2%, since it is a high volume block. And again, you have to use at least 25 to 30 ml, so 0.3 to 0.4 ml per kg. So again, where to park the needle? This is very important understanding. I am putting this QL and psoas major here, and is it all our ultrasound machines, or all of us can, even senior people, whether we can identify these layers clearly? Is it not so? But to make it very simple, we are not supposed to inject inside the QL muscle, and we are not supposed to inject inside the psoas major. We have to park the needle above, in between. Is there any way to do it very easily? We can use the nerve stimulator needle indirectly. Whenever we put the needle inside the QL, that quadratus lumborum, direct muscle twitch comes. Again, if you pass the needle little more deeper, psoas major muscle, direct muscle twitch comes. It is not the nerve stimulation, direct muscle stimulation. So if you keep the needle in between, usually we are in our preferred area. Ideally, we are not supposed to cross the thoracolumbar fascia, because once you put the drug inside the before the thoracolumbar fascia, the drug spreads happening entire cranially caudal direction. This is another way to get that better this Shamrock sign. We have to put the kidney bridge, the way to open the space between the iliac crest and costal margin. So different types of QL we have compared in cadaveric studies. Which QL is, normally QL means it is covering from T7 to almost T12 or L1. But anterior QL is little more special, because it is covering the little upper lumbar area also, which is preferred in hip surgery and femur surgery. So as we talked about indications, the orthopedic indications alone, anterior plays a major role. Other all surgeries, we can see, except orthopedics, we can see any approach is better. So how to check the optimal spread? Number one, we have to identify the QL muscle. Then we can keep the probe in a transverse position, like longitudinal spread, how we are going to see. So we have to see the separation of this QL, identify the QL, then identify the psoas major, and we have to see the drug spread between the cranial caudal area, like this. So this is the foot end of the patient, where this is iliac crest you can see. Here, if you go a little more cranially, you can see the 12th rib. So this is lumbar, latissimus dorsi, and here, and we can see quadratus lumborum. Slightly thicker muscle, that darker muscle, that is psoas major. In between, you are going to check the craniocaudal spread of local anesthetic. This is a scanning video. So it's a linear probe scanning. We are starting from midline, rectus abdominis, anterior abdominal wall muscles we are seeing. Once you come towards the spine, we can easily appreciate, this is a 20 kg child, that's why we are able to see with linear probe, even little lateral position, not so pure lateral. Patient was given wedge-like support. Then the bulkier muscle we are seeing, that is QL. So this is psoas major, typical Shamrock sign, 3 leaves we are seeing. Another, this is curvilinear scanning, where we can see the abdominal wall muscles, and when we move the hip, when the patient moves hip, the QL muscle is moving, okay, which we will be again seeing in the next video. Next slides. So the whole success of QL muscle, the QL block depends on the identification of the QL muscle. Is it easy to identify in all patients? Sometimes it is difficult. So we have to follow some of the steps. That is, we have to identify the transverse process of the vertebra, which is where it is lying, and the muscle is relatively hypoechoic when compared to surrounding muscles majority of the time. And we have to trace the transversalis fascia. And there is another confusing factor is this peritoneal fat that we have to differentiate. Otherwise, we might be injecting the drug in front of or back of the peritoneal fat. And again, this muscle movement with hip joint that we have to see. See, this is the. So literature also described whenever the extension of the hip movement comes, this QL muscle moves actually. So one of the volunteer, we purposefully made him to abduct the hip. So if you keep seeing this muscle moves, that is the QL muscle. Probably it is because of the iliac crest attachment. Whenever the hip movement comes, the muscle moves. Okay. So this is the subcostal approach where we are going to keep the probe in a vertical direction so that we can see the craniocaudal spread. Again, subcostal scanning. So skin subcutaneous tissue. So we are trying to identify the muscles, the darker muscle, deeper muscle, that is psoas major. And we have to see the important structure, that is kidney. So when we have planning to give this in-plane technique, we have to be really careful. We prefer out-of-plane technique, this approach alone to prevent injury. And this is the latissimus dorsi muscle and the QL muscle. And we have to see the drug spread here and try to separate the QL muscle and psoas major. So this is our injection, real-time needle injection. First we are giving, trying to identify the anterior abdominal wall muscles. This is a wrong injection because it is going above the QL and above the transversalis fascia. Now we are trying to reach the lateral end. In fact, it is below the transversalis fascia. So it has become a transversalis fascia block. But our aim is this lateral QL. Lateral QL is, we have to reach this area. That is lateral part of the QL muscle. This is the anterior part, this is the lateral part. So this is posterior aspect, this is the anterior aspect of the QL muscle. This is the tip of the transverse process. We are trying to negotiate the needle so that the drug comes exactly in the lateral aspect of the QL muscle. Once we park the needle there and give the drug between the psoas major and especially we have to clearly identify the peritoneal fat, and the drug is going to the lateral aspect of the QL muscle. The good drug deposition you can easily identify like our routine any other drug deposition like downward approach. If the drug is deposition is clear and it is in the right place, even if you give lateral QL, the drug goes to the anterior aspect also. Okay. So this is again anterior QL block in a thin 20 kg child. We gave block with the transverse, that linear probe only. We are scanning from abdominal wall muscles and trying to identify that Shamrock sign, where we can typically see the 3 leaves muscles. Psoas major is here, rectus spinae is here, and QL muscle is here. And we are trying to come from in-plane technique. Once we reach the, we have to identify the 2 muscles, that is separation between this psoas major and quadratus lumborum. The drug is going to the anterior aspect of the QL, almost lateral to anterior aspect the drug is spreading. So complications, no block is without any complications, especially is a deeper block. Mainly we want to avoid the delay in discharge and delay in mobilization, because all these things are very important in orthopedics. So if you give the anterior approach of QL, there is a chance of blocking the lumbar nerve roots, and there's a chance of delay in mobilization, which mainly we are worried about quadriceps muscle weakness. Another one is sympatholysis. Already the patient is having hypotension. You are going to again give the drug which is going to deposit it in the sympathetic trunk, which can further reduce the BP. Bowel injury, if you are not careful enough in the lateral aspect, we can cross the peritoneal fat and go into the bowel injury. Another one is kidney injury, very, very important, especially right side. If you are doing block, right kidney is lower than left. We have to be really careful. And vascular injury, I think when we deal it with in the workshop scanning, you can see this aorta, great vessels and all. If you go very deep without seeing the needle tip, we can injure the greater vessels also. So few points about, is it better than TAP? Definitely, because it covers more dermatose than TAP with single injection. And it takes care of somatic pain as well as visceral pain because of the drug spread through the paravertebral space. And definitely it is better than fascia transversalis. Again, the lumbar spread is better with quadratus lumborum block, but it is a deeper block. Take home message, it is a deeper block. Once we learn all the superficial blocks, we have to embark in this quadratus lumborum block, and it potentially blocks both visceral pain and somatic pain. Right now, there is no perfect study to conclude which approach is better, but preferably QL3 is better if you are able to do, especially for hip surgeries. We have to be really worried about this volume whenever we give a large volume of drug, local anesthetic. So preferably, as the previous speaker mentioned, we have to use saline to identify and hydrodissect and confirm the needle tip. Then we have to proceed with entire volume block. Otherwise, we might lose all the volume before reaching the tip of the needle rightly in the right place. So QL3 may not be ideal in daycare because of the quadriceps weakness. All other surgeries, surgery, OBG and GA surgery, urological surgeries, QL1 and 2 is well enough. QL3 is for orthopedic procedures. Thank you for patient listening. One more small announcement I have, because our academic director is requesting to pass this information. We request you to vote for President-elect for Dr. Balavenkat. Thank you.
Thank you very much, sir. Excellent presentation and video demonstration, sir. Sir, I welcome Dr. Sadish Rajaselvam, sir.
Yeah, just 2 minutes. I think it's been a really heavy morning, right? There is so much information that's been conveyed from our side to your side. I'm not sure if there is any really, I'm not sure how much information has gotten across. But try and understand the story here. What's the main topic here? It's truncal anesthesia or analgesia, right? So if you look at the torso, except for this region, just below the clavicle, and the muscles of the anterior thorax, it's like superficial cervical plexus, medial lateral pectoral nerves, and some in the axilla, like nerve to serratus anterior and thoracodorsal nerve. Except for these contributions, the rest of the torso is contributed by thoraco-abdominal nerves, T2 to T12 and L1. L1 is like just lower to your T12, right? Simple. If you can manage to block these nerves, that means you are observing analgesia and anesthesia for your entire torso. For that to happen, you'll have to use a large volume of local anesthetic. Present day, it's not possible. Let us assume in 30-40 years down the line, we are going to invent a drug that's going to help us this kind of peripheral anesthesia analgesia. That's not going to happen, right? At our disposal, we have the capability to block these nerves at their origin, inside the neuraxis or at the periphery, by using a combination of blocks, right? Just try to understand each of these blocks from 2 angles, efficiency and their ability to cause complications. Just 2 angles. Keep the language very simple. In the neuraxis, extreme efficiency, but complication rates are very high. Hematoma, infections. As you go to the periphery, very minimal efficiency, but extreme safety, right? So, until the time where we have a really powerful drug that's going to give us only safety and extreme efficiency, we have to juggle with what we have, right? In this aspect, I have to say something about two blocks. One is the thoracic paravertebral, the other is the QL group of blocks. Because in this end of the spectrum, the blocks of the neuraxis, and in this end of the spectrum, we have the peripheral blocks, the facial plane blocks. Okay. Extreme efficiency, good number of complications, low efficiency, but no complications at all. Imagine if you can deliver a drug in this part which has the same efficiency as that is happening in the neuraxis. By their ability to involve the dorsal rami, ventral rami, and the visceral analgesia, the thoracic paravertebral and the QL group box tries to bridge the gap between these two kinds of blocks. Okay, so try and get this narrative as you're going to go through this, these workshops. Try and get this narrative. So when you go and practice in the future, you might be able to come to a better decision-making phase of your mind to reasonably come at a certain logical decision to conduct a safe anesthesia. That's all I wanted to say, and I hope we all have a good, productive afternoon. Thank you.
Thank you very much, sir. Any questions for any of the faculties? Any questions? So then we will move on to our workstations. So workstations are in the just one floor above this basement. So if you are marked as group A, please go to station 1. If you are marked as group B, go to station 2. C will go to 3, D will go to 4, E will go to 5, and F to 6. So please assemble there as soon as possible. We will try to accommodate 2 sessions. If it's not possible, we will do with 1, then we will move on to lunch, then we will start by 1:45. So lunch will be shortened by 15 minutes. So we will have 45 minutes lunch. Okay. So please assemble. Group A, go to station 1 like that. B to 2. Just one. So our volunteers are our BSc students. So please thank them whenever possible. So our college allied health BSc students are volunteers today.
The midline, exact level, எந்த டெப்த்தில் டியூரா இருக்கு, எந்த ஆங்கிளில் நம்ம வந்து ரெசல்யூஷன் கம்மியாக இருக்கும், அதை இம்ப்ரூவ் பண்ணுறதுக்கு தான் ஆஸ்க் யூ டு யூஸ் டிஹெச்ஐ, டிஷ்யூ ஆர்கோ இமேஜிங். ஸோ it's probably automatically switched on unless you want to switch it off. It is automatically switched on. அது இருந்தால் ரெசல்யூஷன் கொஞ்சம் நல்லா இருக்கும். So as I told you, there are 3 longitudinal views and 2 transverse views. And as I told you, probe பிடிக்கிறது வந்து இதில் வந்து இப்போ காமனாக நீங்கள் பண்ண நார்மல் effort is needed to stabilize the probe. Here, since you're keeping it horizontally, you'll have to make gel where it slipping. You'll have to make constant adjustments to have a stable image. So the first view will be, as like any other procedure, I preferably use my non-dominant hand to scan and use my right hand for intervention. So always marker cranially. So இப்போ பார்த்தீங்கன்னா the left side is cranial, right side is caudal. ஒரு 6 to 7 சென்டிமீட்டரில் இவனுக்கு இருக்கும்னு அப்ராக்சிமேட்டாக நம்ம சூஸ் பண்ணி நம்ம ஒரு 10 சென்டிமீட்டர் டெப்த் சூஸ் பண்ணியிருக்கோம். ஸோ தென் வி ஸ்டார்ட். ஸோ ஃபஸ்ட்டு வந்து பார்த்தீங்கன்னா ஸோ வாட் யூ சி, இப்போ ட்ரைடென்ட் மாதிரி தெரியுதா? ஸோ மேலே தெரியுது எரெக்டோஸ்பைனல் மசில், and acoustic shadows you see are cast by the transverse process, and in between the 2 transverse process you are able to see the transverse process, you are psoas major muscle. This is adukku mela that's the last transverse, that is the L5 transverse process. So eppadi adha vandu middle of the screen ku kondu vandinga, the the middle of the probe will be L5. Okay? So whatever is seen in the view will correspond to the middle of the probe. So that is how you will identify where the position. So if a first view is this, clear? The trans. இப்போ இன்னும் கொஞ்சம் ப்ரோப் மீடியலாக மூவ் பண்ணுறேன். நவ் இப்போ என்ன தெரியுது? நவ் இட் இஸ் அ கண்டினியூஸ் போன். கீழே அக்கோஸ்டிக் ஷேடோ எதுவுமே தெரியல பாருங்க. எலக்ட்ரோஸ்பைனல் மசில் தெரியுது. அதுக்கு கீழே யூ சி அ கண்டினியூவல் ஆஃப் தி ஆர்டிகுலர் ப்ராசஸ். எல்லா ஆர்டிகுலர் ப்ராசஸ். ஸோ அங்கே வந்த பிறகு யூ டில்ட். இப்போ what is the camel? This is not the camel arm. This is the horse head. இப்போ பார்த்தீங்கன்னா this is the head of the horse. Okay? This is the interlaminar window. If you don't mind. Okay? So இங்கே நீங்கள் இப்படி பார்க்கறது what you are seeing is the sloping lamina. That is what you are seeing here. And the anterior complex and the posterior complex. இப்போ நீங்கள் you can even measure. இப்போ அப்ராக்சிமேட்டாக இதான் நம்ம posterior complex தான் நம்மளுடைய target. So you can see anterior complex is thicker. இப்போ நான் மெஷர் பண்ணணும் அப்படின்னா I can approximate skin level. The approximate distance is around 5.1 centimeter approximate. So நம்ம பண்ணும்போது இதில் என்னன்னா ஒரு 10% ஆட் பண்ணிக்கலாம். ஏன்னா நான் கம்ப்ரெஷன் நான் கொடுக்குறேன். ஸோ டிஷ்யூஸ் ஆர் கம்ப்ரெஸ்டு. ஒரு 10%னா இதில் ஒரு 5 mm, 5 centimeterல 10% is 5 mm. So 5.5 centimeter. So that will be the distance beyond which you should not try to pass in your needle. So this is the horse head appearance of the parasagittal oblique view. So next we are going for the spinous process view. So இப்போ வந்து always prefer to have on the right side of the patient. The marker on the right side. இப்போ பார்த்தீங்கன்னா there is nothing seen here. இல்லையா? ஸ்பைனஸ் ப்ராசஸ் இருக்கு. இது ஸ்பைனஸ் ப்ராசஸ் நேரோவாக விடுது. அதுக்கப்புறம் இங்கே லேமினா வந்து ஃபுல்லாக இட்ஸ் ஷேடோயிங். ஸோ திஸ் இஸ் அட் த மிட் லைன். ஸோ இப்போ என்னன்னா ரெண்டு எரெக்டார் ஸ்பைனே ஷார்ட் ஆக்சிஸில் பார்க்குறோம். ஸோ இப்போ மை ஐடியா இஸ் இப்போ இதை வந்து சென்டரில் வரணும். எம்மோட் ஆக்டிவேட். ஓகே. ஸோ இப்போ பார்த்தீங்கன்னா clear. இல்லை I just want வெறும் எம்மோட் மட்டும் போகும். சரி எடுத்துருங்க. ஸோ approximately I brought it to the center. தெரியுதா? spinous process casting a shadow. the ரெண்டு lamina is casting a bigger shadow. so sound does. ஸோ ஒரு ஸ்பேஸ் நான் கீழே வரேன். அந்த ஸ்பைன்லேருந்து அப்படியே இறங்குறேன். இப்போ என்ன தெரியுது? சி இங்கே இன்டர்ஸ்பைனஸ் ஸ்பேஸ். இது ரெண்டு ஹம்பும் ஆர்டிகுலர் ப்ராசஸ். இந்த ஃபெசட் ஜாயிண்ட்ஸ் நான் சொன்னேன் இல்லையா? அந்த லெவலில் தான் யூ ஹேவ் தி ஈக்குவல் டு சைன். யூ ஹேவ் தி posterior complex and the anterior complex. So in between you have it's dark because CSF fluid, it appears dark. So this is the transverse process view. So இப்போ நான் என்ன பண்ணுறேன்? once I get this view, இப்போ இந்த வியூ கிடச்சிருச்சு எனக்கு. ஓகே, சிம்மெட்ரிக்காக இருக்குது. ரெண்டு சைடு ஆர்டிகுலர் ஃபேசட் சிம்மெட்ரிக்காக இருக்குது. ஸோ நான் என்ன பண்ணுவேன்? ஐ வில் ட்ரா அ மார்க்கர் திஸ் சைட், அ லைன் திஸ் சைட், அ லைன் ஆன் த டாப். ஒன்ஸ் ஐ டேக் இட் அவுட், கனெக்ட் ஆல் தீஸ் திங்ஸ், ஐ வில் ஃபைண்ட் அவுட் தி எக்ஸாக்ட் சென்டர். இப்போ பாருங்கள், ஒன்று ரெண்டு விஷயம் இதில் ட்ரான்ஸ்ஃபர் தெரியுது. இப்போ அப்ராக்சிமேட்டாக 5 சென்டிமீட்டரில் இது இருக்குது. அண்ட் இப்போ வந்து ஆங்கிள் ஆஃப் இன்சர்ஷன் பாருங்கள். நான் இப்போ கெஃபலாய்டாக கொடுத்தா டியூரா நல்லா தெரியுதா? நீடில் கெஃபலாய்டாக தெரியல. ட்ரான்ஸ்வர்ஸ் பர்பெண்டிகுலராக வைக்கும்போது நல்லா தெரியுது. ப்ரோபை கார்டராக டில்ட் பண்ணால் அகைன் சரியாக தெரியல. ஸோ த ஆங்கிள், த போஸ்டீரியர் அண்ட் தி அண்ட் ஸோ த போஸ்டீரியர் காம்ப்ளெக்ஸ், ஆன்டீரியர் காம்ப்ளெக்ஸ் ஆர் எந்த ஆங்கிள் ஆஃப் ப்ரோப் ஹோல்டிங்கு நல்லா தெரியுதோ தட் வில் பி யோர் நீடில் இன்சர்ஷன். ஸோ எவ்வளோ டீப்பாக போகணும், எவ்வளோ எந்த ஆங்கிளில் போகணும், அது ரெண்டு இன்ஃபர்மேஷன் உங்களுக்கு கிடைக்கும். இப்போ சப்போஸ் பேஷண்ட்டுக்கு ஸ்பைன் ரொட்டேட்டடாக இருக்குது அப்படின்னா நான் என்ன பண்ணுவேன், இப்போ சப்போஸ் ஒரு இப்படி இருக்க வேண்டிய ஸ்பைன், இப்போ இவனுக்கு இப்படி இருக்க வேண்டியது கொஞ்சம் இப்படி இருக்குது, கொஞ்சம் ஸ்கோலியோட்டிக்காக இருக்குது. என்ன பண்ணுவேன், நான் இப்போ ப்ரோப் வச்சேன்னா சிம்மெட்ரிக்காக வராது, நான் இப்படி வச்சேன்னா சிம்மெட்ரிக்காக வராது. ஸோ நான் என்ன பண்ணணும், எவ்வளோ ரொட்டேஷன், இப்போ ஃபார் எக்ஸாம்பிள் ஒரு 10 டிகிரி, இந்த 10 டிகிரி என் ப்ரோபை ரொட்டேட் பண்ணேன்னா, இப்படி திருப்பினேன்னா இமேஜ் கிளியராக வரும். ஸோ தட் வில் பி மை நீடில் இன்சர்ஷன். ஸோ தட் இஸ் ஹவு யூ ஃபைண்ட் இட். வாட் எவர் மேபி த ஸ்பைன் ரொட்டேஷன், நீங்கள் உங்கள் ப்ரோப் அட்ஜஸ்ட் பண்ணி சிம்மெட்ரிக் இமேஜ் கொண்டு வரும் ஆன் தி ஸ்க்ரீன். And then you will know what is the depth and at what angle you have to insert. அவ்வளோதான், சிம்பிள். இப்போ ஸ்பேஸ் கவுண்ட் பண்ணணும். எனக்கு டிஃபிகல்ட்டாக இருக்குது, ஸ்பைன் கிடைக்கவே இல்லை, மேலே எங்கெங்கேயோ ட்ரை பண்ண. யூஸ்வலாக நம்ம பார்த்தீங்கன்னா நீங்கள் ஸ்பைனல் போடுறீங்க, ஸ்பைன் டிஃபிகல்ட்டாக இருந்துச்சு, என்ன பண்ணுவீங்க, எதர் யூ சூஸ் அ லோவர் லெவல் ஆர் கோ டு ஹையர் லெவல். மோஸ்ட் 10 people tend to go to higher level, ஜென்ரலாக அது. பட் நமக்கு வந்து இப்போது பிகாஸ் நமக்கு தெரியாது எங்கே இது இருக்குன்ட்டு ஸ்பேஸை பார்த்தீங்கன்னா ஸ்கேனிங் ஃப்ரம் பிலோ. ஸோ வாட் இஸ் திஸ்? ஏன் சேர்க்கிறோம் சொன்னீங்க? வெரி குட். ஆப்வியஸ்லி கண்டினியூஸ் லைன்ஸ் சேர்க்கிறோம். அதில் வந்து மேலே வரும். நான் சேர்க்கிற பேராசைட்ஸில் ஒப்ளிக் வச்சிருக்கேன். ஸோ த ஃபர்ஸ்ட் பிரேக் இஸ் தி L5S1 space. தெரியுதா? So அது mid point இங்க இருக்கு. So I will try to catch the L5. I will try to catch the L5S1 space and do the needling. Again this is a spine. This is dura. சரியா? So this is how you calculate. பாருங்க எவ்வளோ பெருசாக இருக்குது பாருங்கள் ஸ்பேஸ். ஸோ இட்ஸ் இன்ஃபேக்ட் யூ கேன் சி தி ஆன்டீரியர் காம்ப்ளெக்ஸ் ஹியர், தி போஸ்டீரியர் காம்ப்ளெக்ஸ் இஸ் ஹியர். ஸோ இட் இஸ் வெரி ஈஸி. இதை இப்போ மிடில் ஆஃப் த ஃபீல்டில் இருக்குது. ஸோ இந்த இடத்துல தான் L5S1 ஸ்பேஸ் இருக்குது. ஸோ அங்கே வச்சு இது ஒரு L5S1 ஸ்பேஸ் இருக்குது, அப்படியே வச்சு இது போட்டுற முடியும். இப்போ இதுக்கு கொஞ்சம் மேலே போனால் சேர்க்குறோம், சாரி L5, அதுக்கு மேலே போனால் கீழே வந்தால் சேர்க்கணும், இது சேர்க்கணும். ஸோ தட் இஸ் ஹவு யூ கவுண்ட். வேர் வென் யூ வாண்ட் ஸ்பெசிஃபிக்கலி டு டெபாசிட் இன் தி நெசசரி ஸ்பேஸ். சி another thing is உங்களுக்கு மேல் ஸ்பேஸை we are finding it difficult. Immediately try to go for the L5S1 interspace. Usually it is the largest space, easily will be accessible. சரியா? டவுட்ஸ் இருக்கா ஏதாவது? இல்லை, அதாவது பேராமீடியன் சாஜிட்டல் நான் சொன்ன மாதிரி சாஜிட்டல் வியூஸ் ஆர் யூஸ்வலி யூஸ் டு கவுண்ட். ஒன்று டு பி வெரி ஸ்பெசிஃபிக் அட் வாட் லெவல் வி ஆர்னு ஒன்று தெரிஞ்சுக்கலாம். இன்னொன்று ரியல் டைம் அல்ட்ராசவுண்ட் கைடன்ஸில் நீங்கள் பண்ணும்போது பேராசனல் ஒப்ளிக் வந்து வில் பி அ குட் ஆப்ஷன். நம்ம டிரான்ஸ்வெர்சியூவில் வச்சு போட முடியாது. நீங்கள் பேராமீடியன் சாஜிட்டலில் வச்சுட்டு எய்தர் ஷார்ட் மீன் அவுட் ஆஃப் பிளேனோ இன் பிளேனில் யூ கேன் அட்டம். அதுதான் சொல்கிறேன். சி இட் இஸ் நாட் மேண்டேட்ரி தட் யூ ஹாவ் டு கோ சீக்வன்ஷியலி த்ரூ ஆல் தி ஸ்டெப்ஸ் டு ஃபைண்ட் அ ஸ்பேஸ். ஸோ உங்களுக்கு வந்து அப்போ ஒரு லோவர் லெங் ப்ரொசீஜர் எனக்கு ஸ்பேஸில் ஜஸ்ட் வாண்ட் டு புட் இருந்தீங்கன்னா யூ கேன் டைரக்ட்லி கோ ஃபார் யுவர் ட்ரான்ஸ்வர்ஸ் வியூ. ட்ரான்ஸ்வர்ஸ் வியூ நீங்கள் வைக்கிறீங்க, இது வந்து ஸ்பைனை கொஞ்சம் இறக்குறோம், இது வருது, அவ்வளோதான். அதை தான் சொல்கிறேன். இப்போ வந்து ஆமாம், இப்போ இங்கே ஒரு லைன், இதில் இந்த மிடில் ஆஃப் த திக்னஸ் ஆஃப் த ப்ராப்ளம் மிடில் ஒரு லைன், இந்த பக்கம் மிடில் ஒரு லைன், சென்டரில் ஒரு லைன் போட்டுட்டு இதை எடுத்துகிட்டு மூணையும் கனெக்ட் பண்ணால் அந்த இன்டர்செக்ஷன் பாயிண்ட் இருக்குல்ல, தட் இஸ் யுவர் நீடில் இன்செர்ஷன் பாயிண்ட். அண்ட் எந்த ஆங்கிளில் டியூரா, இப்போ இந்த ஆங்கிளில் தான் 2 டியூராவும் நல்லா தெரியுது. ஸோ இதான் நீடில் இன்செர்ஷன் பாயிண்ட். அதே இது சப்போஸ் எனக்கு இப்படி கொஞ்சம் கார்டல் டில் கிரேனியல் டில் கொடுக்கும்போது தான் நல்லா தெரியுது அப்படின்னா that will be my needle insertion. அதாவது ஃபுல் பல்கி இண்டிவிஜுவல் வேறு எதுவுமே ஸ்பேஸே தெரியல, நம்மளுக்கு பால்பேட்டும் பண்ண முடியல, அந்த மாதிரி சமயத்தில் யூ மைட் இட் வில் கிவ் யூ ரியல் வேல்யூபிள் இன்ஃபர்மேஷன். அதனால் நீங்கள் ஃபஸ்ட்டு இது பண்ணும்போது க்ளவ் போட்டுட்டு எய்தர் 2 டெக்னிக் இருக்குது, இப்படி பண்ணலாம் டு கெட் அ ஸ்டேபிள் இமேஜ். மிட் லைனில் 2 டியூராவும் நல்லா தெரியும். இல்லைனா இப்படி பண்ணலாம், இப்படி பண்ணலாம். 2-handed டெக்னிக் இனிஷியல் அப்படி பண்ணிங்கன்னா இதாக இருக்கும். Ultimately, this is what we want finally, the bad sign. The ரெண்டு articular process அந்த லெவலில் போஸ்டர் காம்ப்ளெக்ஸ் அண்ட் ஆன்ட்ரியர் காம்ப்ளெக்ஸ் பார்த்துட்டிங்கன்னா நீங்கள் நீடு. சரிங்களா? ஓகே. சி ப்ராப்ளம் இஸ் இதுலேயே கூட நம்மளால் டியூராவும் லிகமெண்ட்லையும் டிஃபரன்ஷியேட் பண்ண முடியாது. Maybe with very high-end machines, the subtle tissue movements during an epidural catheter movement, I mean insertion can be seen. But personally, I have not. It's not necessary also to see the catheter being threaded into the epidural space. இப்போ இருக்கிற இதில் வந்து இல்லை அது இதில் கன்ஃபார்ம் பண்ணுறது இஸ் வெரி வெரி டிஃபிகல்ட். பிகாஸ் see this is all the epidural space is somewhere here inside. Ligamentum flavum, dura, தான் நமக்கு லிகமெண்ட் காம்ப்ளெக்ஸாக தெரியுது. மேபி 1 out of 10 individuals in extremely high, very good sensitive machines, you might see them as 2 layers with the epidural space in between. Okay, so இதில் வந்து it's not necessary to see the epidural space. நீங்கள் வந்து அந்த ஸ்கின் டு டியூரல் காம்ப்ளெக்ஸ் லிகமெண்ட் இதை மெஷர் பண்ணிவிட்டு you can do நான் காமிக்கிறேன். படுத்துக்கோ லெஃப்டில் படுத்து அப்போ பண்ணுவேன். நல்லா 2 காலையும் மடக்கி வயிற்றுக்கிட்ட கொண்டு வா. கொஞ்சம் இன்னும் கொஞ்சம் என்ன நோக்கி வா, என்ன நோக்கி வா. இப்போ இதில் என்ன பண்ணுவோம்னா யூஸ்வலாக திஸ் டுவர்ட்ஸ் அ கிரேனியல் எண்ட் என்ன பண்ணலான்னா யூ கேன் இப்போ பார்த்தீங்கன்னா இப்போ கிரேனியல் எண்டில் நான் டியூரா பார்க்குறேன் இல்லையா? left is cranial, right is caudal pa, the posterior complex, anterior complex. So I am holding the probe in an oblique manner such that the cranial end is looking into the space. சரியா? இது lamina, posterior complex, இது anterior complex. So இப்போ வந்து in plane I can insert my needle from this side. The needle will come and target this point. இங்க இருந்து இது வரைக்கும் உங்களோட needle travel in plane. But இது actually easier said than done actually, because ஒரு இதில் ஸ்டேபிள் நீடு இதை வச்சுட்டு இன்னொரு இதில் நீடில் அது கூட if you try to use a fine gauge needle it will be very difficult. அதாவது hand eye coordination ஈஸியாக இருக்காது. இப்போ I have tried using a 23 gauge needle which will not bend during அப்போ you can see the needle going. Epidural will be technically difficult because நீங்கள் LOR பார்க்கணும். ஒரு கை ப்ரோபில் ஹெல்டப் ஆகிடுச்சு. ஸோ அங்கே என்ன பண்ணலான்னா வாட் வி டூ இஸ் ஹைப்ரிட் மாதிரி கிட்ட கொண்டு போயிட்டு அப்புறம் லாஸ்ட் மினிட்ல அந்த கிட்ட நீல் டிப்பை அதுக்கிட்ட ப்ளேஸ் பண்ணிவிட்டு ப்ரோப் எடுத்துகிட்டு நீங்கள் LOR பார்த்து புஷ் பண்ணலாம். ஃபியூ ஆஃப் யூ கேன் ட்ரை. உட்காந்துக்கோப்பா. ரியல் டைம் கைடன்ஸில் பண்ணுறது ஃபியூ கேன் ட்ரை. உதய் நீ ஒரு கொஞ்சம் பேர் அங்கே அதில் பண்ணுங்க. ஸோ தட் ஆல் ஆஃப் யூ கேன் கெட் அ சான்ஸ். இல்லை அதான் தெர் ஆர் லிமிட்டேஷன்ஸ். ஃபுல்லாக இப்போ ஆங்கிலோசிங் ஸ்பாண்டிலைட்டிஸ் இதில் ஃபுல் இது லிகமெண்ட் காம்ப்ளெக்ஸ் கால்சிஃபை ஆகிடுச்சுன்னா வில் நாட் கெட் அ விண்டோ. எதுலேயுமே தெரியாது, எந்த இதுலேயுமே தெரியாது. எக்ஸ்ட்ரீம் ஆங்கிலோசிங் இப்போ 85-90 இயர்ஸில் வர்றாங்கல்ல சம்டைம்ஸ், the entire thing will be calcified. Ligament of எதுவும் உங்களுக்கு bone ligament அந்த நமக்கு differentiate பண்ண முடியாது. Of course there is a ஒரு population where sound waves may not gain access at all. இப்போ thoracic-ல வந்து இதே தான், பட் லம்பார் லாமினா வந்து நல்ல ஸ்லோப்பிங்காக இருக்குது, இது ஃப்ளாட்டாக இருக்கும் அவ்வளோதான். See, in transverse view in spine is impossible because of the overhanging spinous process. Transverse viewல நீங்க டியூரா பார்க்கவே முடியாது. பட் டெஃபினட்டா interlaminar window in parasagittal oblique view நல்லா இருக்கும். டிஃபிகல்ட்டி ஒபீஸில் வந்து மை எக்ஸ்பீரியன்ஸ் வந்து நான் எக்ஸ்ட்ரீம் ஒபீஸை தொராசிக் எபிடியூரல்ஸ் ட்ரை பண்ணதில்லை. வந்து இதுதான் சிட்டிங் உட்கார வச்சு ஃபுல்லாக மார்க் பண்ணிவிட்டு தென் we do the 8 சென்டிமீட்டர் அந்த மாதிரிலாம் இருந்துச்சுன்னா நம்மளுக்கு இது பராது. அப்போ வந்து வி யூஸ் இட் எக்ஸ்ட்ரா லாங் ஸ்பைன் 12 சென்டிமீட்டர் நீடில். பட் ஆனால் ப்ராப்ளம் 12 சென்டிமீட்டர் நம்மக்கிட்ட அவைலபிள் வந்து 22 கேஜ் பிளாக் நீடில். அது கொஞ்சம் கேஜ் கொஞ்சம் பெருசாக இருக்கும். இல்லை ஆங்குலேஷன் நீங்கள் ப்ரோப் வைக்கிறீங்க, நீங்கள் ப்ரோப் வைக்கும்போது எந்த ஆங்கிளில் டியூரா உங்களுக்கு தெரியுதோ அந்த ஆங்கிளில் நீடில் பாஸ் பண்ணும். அதுதான் கீ. ஸோ எல்லா வியூவும் தெரிஞ்சு வச்சுக்கணும். சுச்சுவேஷனுக்கு தகுந்த மாதிரி நீங்கள் வந்து இப்போ சீக்வன்ஷியல் ஸ்கேனிங் இஸ் ஆல்வேஸ் சேஃப். நீங்கள் இனிஷியலாக வென் யூர் பிகினிங் பொறுமையாக பண்ணலாம். ஒரு ஹேர்னியாக எலக்டிவ் இன்குவானல் ஹேர்னியாக ஸ்பேன் போடுறீங்கன்னா அப்போ யூ கேன் பொறுமையாக நீங்கள் ட்ரான்ஸ்வர்ஸ் பாஸ் வச்சு லெவலில் கவுண்ட் பண்ணி வியூ பார்த்து அப்புறம் பேராசைட்டிக் ஒப்ளிக் பார்த்து ட்ரான்ஸ்வர்ஸ் ஸ்பைனஸ் ப்ராசஸ் வியூ இன்டர்ஸ்பைனஸ் வியூ பார்த்து டெப்த்தை மெஷர் பண்ணி அதில் வர மாதிரியே போட்டு நீங்கள் பண்ணலாம். ஒரு 10 கேசஸ் நீங்கள் பண்ண பிறகு உங்களுடைய ஸ்பீட் வித் விச் யூ ஐடென்டிஃபை த ஸ்பேஸ் அண்ட் டூ த ப்ரொசீஜர் உங்கள் ப்ரொசீஜர் டைம் ஷார்ட் ஆகிட்டே வரும். ஆமாம். இப்போ ட்ரைடென்ட் வந்து ட்ரைடென்ட்லேருந்து அப்படியே மூவ் பண்ணணும். இப்போ மீடியில் அப்படியே மூவ் பண்ணணும் ட்ரைடென்ட்லேருந்து மீடியல். இல்லை நீ ஆங்குலேட் பண்ணுறல்ல, ஆங்குலேட் பண்ணாத, அப்படியே மூவ் பண்ண, அப்படியே மூவ் பண்ண. இது இப்போ கண்டினியூஸ் ஹம்ப். இப்போ இங்கேருந்து டில்ட் பண்ண, இங்கே டில்ட் நீ இப்போ டில்ட் பண்ண உடனே ஹார்ஸ் ஹெட் வந்துருச்சு. லேமினா ஆன்டீரியர் காம்ப்ளெக்ஸ் போஸ்டீரியர் காம்ப்ளெக்ஸ், சாரி போஸ்டீரியர் காம்ப்ளெக்ஸ் ஆன்டீரியர் காம்ப்ளெக்ஸ். இப்போ அப்படியே ட்ரான்ஸ்வர்ஸ் அவை நீ வச்சுருக்கதே ஆக்சுவலாக ஸ்பேஸில் தான் வச்சுருக்கேன். ஸ்பேஸில் வச்சுருக்கேன். ஸோ 2 ஆர்டிகுலர் ப்ராசஸ் சிமெட்ரிக்காக இருக்குது. இன்டர்ஸ்பைனஸ் லிகமெண்ட் தெரியுது, ஆன்டீரியர் காம்ப்ளெக்ஸ் போஸ்டீரியர் காம்ப்ளெக்ஸ். இப்போது ஒரே எக்ஸாம் தொராசிக் கேட்டிங்கல்ல. இப்போது தொராசிக்கில் பார்த்தீங்கன்னா ட்ரான்ஸ்வர்ஸ் வியூ எப்படி இருக்குது, ட்ரான்ஸ்வர்ஸ் ப்ராசஸ் வியூ. அப்படியே இன்னும் கொஞ்சம் வந்து ஆர்டிகுலர் ப்ராசஸ் வியூ. இப்போ ரொட்டேட் பண்ணுறேன். இப்போ பார்த்தீங்கன்னா அங்கே லேமினா நல்லா ஹார்ஸ் ஹெட் மாதிரி இருந்துச்சு. இங்கே வந்து ஃப்ளாட் லேமினா இருக்கும். பட் ஸ்பேஸ் தெரியுதா? ஆன்டீரியர் போஸ்டீரியர் காம்ப்ளெக்ஸ் டிஃபரன்ஷியேட் பண்ண முடியுதா? காமிங்க பார்ப்போம். சம் ஆஃப் யூ ஷோ மீ. எஸ், போஸ்டீரியர் அண்ட் ஆன்டீரியர். ஸோ ஸ்கின்லேருந்து எவ்வளோ டிஸ்டன்ஸில் இருக்குது நீங்கள் அதை மார்க் பண்ணிக்கலாம். மிட் பாயிண்ட் இதில் மார்க் பண்ணிவிட்டு அப்ராக்சிமேட்டாக அந்த இதில் என்டர் பண்ணலாம். டிஸ்டன்ஸ் விட உங்களுக்கு அந்த அந்த ஸ்பேஸ் பிட்வீன் த 2 லேமினா வந்து வில் பி வெரி வெரி நேரோ. பிகாஸ் ஃப்ளாட் லேமினா, ஓவர் ஹேங்கிங் ஃப்ளாட் லேமினா இருக்கிறதுனால யூ வில் ஃபைண்ட் இட் டிஃபிகல்ட். ஆக்சுவலாக அதான் சொல்கிறேன், யூ ஹாவ் டு மாஸ்டர் திஸ் ஃபர்ஸ்ட் பிஃபோர் வென்ச்சரிங் இன் டு தொராசிக் ஏரியா. லோ தொராசிக் ஆல்சோ ஆல்மோஸ்ட் லைக் லம்பார் கொஞ்சம் இது பண்ணலாம். பட் மிட் அண்ட் ஹை தொராசிக் வந்து பி டெக்னிக்கலி வெரி டிமாண்டிங். அவுட் ஆஃப் பிளேனும் நான் பண்ணியிருக்கேன், இன் பிளேனும் பண்ணியிருக்கேன். பெட்டர்னா ஆல்வேஸ் இன் பிளேன் தான். மை ப்ரிஃபரன்ஸ் இஸ் ஆல்வேஸ் இன் பிளேன். இல்லை இது லேட்ரல் பேஷண்ட்டை லெஃப்ட் லேட்ரலில் போட்டுட்டு ஒரு ஒப்ளிக் வியூ காமிச்சேன் இல்லையா, மிட் கிரேனியல் வந்து மிட் லைனில் இருக்கும். மிட் லைனில் வச்சுக்கிட்டு கார்டல் எண்ட் ஆஃப் த ப்ரோபை வந்து கொஞ்சம் லேட்டரலாக வச்சுக்கிட்டு ஒரு எண்டில் அந்த கிரேனியல் எண்டில் மட்டும் டியூரல் காம்ப்ளெக்ஸை பார்க்க, ஆன்டீரியர் போஸ்டீரியர் டியூராவை பார்த்துட்டு அதுக்கு நீடில் எய்ம் பண்ணணும். அப்படியே நீடில் அப்படியே போடுற அப்படியே இன் பிளேன். உங்கள் ப்ரோப் எந்த இதில் இருக்கோ அப்படியே நீங்கள் அப்படியே போகணும். பட் என்னென்னா இப்படி நீடில் ப்ரோபை இப்படி வச்சுட்டு நீங்கள் ஒரு பிளாக் இப்படி பண்ணுறது இஸ் ஈஸி பிகாஸ் தெர் இஸ் நாட் மச் எஃபர்ட் ஆன் யுவர் லெஃப்ட் ஆர்ம். பட் ப்ரோபை இப்படி லெஃப்ட் ஆர்மில் பிடிச்சிக்கிட்டு ஒரு என்டையர் இன் பிளேனில் நீடில் ட்ராஜெக்டரியை வந்து நம்ம ட்ராக் பண்ணுறது ஒரு நெக்ஸ்ட் லெவல் ஆஃப் ஒரு ஸ்கில் செட், வந்து ஒரு அடுத்த லெவல் ஸ்கில் செட்டு. ஸோ கொஞ்சம் அந்த ஃபேண்டம்ஸ்லாம் ப்ராக்டிஸ் பண்ண அது வரும். டில்ட் பண்ணாதீங்கப்பா. ட்ரான்ஸ்வர்ஸ் ப்ராசஸ்லேருந்து மூவ் மீடியலி. ட்ரை டு கெட் த கண்டினியூஸ் லைன், தென் நவு டில்ட் மீடியலி. நீங்கள் இப்போவே ஒரு மிடில் டில்ட் கொடுத்துட்டீங்க. ஏன்னா போஸ்டர் காம்ப்ளெக்ஸ் தெரியுது பாருங்கள், ஐ மீன் ஆன்டீரியர் காம்ப்ளெக்ஸ் தெரியுது பாருங்கள். தெரியக்கூடாது. ஏன்னா நம்ம இன்டர்லாமினார் விண்டோவே பார்க்கல, நேராக வெறும் போன்ஸ். நீங்கள் பர்பண்டிகுலராக உங்கள் சவுண்ட் வேவ்ஸ் வந்து ஆர்டிகல் ப்ராசஸ் அடிச்சிச்சுன்னா ஹம்ப்ஸ் மட்டும்தான் இருக்கும், கண்டினியூஸ் லைன் ஆஃப் போன் இருக்கும். ஐடியலாக என்ன பண்ணுங்க, பேஷண்ட்டு டேபிளில் உட்கார வச்சுக்கோங்க, பேஷண்ட் லெஃப்டில் மெஷின் வச்சுக்கோங்க, வச்சுட்டு டூ த மார்க்கிங். சம்டைம்ஸ் இட் வில் ஃபெயில். நம்ம எல்லாம் கரெக்டாக பண்ணியிருப்போம், பட் நம்ம மார்க்கிங் சரியாக விழுந்திருக்காது, இல்லை நீங்கள் வாஷ் பண்ணுறதுக்குள்ள பேஷண்ட் மூவ் பண்ணியிருப்பான். சம்டைம்ஸ் இட் கேன் ஃபெயில், பட் அகெயின் யூ ஹேவ் டு கீப் டூயிங் இட் ஓவர் அண்ட் ஓவர் அண்ட் மேட்டர் ஆஃப் ப்ராக்டிஸ் தான். இது வந்து ஒப்ளிக் வியூ. ஒப்ளிக் வியூ உன் டார்கெட் அங்கே இருக்கும். நீ இன்பிளேனாக போனேன்னா எங்கேருந்து வந்தாலும் அந்த யூ வில் டார்கெட் தட் போஸ்டர் காம்ப்ளெக்ஸ். கீழே வாப்பா, ஜஸ்ட் கீப். ஸோ போஸ்டர் காம்ப்ளெக்ஸ், ஆண்ட்ரி காம்ப்ளெக்ஸ். என்னப்பா L5S1 ஸ்பேஸ் அப்படி நல்ல இது இது சேக்கரம்ப்பா. அதுலேருந்து சேக்கரம்லேருந்து வர ஃபஸ்ட்டு ஸ்பேஸ். தெரியுதா? போஸ்டர் காம்ப்ளெக்ஸ், ஆண்ட்ரி காம்ப்ளெக்ஸ். அது என்ன பண்ணலான்னா, லைக் நீங்கள் என்ன பண்ணால் ஃபஸ்ட்டு இது ஒரு ஒரு ஸ்பேஸ், இந்த ஸ்பைனஸ் ப்ராசஸே தெரியுது, அது ஒன்று மார்க் பண்ணிக்கலாம். எக்ஸாக்டாக அந்த ஸ்பைனை மார்க் பண்ணிக்கலாம். அப்புறம் அதுக்கு அடுத்த லெவல் ஸ்பைனை மார்க் பண்ணிக்கலாம், அதுக்கு அடுத்த லெவல் ஸ்பைனை மார்க் பண்ணிக்கலாம். ஒரு 3 லெவல் ஸ்பைனை மார்க் பண்ணிவிட்டு அந்த ஸ்பைனஸ் ப்ராசஸ்லேருந்து இப்போ நீங்கள் இதை எடுங்க. இப்போ ஸ்பைனஸ் ப்ராசஸை மார்க் பண்ணிட்டீங்க அப்படின்னா, ஸ்பைனஸ் ப்ராசஸ்லேருந்து 1.5 சென்டிமீட்டர் லேட்டரலாக அப்படியே போனீங்கன்னா என்ன இடிக்கும்? லேமினாவை தான் இடிக்கும். பாருங்கள், ஸ்பைனஸ் ப்ராசஸ் வந்து அப்படியே போனீங்கன்னா 1.5 சென்டிமீட்டர் லேட்டரலாக லேமினாவை தான் இடிக்கும். ஸோ என்னென்னா வி கால் இட் அ வெர்டிக்கல் ஸ்வீப் அண்ட் அ ஹரிசாண்டல் ஸ்வீப் 10 டிகிரி. ஸோ இதில் ஒரு 5 to 10 டிகிரி, இதில் ஒரு 5 to 10 டிகிரி டிபெண்டிங் அப்பான் த பல்கினஸ் ஆஃப் த பேஷண்ட்டு போனீங்கன்னா யூ என்டர். இது ஒரு ஆல்டர்னேட் அப்ரோச். அதான் சொல்கிறேன், இதை வந்து 3 டைமென்ஷனல் நீங்கள் வியூ பண்ணணும். இதை வந்து ஏன்னா நம்ம வந்து என்ன தான் நம்ம thousands of ஸ்பைனல்ஸ் போட்டிருந்தா கூட இதை இப்போ சில நேரம் அப்போ தான் நமக்கு ஸ்ட்ரைக் ஆகும், ஓ இந்த இன்டர்லாமினார் விண்டோ வந்து பார்த்தீங்கன்னா 2 ஆர்டிகல் ப்ராசஸ் லெவலில் தான் இன்டர்லாமினார் விண்டோ இருக்குது அப்படின்ற இது. ஸோ அதை நம்ம வி ஹாவ் அ ஸ்பைன் மாடல் அண்ட் கான்ஸ்டன்ட்லி ரிவ்யூ இட்னா நீங்கள் என்னப்பா இல்லை இருங்கப்பா எடுத்துக்கோ. ஓகே, இது ரெண்டும் நல்ல ஆர்டிகுலர் ப்ராசஸ்ப்பா. இன்டர்ஸ்பைனஸ் லிகமெண்ட், போஸ்டீரியர் காம்ப்ளெக்ஸ், ஆன்டீரியர் காம்ப்ளெக்ஸ். நீங்கள் ஆக்சுவலாக ப்ரோப் பிடிக்கிறது வந்து எவ்வளோக்கு எவ்வளோ ஐ அட்வொகேட் ஹோல்டிங் த ப்ரோப் வித் யுவர் ஃபிங்கர் சப்போர்ட்டிங் த பேக் ஆஃப் த பேஷண்ட். சரி, எப்போவுமே ப்ரோப் ஹோல்ட் பண்ணும்போது நீங்கள் இப்படி வச்சு இப்படி உங்கள் என்டையர் ஆர்ம் மூவ் ஆச்சுன்னா ஸ்டெபிலிட்டி கிடைக்காது, உங்களுக்கு டிஃபிகல்ட்டாக இருக்கும். ஸோ என்ன பண்ணணும்னா ஃபிக்ஸ் பண்ணிக்கோங்க. 2 ஃபிங்கரில் பிடிக்கிறீங்க அப்படின்னா சப்போர்ட் த தம் வித் த பேக்கு. உங்கள் ப்ராக்சிமல் ஜாயின்ஸ் எல்லாம் ஃபிக்ஸ் ஆகிடணும். உங்கள் மூமெண்ட்ஸ் வந்து வெறும் இங்கே மட்டும்தான் இருக்கும், அப்போ தான் சட்டிலாக இருக்கும் மூமெண்ட்ஸ். சி ட்ரை டூயிங் திஸ் க்ராஸாக இருக்கும், this will become subtle. So fix all your proximal joints, only your distal joints. எவ்வளோக்கு எவ்வளோ உங்கள் distal joints மூவ் ஆகுது அவ்வளோக்கு எவ்வளோ fine movements will be transmitted and you'll be able to get a good சோனோகிராம். தட் இஸ் அவர் ஐடியா இல்லையா? நல்லா ஸ்டேபிள் இமேஜ் கிறிஸ்பாக இருக்கணும். ஏன்னா உங்கள் லெஃப்ட் ஹேண்ட் எவ்வளோக்கு எவ்வளோ ஸ்டேபிளாக இருக்கோ அப்போ உங்கள் நீங்கள் மார்க்கிங் பண்ணும்போதெல்லாம் மாறக்கூடாது இல்லையா? இல்லைன்னா அது மாறிடும். டைம் அப்போ
அவ்வளோ பண்ணிடுவாங்க. ஸ்கேன் பண்ணுங்க ஃபஸ்ட்டு. இப்படி திருப்பிக்கோங்க. இப்படி பார்த்தா துறவட ஆர்டரி ஈஸியாக கண்டுபிடிச்சிடலாம். ஸோ இட்ஸ் வெரி ஈஸி. ஏன்னா யூ கேன் சி just slowly move the probe up towards the axilla. So at the end of 3 side teres major, இப்போ latissimus dorsi and serratus. So in the 3 consecutive muscles join our இடத்துல thoracodorsal artery appears. புரியுதா? Almost I closer to on the plane once artery cross section it travels like vertically downwards, so you can easily see from this plane. So once on the plane identify pannittu, just you can change it to longitudinal section where you can locate the thoracodorsal artery. So start from mid-axillary line. Okay. Where you can see the thoracodorsal artery. A small artery here. You can see the thoracodorsal artery. It is between the latissimus dorsi and the serratus anterior. Serratus. Teres kitty na varla. So teres you just locate the artery, then just turn it and see in the longitudinal section. You can see just equal to sign in between these two. Can you see that epimysial layer between these two? So that was we have to look for the. Then we can move up and see where the teres major muscle is. You can see the teres is appearing here. Yeah. And the confluence of all three muscles, you can see the thoracodorsal artery. Yes. Okay, do. Ado three. Ah. So where you can see only the serratus anterior. Just I can draw something. What you see here is the serratus muscle, the rib, the pleural shadow. This is the latissimus dorsi, which is starting. Okay. So when you go medial, only you can see the fat and the serratus muscle. So when you go lateral, you can see the serratus as well as the LD. Move on the posterior axial line, it becomes thicker. The serratus, the LD becomes thicker. You can see LD and serratus. It's going bigger and bigger. So when you are planning this block for a LD flap, you can go at the posterior axial line. So if you want to do it for the breast, you can choose the mid-axillary line, where you can have the what you see here is the rib. The serratus muscle is slightly hypoechoic, while the latissimus dorsi here is slightly hyperechoic. This is the serratus anterior. This is the latissimus dorsi. Subcutaneous fat. So next one, straight up. Usually it is advocated for CA breast patients. So we are thoracic epidural pouring is regularly for breast. We are minimally invasive anesthesia we are using for PECs. So pectoral block is the only block that is advocated by the prospective guidelines. So that is a plan A block for CA breast. Prospective guidelines. So every interfacial plane block you have to look for evidence. There is so much thing available for CA breast. For example, PEC 1, PEC 2, rhomboid, subserratus rhomboid intercostal plane block, ESP, MTP block, costal transverse foramen block, retrolaminar block. So the evidence is the prospective guidelines suggest only there is a quality evidence available at the present time for only for PEC blocks. So it was named into interpectoral block as well as pectoserratus, not like PEC 1 and PEC 2. So the breast area and the axilla is complicated because usually in females you put the patient under anesthesia, but it's difficult to position for a serratus plane. If the patient is awake, you can put it on the lateral side to do a serratus plane block, or if the patient is like exposure is only difficult for female patients because of this, you can do it under anesthesia. It will be obviously. No. It's only for before surgery or post-operative intraoperative anesthesia as well. So you can reduce the opiates requirement. So then when nerve supply for here is the anterior part of the nearer the sternum is anterior cutaneous nerve. At the angle of the rib there is lateral cutaneous nerve from T3 to T7. The T2 is a intercostal radial nerve. Here below the clavicle there is supraclavicular nerve. This is from cervical plexus. While the brachial plexus contributes for thoracodorsal and the long thoracic nerve. So this is a complicated thing where you had to block brachial plexus, cervical plexus as well as PEC 1 for the medial and lateral pectoral nerve, so which provides myofascial pain. And we had to also involve the T3 to T7 lateral cutaneous nerves. So for the complete block, we have to do a pectointercostal block for blocking the anterior patelis nerve. T3 to T7 serratus spine block for block 2 lateral gluteus nerve. Superficial cervical block in supraclavicular nerves, and also for brachial plexus for thoracodorsal and thoracodorsal, long thoracic nerve. But long thoracic nerve and thoracodorsal nerve also it will be blocked with serratus spine block. So you can do a single block at any level. There is a scanning sequence here. Anywhere you put a probe, what you see here is a pec major muscle. Just move closer, just move away from the center. There will be a muscle that start appearing, pec minor, because it is attached towards the ipsilateral humerus, bicipital groove. Yeah. So just go above the clavicle. So what you see here, the clavicle, this is the subclavius muscle, pec major and the pec minor, is rib 2. Now you can see the axillary artery as well, axillary artery. Can you reach here, axillary artery. That's where the subclavius, you have to look for the subclavius muscle. It was enclosed by the clavipectoral fascia. You can see the clavipectoral fascia as the pectoral fascia is moving along. And just I am sliding the probe towards the axilla. Now in between rib 2 and rib 3, I have a thin slip. I have the thin slip. Thin slip. Okay. Serratus. So rib 3, pec major and pec minor. This one is the interpectoral nerve blocker. This one is the serratus angle. That is pectoserratus plane. So pectoserratus plane at the level of rib 3 is the single injection technique, where you can place the drug 10 ml here and 20 ml here. First do the pectoserratus block, then come back to interpectoral nerve. So this is the step 2 that we are finding R2 and R3 space, where you can see all the 3 muscles, pec major, pec minor as well as serratus. So move the just move the probe towards the axilla, where you can see there is ending of the pec minor, that is Jerdis ligament. Okay, you can see here pec minor, the pec major and the serratus only you can see. This is Jerdis ligament. You want the white ligament. So this is what the Jerdis ligament. So pec major and the serratus. Almost the pec minor is ending here. You can also give pectoserratus here, it will be much better, but you have to utilize 2 injections. That will be more painful. So we advocate. It's very difficult to see it on the R3 plane, serratus plane. Rib 3 level, it's very difficult because it's a thin slip here. you want to do a pectoral serratus block, this will be the position supine. Then you proceed towards the axilla, where you see the end of the pec major. And what you see here, serratus and pec major alone. There is no pec minor. And slowly the pec major muscle also is ending here. Yeah. Slowly you go down the only what you see here, the serratus alone. The latissimus dorsi is starting from here. So serratus, so pec major. The pec major was ending. The lattice was starting here because the axillary fold is pec major. So when you go down the கொஞ்சம் திரும்பி flat. The same thing holds good. So very simple to just look for the serratus. When you place here, just over the ribs, what you see is only serratus and the fat. Serratus, fat. So just at the end of this, there is what you see. That's the latissimus dorsi, the thin muscle. When you go at the from mid axilla to posterior axillary line, what do you see? It is becoming bigger and bigger, and it is the serratus muscle also becoming bigger and bigger. Okay. When you go down, what do you see? Yeah, it became a thick muscle now. Now you can see there is a big muscle, that is hyperechoic muscle, that is latissimus dorsi. A slightly hyperechoic thick muscle. What do you see? Here is the serratus. That is the same. Sometimes it will be difficult to put it here. That's why they are advocating deep serratus now. So this superficial serratus it becomes deep serratus. Deep serratus, there is a end point here. You can hit the rib and put it down so that the drug spreads through, and also it blocks the intercostal nerves. What you see here is the thoracodorsal artery. You see, yeah, it's a thoracodorsal artery. That's where that is the plane. You can see two epimacy layers and a thin layer here. That's where you meet the thoracodorsal artery. That's the plane. You have to identify that plane and give the drug. I just want to turn it to the longitudinal section. That's why the spread will be like this in this direction. So probably you can see here. It's a thick. This one, the hyperechoic thick muscle, the LD. This is the hypoechoic thick muscle, that is the serratus. What do you get it? The so slowly I am moving up my probe towards the axilla. So if you want to get into the thoracodorsal artery, it lungs like longitudinal. So if you cut it like here, you can easily pick up the thoracodorsal artery. If you have any difficulty, can you see? Thoracodorsal artery. If there is any difficulty, you just move the probe towards the axilla, where you can see the latissimus dorsi, serratus, as well as the teres major. Yeah, teres major, latissimus dorsi. This is serratus anterior. The confluence of this is the origin of the thoracodorsal artery. You can place it anywhere. You can place it anywhere and see. You can get the nice pulsation. But most of the CA breast patient we won't get a nice view because the patient, because of radiotherapy, they will lost muscle hydration. It will be difficult to elevate. There will be multiple pulsations also. So just if you want to confirm whether it is a thoracodorsal artery, you have to go towards the axilla. Can you see now? The teres major, latissimus dorsi, and the serratus muscle. At the confluence, what you got? The big thoracodorsal artery. Because this thoracodorsal artery is the entry point for the serratus plane block. So it blocks the lateral cutaneous nerve from T3 to T7 as well as the long thoracic nerve as well as the thoracodorsal nerve. For hand, நேரப்படுத்துங்க. Lateral along the lateral border. For hand, because it's an anterior border. I'm just it's a big major. Slowly moving the probe, what do you get? This internal mammary artery. So this was the transverse thoracis, the intercostal muscle. Yeah. Big major muscle here. Big major. This is intercostal. Transverse thoracis. What you have here? Yes. So transverse thoracis, TTP block. Transverse thoracis block, TTP block. This is pecto-intercostal block to block the anterior cutaneous nerve. If you are doing a sternotomy, this will be better when you do it in the bilateral now. For lateral thoracotomy, you have to do a serratus plane block alone. For breast patients, you have to do PEG 1 or interpectoral nerve block as well as pectoserratus block. But this is not sufficient because it has multiple nerve supply. And because it is supplied by cervical plexus as well as the contributions from brachial plexus. Spine for 23. It will be difficult. If you use a small short bevel needle, it will be easy to place it in the interfacial cup. Otherwise, most of the time it will be on the muscular plane. If you use a Venform, it is easy looking, but it is difficult to separate the plane because the size of the plane is very thin. It is around 400 mics, but the needle size is 700 mics. That's very difficult. When you move the plane up and down, you get a muscle spread rather than the interfacial plane. That's why you can use a thin or fine needle like echogenic needle will be better. It's not available, I can go with spine. The axillary artery is the thoracoacral artery, so it's coming out, thoracoacral artery. So you want to, towards the axilla. If you want to see the thoracoacral artery, you can see it here. It's cephalic vein. So what you see is the axillary cephalic vein joining the axillary vein. Just look just above it. Look for, yeah. What you see is small, that's a thoracoacral artery. Yeah, in between the pec major and pec minor, what you got is the acromiothoracic artery. Freeze spoon. There it is. இதில் நீங்கள் ஸ்க்ரிபிள் பண்ணி pec major, pec minor, axillary artery, thoracoacromial artery. Thoracoacromial artery is the one of the branch from the second part of the axillary artery. So you can see the axillary artery. So it's a small artery coming and joining between the interpectoral plane at the level of the intro. Now you can see it's a cephalic vein. This is where you have to look for the costoclavicular block. இந்த இடத்துல பார்க்குறோம் cephalic costoclavicular space. இந்த costoclavicular space இதெல்லாம் நம்ம பண்ணுறோம். Axillary vein, axillary artery, costoclavicular space. புரியுதா? This is costoclavicular. The costoclavicular space. What you see the subclavius as well as from the intraclavicular you want to see this pec major, pec minor. You have to go lateral. Pec major, pec minor. So this is intraclavicular block. This is where you look for infraclavicular block. You have pec major and pec minor, axillary artery and axillary vein. Freeze போடுங்க. Axillary artery, pec major, pec minor, axillary artery, axillary vein. This is the brachial plexus. Brachial plexus. Costoclavicular space here, you have to look for the cephalic vein draining into the axillary vein. புரியுதா? cephalic vein drain ஆகுது. அதுக்கு மேலே ஸ்லோவாக move the probe, you can get the acromiothoracic artery. Acromiothoracic artery just above the cephalic vein entry. So identify the acromiothoracic artery and you can identify the interpectoral plane. You can see here pec major, pec minor and the interpectoral planes. You can do interpectoral plane block alone from this. If you want to do simultaneously two blocks, I will do for all three muscles here. And just put a freeze. Now you can see pec major, pec minor and the serratus vein. At the level of R3, so is R3, rib 3. So this is pec major, this is pec minor. Just above the rib, look for a small slip, which is the serratus anterior muscle. Pec minor, pec major is fatter. This one is the interpectoral nerve block, and this one is the pec2 or say pectoserratus block. Just give 20 ml here and bring back the needle to the pec1 plane. clavicle, subclavius, axillary artery, pec minor, pec major, subclavius muscle, the axillary artery, pec major, pec minor muscle. When you move towards medial, pec minor will disappear, only pec major, intercostal vessels. You can see the thoracic, transverse thoracis. When you go towards what you get is the internal mammary artery. You see the internal mammary artery. This is transverse thoracis block just above the mammary artery. This is like intercostal vessels. So you can see the neurovascular bundle here. You can see the neurovascular bundle here. The transverse thoracis muscle. Just put the block below the transverse thoracis and just above the artery. But always remember that is closer to the dangerous artery, that is, this is the, you can see, rib shadow, some rib there, the pec major. This is the interpectoral plane. This one is the transverse fascia. What you see here is the rib pleura, and the in between these two, the internal mammary artery. So this is the TTB block, transverse thoracis block. This is pecto intercostal block. This is for blocking the anterior cutaneous nerve. For sternotomy will be good. The axillary artery. So when you move more laterally, what you see is a axillary artery and axial vein. So infraclavicular space on most. If you turn, you can have the costocavicular space. The acromiothoracic artery. What you see here is the acromiothoracic artery. This is the cephalic vein draining into the axillary vein. Cephalic vein is draining into the axillary vein. You can see here. So, the cephalic vein is draining into the axillary vein. Just slightly above, what you get? Just go slightly above. This is cephalic vein. What you have? A small artery is entering towards the interpectoral nerve. You can see here. Now you can see here. Now you can see the artery, small artery, that is acromiothoracic artery. You can see it slowly. This is cephalic vein. Drain into axillary vein. Just move above the cephalic. What you get? Acromiothoracic artery in between the pec major and pec minor, the interpectoral plane. It travels in the interpectoral plane. So the problem here is only counting the ribs, which just look for the clavicle, axillary artery. What you look here is the rib 2 shadow. This one is the rib. Yeah, second rib. What you see here is second rib, and this one is third rib. Just move towards the axilla. Move towards the axilla. What you have, the thin slip of muscle over the rib, that is the serratus muscle. This one is a pec 1, this one is pec 2, this is R3, this one R2 is R3. It's a plane that is for both interpectoral as well as pectoserratus block. Slowly you can move the probe towards the axilla. Now you can see the pec minor is ending. becomes the ligament. That is called the Jerdis ligament. So pec major and serratus, there is no pec minor. Only pec major and serratus. Now the pec major also is started ending here because I actually crossed the axillary fold. I moved towards the axilla. So what you see here is only serratus and the latissimus dorsi is not coming. So slowly you can see a small muscle will be coming here. This will be latissimus dorsi. This is full of fat only. Slowly I can move the probe and see the small muscle entering. That's for the latissimus dorsi. This one is the serratus. What you see is the entry of the latissimus dorsi. It's only the subcutaneous tissue. It's R6, almost R6 and R7. It's easy to lateral. It's easy to locate the latissimus dorsi. You can place it anywhere in the. Now what you see here is only serratus muscle, a small thin slip of LD. By moving it, the LD and the serratus become thicker and thicker and thicker. So it will move, when you move from posterior axis line, the serratus become thicker and the LD become thicker. Serratus become thinner, LD become thicker. So when you want to do it for LD flap, you have to go for a posterior to the posterior axis line. So here it will be in the mid-axillary line. It will be in the anterior axis. What you see here is the thoracodorsal artery, which is traveling in between the serratus and the LD. Okay. Just turn it towards the probe in this plane, longitudinal, so that we have a good spread. When you don't get the artery, don't panic. Just longitudinal, it will be because it travels in the longitudinal plane. You can easily get the artery. Don't worry. Just put the probe and move closer to the axilla. What you get is three muscles: teres major, latissimus, and the serratus. In between these three, this is the origin of the. Can you see? That is the thoracodorsal artery. That's where you have. This is why this is how to find the thoracodorsal artery. இது பிஜிஸ்க்கு இப்படியே சொல்லி கொடுத்தே பழகிட்டேன். எதா எழுதியே பழகிட்டேன். செரேட்டஸ், டீரிஸ் மேஜர், எல்டி. Usually in the vertical orientation, there will be a nice spread along this, because most of the lateral cutaneous nerve is given at the angle of the rib, and it will be traveling along this plane. It will be better to give it in this plane. But once under GA, it will be difficult to position. If you have availability, you can do it in the lateral position. It will be always good. But in this position, there will be the spread will not be like in this line. It's there, but it is not sufficient. That's why I usually advocate this line. But patient position should be in the lateral. If it is in the supine position, you can do it, but it is not like what you do in the longitudinal position. இல்லை இது நேராக படுத்துக்கணும். தலை திருப்பிக்கணும்ல, கை கீழே வச்சுக்கோ. thoracoacromial artery. Hello.
come down compared to our block, but we can compare only our block, like anesthetist block. So landmark, this is ultrasound guided block. Whatever it is, you are supposed to feel the tactile sensation of piercing the internal oblique muscle fascia and deliver the drug either superficial or into the transverse abdominis plane block for its complete success. Okay. For rectus abdominis rectus sheath block, deposit the drug anterior to the posterior rectus sheath. So don't pierce it. Go pierce the rectus abdominis muscle, feel for the resistance, dissect the plane with some saline, then deliver your drug 10 ml, 10 ml this side, 10 ml that side, 10 ml. Okay. For upper quadrant anesthesia, analgesia, it is rectus sheath block plus subcostal tab block. For lower quadrant, there is no posterior rectus sheath, so there is no rectus sheath block. It has to be only either lateral tab block or posterior tab block. Out of that, posterior tab block gives superior analgesia compared to the lateral tab block. Whatever is the drug has to go more posterior towards the mid-axillary. And regarding the ilioinguinal iliohypogastric, so keeping the probe over the iliac crest, okay, beautifully you can see the bubbles there, okay, can you see the bubbles there? Now, one thing what I have to confirm is I should go with all the 3 layers I have to see, okay, all the 3 layers I have to see, otherwise this nerve would be leaving the transverse abdominis plane. So I should be able to see all the 3 this thing. Yes, I am able to see all the 3 muscular plane and keeping the one end, over the iliac crest. Now, yes, right, can you see that? Now you have to switch on the color Doppler, rule it out that is not your, you will get deep circumflex iliac artery at this level. Okay, now you are getting it, right? Can you see that pulsatil movement there? I'll tell you, yeah, that's a deep circumflex iliac artery. Okay, now there is one more bubble this side, right? Shall I freeze it, right? Okay, so the one which is very near to the iliac crest is your ilioinguinal iliohypogastric plexus, or the one which is very much near to the iliac crest is ilioinguinal, 2L. Okay, the one which is medial is iliohypogastric, the one which is lateral is ilioinguinal. Lateral, I have put this is my lateral side, this is medial side. The one which is more lateral, more towards the iliac crest is your ilioinguinal. The other one is iliohypogastric. So this is deep circumflex iliac artery. I can get these 2 nerves here. There is one more bubble here. So what has to be? It is this is your subcostal. This is T12, subcostal. That also travels in the same plane. Why this is very important? Why am I emphasizing again and again about this iliac crest? This thing is, for when you do it for analgesia purpose as an anesthetist, doesn't matter. You can put the needle here, out of plane approach, deposit the drug, 10 to 15 ml. Both the nerves will get anesthetized. You will be very happy. But when you do it as a pain physician, most of the patient will be suffering from ilioinguinal iliohypogastric neuralgia. Out of that, ilioinguinal neuralgia. If I do alcoholic ablation here, the patient will not going to get pain relief. So I am supposed to do it here, not in that plane. Okay, the one which is very near to the deep circumflex iliac artery is your ilioinguinal iliohypogastric plexus. Okay, by doing this block, will I get a analgesia for hip, the incision point? Definitely no. Because when the nerves reach this plane, already the lateral cutaneous nerve would have taken off and they would have gone towards the hip. So to catch that, you should go for quadratus lumborum block. So that is why I am telling the usage of this block in anesthesia is very, very minimal. Earlier, this was used for hernia surgeries, this, that, and all, but it has been well documented that for hernia surgeries and other surgeries, you can go for a lateral or posterior tab block. And there, one nerve which is not covered is genitofemoral nerve. So you can ask your surgeon when he is opening up the spermatic cord, you can ask him to infiltrate the drug there. Otherwise, you can identify the femoral artery, trace it up and identify the spermatic cord, and you can give the drug there. But that is a highly vascular area, so you have to be very careful when doing that. Okay, I can't do it because of privacy issues. Okay, so that is the thing. So you have any other doubts? Okay, you can start practicing. Sorry. See, again, you may pick up some arteries here also. So this is epigastric artery, superior epigastric artery, which is there into the muscle, and the deep inferior epigastric artery sometimes below this thing. But as because the bowel movement is there and the bowel ways have a lot of air, you will not be able to identify that. But when you go for gastroenterological procedures where they have prepared the bowel with this thing, if you scan it and switch on your Doppler, you may pick up it. So I will try that. This is bowel movement. What is there now is bowel movement. This is not related to the artery. But you can pick it up the artery there. Yeah, so you can see the two lines. The upper one is your posterior rectus sheath. The down one is your transversalis fascia. Transversalis fascia and the parietal peritoneal combination. Okay, so she is going into the, this is the subcostal tab plane. So rectus abdominis muscle, transverse abdominis muscle. If you inject your drug, see what you can do is you can inject some drug here, cover up the rectus sheath. Then you can come here and you can inject the other drug here. That you can do. Okay, so you can combine these two blocks here. Okay, so this is subcostal tab. 3 layers are seen. This is subcostal tab, and that is linea semilunaris. This is linea semilunaris. Okay, the junction of the two aponeurosis with the rectus abdominis muscle. Yeah, you can go down. Yes. So the lateral tab block is midway between the costal margin and the iliac crest. I think you have to hold the. Okay, you just hold it like this. Yeah, like that. Yes. Yes, beautiful. Yes. Yes. No, I think you have to. You just go like this. Can you see that, right? Is it fine? Yeah, this is the end point of your tab plane. I will increase the depth. This is the end point of your tab. Okay, here you can see the quadratus lumborum. Okay, once the tab ends, see this is the tab. Once the tab ends, go down, quadratus lumborum. Okay, so the deposit the drug between the end point of the tab and the quadratus lumborum, that is posterior tab. So it's an analog of your lateral fuel again. Yeah, this is rectus muscle. In the middle you can see the linea alba. Yeah, so from there you can come little lateral. Yes, sir, beautiful sir, beautiful. I'll reduce the depth for you. Okay, now, this is the posterior rectus sheath. You can see the rectus abdominis muscle. So here lies the posterior rectus sheath. Transverse abdominis muscle. You can deposit the drug for the rectus sheath block here and go deposit the drug here for your subcostal tab. Yeah, this is linea semilunaris. All the 3 plane muscles are seen. come down and posterior, come down and posterior. Yes, sir, beautiful, sir, yes, sir, that's it, sir, that's it, yes. Now I will increase the depth for you. Okay. You can change your like this, yes, sir, yes, sir. Yeah, this is the end of the tab, there you can do. This perinephric fat, this is paranephric fat actually. Perinephric is with the kidney, this is paranephric fat, peritoneal fat, because of the contact these things are, yes, sir, yes, sir. Yeah, now you can go, sir. Little down, sir. Yeah. Okay, you can see the quadratus lumborum muscle there. Yes. Okay, if you want it to be more specific over the quadratus lumborum, change the probe to, okay, you want to, sorry. இல்ல பண்ணல. Yes, sir, you can see the plane. Only thing is you can see the plane. Only thing is just orient always over the iliac crest. Okay, now you can see. Yes, that's it. Iliac crest. Yes. எப்படினாலும் வச்சுக்கலாம். நான் see I always okay. எப்படினாலும் வச்சுக்கலாம் சார், as per your wish. Okay, as per your wish. External oblique, internal oblique, transverse abdominis muscle, அதை மட்டும் clear-ஆ கொண்டு வந்துட்டீங்கன்னா you can do this tilt. Okay, you can see this is classic. This is your ilioinguinal hypogastric. Okay, so you got it. Yeah, this is lateral. இன்னும் கொஞ்சம் அப்படியே இன்னும் மீடியில் அங்கிட்டு போனால் சப்காஸ்டல் வந்துடும். ஆமாம் சார். Yeah, this block, this is subcostal. Yes. Yes, madam. So this is subcostal actually. This is your ilioinguinal hypogastric. Out of plane easy, amma. Ilioinguinal hypogastric na அப்படி இருக்கணும். சும்மா ஜெனரலா போறோம் அப்படினா சப்காஸ்டல் ஸ்பேர் ஆகாது. அதாவது இன்வால்வ் இருக்குல, ரேடியோ ஃப்ரீக்வன்சி பண்ணும்போது சப்காஸ்டலை நான் பண்ணிட்டேன்னா ilioinguinal when the patient presents with post hernia repair pain, it will be ilioinguinal neuralgia, not subcostal nerve neuralgia. Ilioinguinal iliohypogastric nerves has a small tweak from T12, but they are predominantly L1 nerves. So I have to target the L1 nerves. So if I do a T12, I won't get a complete pain relief. போயிடும். இது 10 ml. இது anterior tap 10 ml. Lateral tap and posterior tap 15 to 20 ml, subcostal tap 15 to 20 ml or 0.2 to 0.3 ml per kg body weight. Rectus sheath block 10 to 15 ml. அது spermatic கார்டுக்கு பக்கத்துல, that is லேப்ரோ. ஆமா. See, that is actually best. Surgical tap is actually always better. So that is always better, but for anesthetist point of view, we want to do the tap block. So yes, madam, this is fine. See, midway between the costal margin and iliac crest. When you do it from here, just go this angle and then park it here. Okay, so don't go straight, go slant. Better, these are all small patients, so you don't need, but when you want to do from tap to QL, better lateral position. Lateral position you will be more comfortable. Lateral position, you can decide whether what QL you are going to do, anterior, lateral, or posterior, lateral or anterior.
A wedge is more than enough, but keeping the patient in lateral, who is so conscious like that. I'll ask him. Yes, madam. See, you are doing it above, right? So the muscular pain will be different. See, now this is different, right? Now if you go here, yes, this is the tapering point, right? Okay, now this is the tapering point. ஒரு நிமிஷம் தம்பி திரும்பி படுங்க அப்படி திரும்பி படுங்க. So one minute madam, 1 minute. See, so keeping the patient on lateral position will be more comfortable. See, now when I come, yeah, tap ends here, right? Now when I go, can see the QL here. Yes, hypoechoic is QL. Block actually இங்கே கொடுக்குறீங்க, இங்கே கொடுத்தீங்கன்னா the drug will go this side or this side. That's what I'm telling. It will go to that side or that side. So QL, it's not QL1 and 2. That's what. It's no more QL1 and 2. The QL1 is lateral QL. The QL2 is posterior QL. And the QL3 is anterior QL. So where we have to give the drug, that we have to decide according to the surgical level. Analgesia. Anesthesia usually don't be sufficient for producing anesthesia. You have to only for analgesia. Analgesia, super. QL3 is for. See, quadratus lumborum block is studied thing for other. Would a better option on the suprainguinal fascia iliaca block. So number one is always suprainguinal fascia iliaca block, particularly when the patient is on clopidogrel or aspirin. Okay. So in that angle, I prefer SIFI. Then comes your pen block. Pen block of the percutaneous this thing, pericapsular nerve group block. So there is another entity, pen block. So that can be practiced. Again, see, it is the deposition of the drug between the inferior iliac spine and the iliopubic prominence, below the psoas tendon. So 20 ml volume. That also gives superior analgesia for metaphyseal fracture. Yeah, நீங்கள் பண்ணுங்க மேடம். See, இங்கே போய்ங்க, நீங்கள் பிடிங்க மேடம், நீங்கள் பிடிங்க. So this is for the rectus sheath. Okay, so this is your rectus sheath. So you can see the posterior rectus sheath. So if you deposit the drug coming from here, you deposit the drug here, above the posterior rectus sheath, below the rectus abdominis muscle, that is it. 10 ml this side, 10 ml that side. Lateral. Okay. Now this is the origin point of your transverse abdominis muscle. So now you just put your drug here. So that will. This is your subcostal tab because you are doing it in the subcostal region. Okay. Now when you go more, yeah, yes. So the same tab plane only you are going on. Okay. So if you go here, this is lateral tab. You do it here, lateral tab. When you go more posterior, okay, this is the end point. So here it is your posterior tab. Ore plane down, but parking in different places will give you different results and for different surgeries. But volume remains same, 15 to 20 ml wherever the tab block you do. For rectus abdominis it is 10 ml, 10 plus 10, 20 ml. video வேணா காமிக்கிறேன். Okay, so that we will do it in this. Ilia inguinal வந்து you just yes. Ilioinguinal you just keep one side of the probe over the iliac crest and other side of the probe towards the abdomen, umbilicus. Okay, can you see that now? So you just reduce the depth. All the three planes, if you are seeing it, that is it. Now actually you have got both beautiful this thing. This is subcostal, this is ilioinguinal iliohypogastric, because you are going near the iliac crest. The one which is very near to the iliac crest is your ilioinguinal iliohypogastric. Among that, the more lateral, because you have kept this as lateral, the more lateral will be your ilioinguinal, then iliohypogastric, then subcostal. Iliac crest to umbilicus. Iliac crest to umbilicus line, madam. Draw a line, just put a probe like that. ஒரு நிமிஷம் அப்படியே லேட்டரல் போடு, ஒரு திரும்பி போடுங்க. ஓகே, அப்படியே ஸோ திஸ் இஸ் ஃபார் யுவர் QL திஸ் திங். வரேன். ஓகே, ஸோ நோ ஸோ reduce the depth. See rectus abdominis. Can you see the rectus abdominis? Then all the three layers, right? 3 layers, right? Right, 3 da. So you just come tapering down, right? Okay, it's tapered down here, right?
கஷ்டமாக இருக்கும்போது இங்கே நிற்கலாம். இது நிறையா
As you can see, this paravertebral space is very closely approximated with the intervertebral foramina. So through that only you get all your ventral rami, intercostal nerves, the dorsal rami, and through the communication sympathetic ganglion. In other words, it gives block epidural or a unilateral epidural. Clear till now? Okay. So now we'll see structures you'll be seeing in transverse and sagittal view. For transverse view, I'm going to keep my probe here. As I said before, spinous process, lamina, costo-transverse junction. Just get your probe slightly below to look out, target your tip of the transverse process. By keeping my probe in the tip of the transverse process, what ligament will I? Excellent. So I will not be able to see any ligament. Transverse process will obscure my superior costo-transverse ligament. Unless until I get my probe below the transverse process, I will not be able to see the superior costo-transverse ligament. Right? What you'll be able to see, you'll be able to see only the internal intercostal membrane. So, as I said before, the paravertebral space is bounded by the SCTL. Right? So, what is the point in looking at the internal intercostal membrane? We are talking about block, right? Then what is the point in having talking about internal intercostal membrane? It continues as the superior costo-transverse ligament. So, indirectly, if I'm getting a probe slightly below, getting the internal intercostal membrane, if I'm piercing it in the medial most part of the intercostal membrane, that forms the apex of your paravertebral space, directly entering into the paravertebral space. You may ask, ஏன் அவ்வளோ கஷ்டப்படணும், கீழே வச்சு பார்த்து எஸ்சிடிஎல் பார்த்தே போடலான்னு உங்கள் மனசு தோணலாம் இல்லையா? That's more difficult. Why? Because once it goes down, the landmarks, bony landmarks இல்லாமல் அங்கே pick up பண்ணுறது slightly difficult. Because this being a slightly deeper block, it's difficult to pick up, and moreover, you'll not be able to identify the SCTL very clearly as in a sagittal. So the best, and now one more thing is, you're having a tip of the transverse process that serves as a bony landmark. When you do an injection, the needle can go and hitch against the bony landmark rather than go deep and pierce into the pleura or go into the epidural. So that serves as a safety marker so that you don't transverse or put in a needle 2 inches. Okay, Kandi. அடுத்தது வரேன். நான் transverse மட்டும் தான் டவுட் இருக்கான்னு சொல்லுங்க. ஏன்னா நான் transverse மட்டும் கொடுக்க போறேன். Unless until you're experts, you want a sagittal, I'll tell you sagittal. Because sagittal, I'll tell you the problem. All of you are doing ESPs in sagittal. You think sagittal is much more easier. I feel transverse is much more easier. Needle visualization is most important in a paravertebral block. That is better seen in case of a transverse plane. இப்போ sagittal என்ன சொல்ல வந்தீங்க? In case of a sagittal plane, the reverse, I'm asking the next point. So for transverse plane, you're getting the costo-transverse junction, the tip of the transverse process, seeing the coastal membrane, pierce it. Clear. So keep the probe this way. இப்போ இப்படி probe வைக்கிறது என்ன தெரியும்? I'll be able to see the transverse process. Lateral போனா I'll be able to see the ribs above and below transverse process. So I'll be able to see the superior costo-transverse ligament, and beyond that, anterior to that, I'll be able to see your paravertebral space, pleura or paravertebral space and the pleura. Right? Looks easy, right? So why I'm not talking over this? அப்போ ஸ்கேன் பண்ணுறவங்க சொல்லி சரியா? இப்போ சொன்னால் சத்தியமாக உங்களுக்கு புரியாது ஏன் நான் சொல்கிறேன்னு. இட் லுக்ஸ் ஃபன்னியாக இருக்கும். நீடில் அங்கே போகாத வரதுன்னா நீங்கள் சும்மா சொல்கிறீங்க அப்படின்னா ஸ்கேனில் பார்க்குறோம், அண்டர்ஸ்டாண்ட் மச் பெட்டர். Now we'll go to the scan. Now you understand why I'm talking about that? Fine. Okay. நாலாவது பேட்சுக்கே உடஞ்சி போச்சு. சொல்லுமா கண்டினியூ பண்ணுமா? Now you see you have your levels. நீங்களே பண்ணு. Come. You want to do level, you all know, right? Rib is rounded borders. You go medially, you have a deeper transverse process. This is your rib, transverse process. Rib, transverse process, right? You get your rib, you count above. So that is your first rib, right? So there is no any black shadow above that rib. That is your transverse process, or that is your rib, first rib. First 2, 3, 4, 5, 6, 7, whichever. Keep it as T4, T5. Now what I'm doing it is, I'm doing it transverse, right? Go in the midline, Yeah, you're able to see some white dark shadow. That is your spinous process. So what is the next structure you'll be able to see? Lamina. So the lamina, being a flat lamina, it's a U-shaped one. No, this one. Yeah, that is your lamina. So you come lamina, you come laterally. The next structure I want you to see is you'll be your transverse process, right? So that is your transverse process. Transverse process. I want to see your costo-transverse junction. Rib with your transverse process. Rib with your transverse process, right? After I see that, I just want to get it below. அந்த tilt பண்ணாதீங்க, நேரா வச்சிட்டு பாருங்க. Again, you doubt on the திருப்பி இங்கே வாங்க. No issues. அப்படியே keep it straight. Keep it straight. Yeah, keep it straight. Come down. Come down. Yeah, now able to see. Go above. Now able to see the costo-transverse junction. Full rib. There is no pleura down. That means bone மட்டும் தான் இருக்கு. Once totally black. Now you just get it below. Yes. Yes. ஒரே நிமிஷம். இந்த இப்போ மட்டும் you get your இப்போ பண்ணு. இப்போ பண்ணு. இப்போ பண்ணுங்க. So this is your spinous process. இல்ல லாமினாவே தெரியல. That is your lamina. That is a lamina. That is your costo-transverse junction. Go slightly below. இல்ல ஒரு நிமிஷம். Yes. இப்போ now look at the picture there. அந்த வால்ல மாட்டிருக்க picture பாருங்க. Able to get it? மேல இருக்க நைஸா ஒரு picture பாருங்க. Freeze பண்ண வேணாம், விட்டுருங்க. Freeze இல்லாம தான் நான் பெட்டரா இருக்கும். membrane தெரியும். Now look at the picture. Nice or a picture தெரியுதா? See the transverse process, the pleura. Now give a caudal tilt to appreciate it. Now you able to see the membrane, internal intercostal membrane. Yes. So that's what. So when you pierce the internal intercostal membrane, indirectly you are reaching your of the paravertebral space. ஆமா, அது அவ்வளோ க்ளோஸாக இருக்காது, இதில் தெரியுது. நான் உங்களுக்கு காமிக்கிறேன். உங்களுக்கு ஸ்பேஸ் நல்லா வேணும்னா நல்லா காமிக்கிறேன் உங்களுக்கு. It looks like that, right? But it's not actually. No, doctor. Actually, sympathetic chain lies more anteriorly. We're not doing with the sympathetic chain. Paravertebral sympathetic blockade will occur, but we're not going close to sympathetic chain. Lies close to the vertebral body. We're talking about the posterior arch kitta பேசிட்டு இருக்கோம். We're not talking about the sympathetic chain. What I said is not the complication. It is an advantage. I mean, sympathetic chain illama no visceral pain will get blocked. If you want to provide anesthesia, this is the only technique which can provide anesthesia next to epidural. Only technique. I repeat again. Not your QL, not your ESP, none of your facial line blocks will provide anesthesia. Will provide analgesia, will not provide anesthesia. If you want to provide anesthesia, you want to have somatic as well as visceral blockade. Somatic blockade is mainly through your nerves, ventral rami, whereas visceral blockade pain is mainly due to your sympathetic pain. Unless until you block your sympathetics, none of your abdominal pain will settle off. All your ESPs, QLs may be good in your postoperative as part of your multimodal analgesia, not as a sole technique for analgesia. Whereas paravertebral, just give a single paravertebral or a continuous paravertebral, it will give good analgesia by itself. You don't need to supplement with any other analgesics. That is the advantage. I believe ESP ஓட பயங்கர proponents அப்படியே ஃபுல்லா ESP உங்களுக்கு காமிக்கிறேன். ESP என்னன்னு காமிக்கிறேன். MTP பண்ணிருக்கீங்களா? MTP block பண்ணதில்லை. சரி, okay, we'll show. Okay, somebody wants to do it? Show you the sagittal. Recording here, I'll show you the sagittal. Right? So this is your rib transverse process. This is a costo-transverse. அங்க ரெண்டு shadow தெரியுதா? Somebody can appreciate the two shadows. This is a single shadow, right? இங்க ரெண்டு தெரியுதா? This is ரெண்டு தெரியுதா? So rib and the transverse process above. Yeah. So everybody want sagittal. This is sagittal view. This is your transverse process, costo-transverse junction. This line is your superior costo-transverse ligament. So superior costo-transverse ligament. What you do in ESP is deposit the drug here. Purely depositing the drug here will not cause analgesia for the anterolateral chest wall because it will never block your ventral rami. Without blocking the ventral rami, you cannot give analgesia to the chest wall. Right? If you want to give ESP, deposit the drug, it will provide analgesia only this area. That is supplied by your medial and the lateral branches of the dorsal rami. So இங்க நம்ம அந்த analgesia கொடுக்கிறது very very limited except for spine surgeons. Most of the time we are only bothered about the lateral and the anterior aspect. So for that you need to deposit at least the drug should go and block your ventral rami. For that at least you need to get your needle here to block it. அது எப்படி ஆக்ட் ஆகுது? It comes here. There are slits in your water in the superior costo-transverse ligament. The drug traverses through this and again goes in the acts in the paravertebral space where the ventral rami occurs. My point is, why you want to give a drug, something CPOP, if you can see it, deposit the needle and here itself. Then why you are saying only transverse, not sagittal, since that you are able to see the space before, right? Since I am able to see here, but I am not be able to put in a needle in plane. The needle will come here, I'll be able to hitch it. If I want to cross this, I need to really get at a deeper plane. If I am getting it too deep, I'll not be able to see the needle. Unless until I see the needle, there's every chance I can injure this structure. If you are going to do it out of plane, this workshop is not for you. This workshop is not for you, right? Out of plane, more importantly, if you are doing it out of plane, definitely you should use a needle that has a measured gauges. If I am doing it at out of plane, my markings approximately, my distance is approximately 2 centimeters. My SETL is approximately 1.8 centimeters. My needle should not go beyond 1.8. My needle should not go beyond 1.8 because out of plane you will not be able to see anything, just the tip. We'll never know there is a tip of the shaft. Definitely beyond 1.8, my needle tip should not go. It's not that you cannot do it, you can do it, but definitely not for beginners. It's not a block where you try learning out of plane for a paravertebral. Out of plane for a paravertebral. Do an in plane, still difficult, finding it difficult, you can do it. Shall we have it at the end? Probably we are just talking slightly higher level. Others are having தனியாக பேசலாம் அப்புறம் நம்ம டாபிக் விட்டு டைவர்ட் ஆயிரும் அப்புறம் இவங்க எதுக்கு பண்ண வந்தாங்கன்றது தெரியாது because as I said before we are doing only the thoracic paravertebral, right? Okay.
இடத்துல கொடுத்தாலே ரெண்டு பக்கம் போயிடுமா? இதுக்கு க்ரௌட் வருமா? நான் தனியாக பேசணுமா? யூடியூப்க்கா? இந்த இடத்துல ஒரு லைன் தெரியணும் மேடம். அந்த இன்னர் இன்டர்காஸ்டல் மெம்பரேன் தெரிகிற மாதிரி அட்ஜஸ்ட் பண்ணி பார்க்கணும். மேலே கீழே லேஸ் அட்ஜஸ்ட் பண்ணி பாருங்கள், தெரியும். ரிப்பு வராது. ரிப்பு வந்துச்சுன்னா அது கரெக்ட் இல்லை. ஒரு நிமிஷம் இருங்க, நீங்கள் அழுத்தி வைக்கிறீங்க. இந்த இருக்கு பாருங்கள். இதை வந்து என்ன செய்யணும்னா இந்த மூமெண்ட்டில் தெரியும். இப்படிங்க பாருங்களேன், இந்த மூமெண்ட் வந்து ஷைனிங்காக மாறிடும். ஏன்னா இதோட பிளேனே இப்படி இருக்கும். அதனால் வந்து இப்படி தேடுறதை விட இப்படி மூவ் பண்ணுங்க, வந்துடும். ஏதோ ஒரு இப்படி போட்டாலும் சரி, இப்படி போட்டாலும் சரி தெரியும். இப்போ நல்லா வருது பாருங்கள், கீழே தெரியுது அந்த மெம்பரேனு. ஸோ இந்த மூமெண்ட்டில் தான் அது ஆக்சுவலாக நல்லா விசிபிளாக மாறும். எங்கே நல்லா விசிபிளாக மாறுச்சோ அதுக்கப்புறம் அங்கிட்டிருந்து நீடில் கொண்டு வந்துக்கலாம். வேரியபிளாக இருக்கும். கரெக்டாக லிகமெண்ட் மேலே போட்டிங்கன்னா 10 ml கொடுத்தாலும் 5 செக்மெண்ட் போயிடும். 2 ml per segment in thorax. ஆமாம், 1 ml-க்கு அது 3 ml-க்கு ஒரு செக்மெண்ட் லம்பாரில். லம்பார் கொஞ்சம் தான் போகும். நீங்கள் வந்து ஆக்சுவலாக வந்து அந்த இன்டர் டிரான்சஸ் லிகமெண்ட் ரோடு மாதிரி அது மேலே ட்ரக்கு வச்சிங்கன்னா ஒரு டனல் மாதிரி ட்ரக்கு வந்து மசிலுக்கு இல்லை நல்லா இங்கேயும் போகும். இந்த லிகமெண்ட்டை விட்டு இங்கேயும் கொடுத்தீங்கன்னா இந்த இடத்துல மட்டும் பூலாகி நிற்கும். அட்ஜஸ்ட் பண்ணி கரெக்டாக அந்த இடத்துக்கு வைக்கணும். 0.25% போதும் மேம். 15 ml கொடுக்கணும். லம்பார் இருக்கு வந்து என்ன செய்யணும்னா, சாரிப்பா, இப்படி வச்சு ஆக்சுவலாக வந்து இந்த மாதிரி கண்டுபிடிக்கிற கஷ்டம். கீழே பெரிய ஸ்டீம் தெரியுது பாருங்க, பெரிய ஸ்டீம் தெரிஞ்சுல, இந்த பெரிய ஸ்டீம் அட்ஜஸ்ட் பண்ணி இருக்கிறதுலே மேலே எங்கே வருதுன்னு பார்க்கணும். அவ்வளோதான், இந்த டெப்த்து இங்கே போய் போட்டுறணும். இங்கே வந்து மெம்பரேன் இருக்காது, நேர நீடில் வந்து இந்த பெரிய இது மேலே பட்டுச்சுன்னா ஒரு கேப் இருக்குல்ல, இந்த கேப் ஃபில் ஆகி மேலே இங்கேயும் போயிடும். ஆமாம், 5 செக்மெண்ட்டு 20 ml கொடுத்தா 5 செக்மெண்ட் தான் இங்கே ஸ்ப்ரெட் ஆகும். L1லேருந்து L5. நான் யூஸ்வலாக L2 L3யில் போடுவேன். போட்டால் கரெக்டாக L1லேருந்து L5 வரைக்கும் வந்து ஸ்ப்ரெட் ஆகிருக்கும். இந்த இருக்குது, அது மாதிரி தெரியாது மேம், இது பெரிய மசில், அதனால் இந்த இருக்குது. அதாவது டிரான்ஸ்வர்ஸ் ப்ராசஸை கண்டுபிடிக்கிறீங்க. தேங்க்யூ மேம். ஸ்டார்ட் பண்ணவா? ஓகே, மைக் ஓகேயா? ஓகே, லைவ் இல்லையா? நான் பேசுறது கேட்குமா? ஆனா கடவுளே. Okay, this station is for erector spinae block. Additionally, we will see the midpoint of transverse process to the pleura block and retrolaminar block. In addition, we will see also, if possible, the paravertebral block. Okay, so first to scan this, you should use a linear probe with the depth of 5 centimeters, concentrating on the 3rd centimeter. So for that, what you will do is you will increase the gain at the 3rd centimeter nicely, and the patient lying prone, the marker is always towards the head. So whatever is there in the marker side will be all cranial anatomical structures. I am placing it over approximately T5 to T6 in the midline. In the midline, you will not see anything. There's nothing seen there in the midline. As I slowly roll my transducer laterally, you will see that the transverse process rise above. So they are all box-shaped structures, and below, anteriorly to this, whatever is down is anterior. So anteriorly to this, you have ribs, but that will not be seen because of the transverse process shadows. Now what you have to do is, you will have to look for a ligament that connects all the transverse process, that is the intertransverse ligament. So I am scanning it medially and laterally to get the best view of the line there. See, can you see the line there? There is a line there which connects all the transverse process. That is called the intertransverse ligament. So now my drug injection should be in between the intertransverse ligament and the erector spinae muscle. That's a small space, hypoechoic space you can see there. So that is the plane of division of erector spinae plane. So you can either give it craniocaudally or caudal cranially, whatever direction you want you can give. You have to see to that the drug spreads well in the superior inferior direction. So this is one mode of spread which is useful for spine surgeries. Wherever you give from cervix to the sacrum, wherever you give, you will get a craniocaudal spread and a layer of analgesia from midline to approximately 8 centimeters along the midline. There will be good analgesia. So that is how you give a dorsal ramus block with the erector spinae drug injection. Now see, you have to look, see this is the intertransverse ligament. Now if I just move here and there, you will be able to see a small ligament connecting the transverse process and the rib below. This is the rib below it. So that is a slanting one. This is the superior costotransverse ligament. So that separates the intertransverse space and the paravertebral space. So if you breach the intertransverse ligament and deposit the drug in between the intertransverse ligament and the superior costotransverse ligament, that's called the MTP or midpoint of transverse process to the pleura block. This doesn't go anterior, superior inferiorly. What happens is this drug will permeate the space, go down and push into the paravertebral space. So MTP is actually a correct proxy paravertebral block. In case I breach the superior costotransverse ligament, the needle is directly into the paravertebral space. So these three injections can be given depending upon how confident you are. So if you want to give, if you are a beginner, stop the needle here, give the drug there, you will get an ASB block. If you are a little bit more confident of your needle tip, go here, breach the intertransverse ligament, you will get the MTP block. If you breach the superior costotransverse ligament, you will get a paravertebral block. All this is in the parasagittal plane. Now we will see the transverse plane. So you hold the transducer like this, the marker towards you, so that whatever is in the marker side is all towards you. So this is the spinous process. If you see a spinous process like this, your transverse process of that spine is one level above it, because this is the vertebra, this is the spinous process. The transverse process will be like this in the thoracic area. So you will have to just move your transducer a centimeter above and lie slightly laterally. Can you see the transverse process there? By the time your spinous process will go, the transverse process will come into view. Now if you bring the needle here and put the drug in this lamina, that's called retrolaminar block. Retrolaminar block will spread the drug near this area. It will pull the drug not superior inferiorly, but just on that area, but it will allow the drug to pass through the costotransverse split into paravertebral space. So that is one way of blocking the paravertebral. That's also proxy paravertebral. So the proper erector spinae block you can give in the tip of the transverse process. So what you'll have to do is, this is the periosteum proper. If you just give over the transverse process, that might not spread well. So you will have to just move it little bit up and down to see the epimysium of the erector spinae muscle. See, can you see there's a small one more line above it? Can you see this? See, if I am just above the transverse process, there's only white shadow. That is the periosteum. If I just move it slightly above it, you will see another, see there is another small line which is coming there. There's a small black space there, no? That is the space between the muscle and the intertransverse ligament. So that is the place where you will have to bring the needle from lateral and give the drug for erector spinae muscle block. This also will block the erector spinae, but if you give in this direction, the block spread will be over that area only. It will not spread cephalocaudally nicely. So now if you move little bit laterally, you will be able to appreciate the pleura. This is the pleura, and you will have to look for another membrane just above it connecting the transverse process and the internal intercostal muscle. Can you see a small line there? That is the internal intercostal membrane. Can you see that white line there? If you breach this line, you can push the drug into the paravertebral space like that. So these are the 4 things which you have seen today. For lumbar erector spinae, what you will do is, it's very difficult to scan. From the midline, you just push the probe laterally. You will see the periosteum of all the lateral process, transverse processes nicely. So now we have to bring the needle from there and deposit the drug over the transverse process. It will easily spread. But the difference between thoracic ESB and lumbar ESB is that the anterior spread is not there. See, if I give in thoracic space, the drug spreads superior inferiorly. It spreads laterally into the intercostal compartment. It spreads anterior into the paravertebral compartment. The thoracolumbar fascia in the lumbar area is so thick that it will limit the drug only in the posterior. So dorsal ramus only will be blocked, and it's only that you can do a spine surgery in the lumbar area and nothing else with the lumbar erector spinae block. So that is the only use there. So is it clear? You can start scanning. பண்ணக்கூடாது மேம். ESB is always above the intertransverse, below the epimysium of erector spinae muscle, and MTP block is below the intertransverse but above the superior costal transverse. If you breach the superior costal transverse, it is always the paravertebral space. Best is paravertebral. There is no other MTP and retrolaminar. MTP is better than retrolaminar because what happens is you are seeing the drug into the space between the two lamina, and there's, you know that's a medial split in the costal transverse ligament, so definitely drug will go into the paravertebral space. In the interlaminar space, if you give, it is that you just see the drug which is posterior to the bone. You won't know whether it goes down or not. So it is dependent on flowing through the costal transverse slit. So that may occur or may not occur, but it does occur. It does occur, but it's not very sure. But your MTP block is better than.
Sir, but in MTP, if we deposit the drug, how much time it will take to action? It has
Hardly
to
10 minutes. See, if you see what when you do a cardiac surgery, we give a ESB block and put the child in supine. When the surgeon starts after 20 minutes, the block wouldn't have taken up at all. The child will have tachycardia, we'll see it and we'll give additional fentanyl. But when we extubate the child after 3 hours on table, the child is comfortable. It means that it has taken some longer time than 30 to 45 minutes for the ESB block to come down to paravertebral space. There are few differences, like if you put the patient prone and do a ESB, it acts only on the dorsal ramus. The spread to laterally or into the anterior into the paravertebral space is negligible. But if you put the patient supine, the drug is forced to go into the paravertebral space. And if the patient is in spontaneous breathing, the negative intrapleural pressure will pull the drug from the ESB plane into the paravertebral plane. If the patient is on control ventilation, that might not occur. And when you do a longitudinal way, the drug will be more in the superior inferior column. But if you do it in the transverse way, it will go more into the retrolaminar and the paravertebral spaces. That is how it spreads. So it's more variable. That is why when you do an ESB, you should make sure that you move the probe here and there and see that your target spinal nerve is blocked. Mostly single point injections, sir, because 20 ml, 15 to 20 ml can block 5 spaces in the thorax, and 20 ml can block only 2 to 3 spaces in the lumbar. So if it is lumbar, it might need 2, but if in the thorax, 1 injection is more than enough. It depends on the drug, sir. If it is ropivacaine, for 3 to 4, because it's a facial plane block, the vascularity is low. So 5 hours you will get comfortable, but if you add additive, it is for 24 hours. Usually we give dexmedetomidine in planes. We have a rule that whenever it is in the neuraxis, like in epidural, we give a long-acting opioid. Opioid in other places might not be very useful because opioid traverses into the CSF and produces a better effect. Whenever it's on the nerve, we use dexamethasone. When it's a facial plane block, we use dexmedetomidine because the hypotensive effects of dexmedetomidine is very less if it is inside a plane which doesn't contain more vascularity. So I always use dexmed in the facial plane blocks.
Hypotension paravertebral compared to epidural.
It is the same. But the only thing is it is unilateral. Your paravertebral is only half epidural, so it is comparatively less. But if you put bilateral paravertebral, it is almost equal to an epidural. ESB, what happens is, if you see, suppose 6 segments of spinal nerves are blocked in ESB, when you see that clearly, only 3 to 4 segments would have been blocked in the paravertebral space, because the drug wound would have traversed all the segments. But if you give a paravertebral, it's in the 6 segments, it blocks 6 segments. So comparatively, ESB produces less hypotension, no hypotension at all.
MTP, sir?
MTP is as same as paravertebral.
You will get hypotension also.
Yeah, you will get. By the time you finish giving your drug, you will see that pleura has gone down. So see, suppose you are doing a breast surgery which is anterior, and you want a sure shot block, and you are afraid of a paravertebral, MTP is good. We are actually conducting a study now in Madurai Medical College comparing MTP and paravertebral, because see, in a breast surgery you won't open the thorax. In case there is a pneumothorax, that it's a morbidity for the patient. So it is better to put the drug in the MTP plane than in a paravertebral plane. That is where it helps. Any doubts? You can do it for yourself and see.
So breast surgery
T3, T4. For breast surgery it is T3, T4. For cardiac surgery it is T5, T6. It should cover T2 to T7 for cardiac surgery or thoracotomies. For surgeries involving upper abdomen like cholecystectomy, it should be from T6 to T8. T6 to T8. So ESB. So we aim at T7. See to that it goes up to T9. So that is more, T10 or it's more than enough. For lower ones you have to go to the lumbar space and give. From T12 to L2 you should give. It's like that. Back. This is nice plane. Can you see this? It's like a tray. Yeah, intertarsal ligament and the epimysium of erector spinae muscle. It's going like that. You can see the costal ligament also there. See, that's a ligament there. It's a slanting one.
MTP point.
Yeah, this is MTP point. Here, in all the planes you will be able to see the pleura nicely, but only in one plane you will be able to see the internal intercostal membrane. So you have to search for that. If you want to do a good paravertebral, search for the intercostal membrane there. Yeah, I think you got it. This is the membrane. You have to adjust so that you get it fully till the transverse process. This is the transverse process here. You have to get it there. Bring the needle up to here and give, because if you put it here, it becomes an intrapleural block.
The internal intercostal continues as a superior costal transverse.
Yeah, medially it is the superior costal transverse ligament. Laterally it will be the internal intercostal muscle. No, that's a membrane. That's very nicely seen. Yeah.
This one continues medially as a
It as superior costal transverse, but it is not seen here because of the bone complex. You can't see it. Actually, slightly you might be see she's able to see it, get it here, but it should not be seen ideally.
Even for here, if you give it to paravertebral,
It will go down like the paravertebral. It's paravertebral given laterally. That's all.
Okay, now we'll start. Quadratus lumborum block can be done with curvilinear probe also or linear probe also. Since this our patient is not very obese, not very muscular, we can choose either probe. But this patient I am choosing curvilinear probe. One of the advantage of using curvilinear probe, we can see the wider area of structures, including spine, deeper structure like aorta, everything, so that we can correlate and we can see the all paraspinal muscle, erector spine, everything very clearly. So I will start the scanning from midline after application of a good amount of jelly. Now the marker is towards me. Okay, marker is towards me. I am keeping the probe near the umbilicus and trying to reduce the depth. So this muscle is rectus abdominis. Here I am trying to move the probe towards spine so that we can see the all three layers of anterior abdominal wall. Can see once we come more lateral, you have to see you have to follow the tap plane and try to see the tapering end of aponeurosis. This tap plane become aponeurotic, that is between transverse abdominis and internal oblique. This aponeurosis you have to trace jelly, take some jelly. So tracing from rectus, then finding out all three abdominal wall layers, moving peritoneum. Once you come towards the spine, we are seeing the tapering end of aponeurosis, that is fascia transversalis, that goes and covers the QL, quadratus lumborum muscle. Once we keep the probe here, we can increase the depth and try to stabilize the probe in particular angle so that we can see the yes. So now I am freezing the image. So marker is towards me here, that is towards the back. So this is transverse process, this is vertebral body L4 level, and this entire back muscle is erector spinae. You see the tip of the transverse process which connects to the quadratus lumborum muscle, where the tapering end of transversalis fascia is coming and covering. So then if you see here some hyperechoic elements which are lumbar nerve roots, that is the content of psoas muscle. So if you consider this is a stem, 3 leaves, one leaf QL, other leaf erector spinae, this leaf psoas major. Now where to give injection? So if you give in the tapering end, almost lateral end of the quadratus lumborum, this is lateral QL. If you give even more, this is a posterior aspect. If you come and give here, this is posterior QL. Suppose this is where the lumbar nerve roots coming and passes in between the QL and psoas major. So in this plane, if you come and give the injection here, anterior, this is anterior. So there are some other important points, like if you keep the probe like this and increase the depth. This is left side, probably you see IVC and aorta here. Here, and after giving injection, we can confirm the cephalocaudal cranial spread of local anesthetic in this direction. This is subcostal view. Suppose if you keep the wedge here in the kidney, something called kidney bridge, if you keep here, then the area becomes wider. The area is between the here iliac crest, here costal margin. So if you keep the probe like this, again we have to see cranial structure and the caudal structure. Cranial structure, this is kidney. So the kidney and perinephric fat, everything is here. This is perinephric fat. So then if you come here, this is a bulkier, darker muscle, that is psoas major. If you move the probe towards this side, towards the foot end of the patient, then you see iliac crest. So here, if you reduce the depth, you see the entire bulk of the muscle is psoas major. Just covering the psoas major, one dark line is there, that is thoracolumbar fascia. So above that, this is QL muscle. All this here, it has lot of muscle layers are there. Here one is QL, another one is erector spinae, and then part of latissimus dorsi also. So either out of plane you have to come and give the drug just above the psoas major, or you can give the Samraxine technique local anesthetic injection. Then you can see the craniocaudal spread here. Drug spread you can see. Okay. Lift almost like a posterior tap, sir. So tap mari. So why the lift? Something like this. Okay. So please. This is a quadratus lumborum muscle. There are three ways of identifying. One is we have to follow the tapering end and covering. Next one is we have to follow the tip of the transverse process, then relatively hypoechoic muscle. Suppose if you give drug here, all the conglomeration of fascia. This is called thoracolumbar fascia. This is the tapering end is called transversalis fascia. Transversalis fascia becomes thoracolumbar fascia once it covers quadratus lumborum. Suppose this area if you give, they say there is a gap between the all something like a, you are seeing this, see lot of muscle layers are there here. You are creating one gap, no? Some gap. So this is something like it forms like a one lift leg area, which is covering from one level to one lumbar level to other lumbar, and it is extending up to thoracic level. So what we are talking here is thoracolumbar fascia becomes endothoracic fascia. So why QL is better than TAP? Means you are giving TAP, you are giving one level injection, it is maximum crossing 3-4 level only, spreading, somewhat even no drug spread. But here lumbar we are giving L1 level or L2 level or L3 level. If you are giving, the drug is going even up to thoracic. So because of the thoracolumbar fascia, they say because of this gap, the drug is getting spread to. One is that reason. Another reason they are telling, it is going into the thoracic paravertebral area and going into cranial and caudal level, and then giving the drug effect. Okay. Lumbar plexus. So these are all the lumbar elements. If you see here, these are all the lumbar elements which is emerging from lumbar nerve roots are emerging from vertebral canal. No, anterior QL, we are blocking some of the branch which is coming out here, this level only. entire lumbar plexus will not get blocked. But if you go on, you see this layer is not very clear now. See, any layer you are giving, you have to make the layer very clear. See, this layer is really clear now. See, because of the particular angle. Anisotropy. If you keep one more one particular angle, there also it will become very clear, almost continuous at least. That is the level you have to give. At least something continuous, no? Relatively continuous. Why we have to make it continuous? Unless this line is very clear, there is a high chance of giving the drug inside the QL muscle. Then the drug spread will not happen, both paravertebral spread also, even other that thoracolumbar fascia spread also will not be good. Drug has to slowly come out of the muscle, then go into the fascia and spread. Even if you put the drug inside the psoas, then it will become a pure lumbar plexus. It is not very easy, but as much as possible we can try not to inject into the QL muscle and not to inject inside the psoas. That's what one of the literature say. You can stimulate. You bring the needle here and try to stimulate direct muscle twitch. If you keep imagine 1.5 milliampere current you are keeping a needle tip here, directly you will get muscle twitch of QL. And if you go inside here, the psoas muscle twitch, direct muscle twitch you will get. Then if you keep the muscle, needle tip here in between, then you will be giving exactly in the anterior QL. But anterior QL only we should try for orthopedic indications. Otherwise it is not necessary. Or once we become more proficient in these two QL. Lateral QL is here, the tapering end. Posterior QL here. Only thing is that sometimes we will get confused between peritoneal fat. Many times if you are not identifying the, see, imagine if I am keeping the probe like this, many people think the QL starts from here. See, this is a moving peritoneum. The proper muscle starts from here only. We might be injecting drug here. Then it will become something like a fascia transversalis block. It will not be a QL block. So we have to make the muscle very clear. Now its muscle is more clear. Yeah. Then this layer sometimes, see, for him this layer is small. Sometimes it will be very big also. Some patients this might be very big also, almost equal to this size. Then we might be thinking this is also QL muscle and giving drug here. Then we will not be getting good success. The drug spread will not be good. So preferably you have to, if this area always confusing area, either you have to give here or here. If you are become once expert, you give here and don't mobilize the patient, because if you are giving here, then chance of lumbar nerve roots are getting affected, and chance of falling is there. Okay, one of you can. So you have to start from center of the abdomen, near umbilicus, yes, below the yeah, something like that, yeah, yes. So give some pressure, madam. This is rectus abdominis. Come, move the probe towards back. Okay. 3 layers, moving peritoneum. Yes. So next important step is the moment you come lateral, you have to follow the tapering end of transversalis fascia. This is the tapering end, the white line. Okay. Then it comes and covers the QL. So here if you comes, you have to keep the probe horizontally like this and stabilize the probe like this. Okay. Now you are able to see the transverse process and 3 muscles you are seeing. So you increase the depth. Okay. This is towards your back marker. So this is marker towards the back. Big muscle is erector spinae. Towards the tip of the this is quadratus lumborum. This muscle, if you move the probe little towards here, this is psoas major. So this is three layers. Yes. Now you have to follow the tapering end. Once you see the tapering end, keep the probe like this, good contact, use some pressure, madam. Okay. So rectus, abdominal wall muscles. Tapering end. Once we see that, you have to give some pressure. Pressure good. Yes. Okay. So this is a transverse process. Vertebral body. This is erector spinae. This is psoas. Rectus. Three layers of abdominal wall muscle. Keep in contact like this. Tapering end. Give some pressure, madam. Give pressure. Okay. Give some pressure. And some tilt. Yes. Give some pressure. This is the tip of transverse process. 3 muscles you are seeing. This is the tip of the transverse. This is like this. இல்லை நீங்கள் இங்கே பாருங்களேன், இங்கே வச்சு இங்கேயே பார்க்க வேண்டாம், இங்கே மட்டும் பார்த்துட்டு ப்ராபபிள் வைங்க, வச்சுட்டு திரும்ப. ஓகேவா? நல்லா ப்ரெஷர் கொடுங்க, ஃப்ரீஸ் பண்ணிவிடுங்க, ஃப்ரீஸ். ஆமாம். இல்லை இல்லைங்க, டுவர்ட்ஸ் த பேக் தான் போஸ்டீரியருங்க. டுவர்ட்ஸ் இங்கே தான் வரும், பேக் தானே இது, இதை போஸ்டீரியர். இங்கே கொடுத்த ஆமாம், இங்கே கொடுத்த லேட்ரல், இங்கே கொடுத்த ஆன்டீரியர். This is a rectus. Come here. Yes. This is rectus. abdominal wall layers, 3 muscles. Always you have to maintain the contact like this. You see here some tapering end is coming. Okay. There you have to keep the probe like this. Okay. Now this is the tip of the transverse process. Towards the tip, this is quadriceps muscle. This is back. So erector spinae. This is psoas major. Thank you. Thank you. Thank you. Thank you, madam. எடுத்துடலாங்க.